Yes, sir.
Why did you ask for history of trauma?
To rule out traumatic fat necrosis.
Think that is also possible.
Yes, sir.
So in this list, when you're starting off, we change our viewpoint a little later. What is more likely, a malignancy or a non-malignancy?
Based on duration of a presenting illness, we can think of benign conditions also. Malignancy.
But Naresh, when you told the history, don't keep on repeating no history of no history of no history. You're eating into your own examination time. Number one. Number two, regarding trauma to the breast, what type of trauma is common to produce fat necrosis to confuse with CA breast? Not the trivial trauma to the breast, the high impact trauma,
Yes.
which you get when you're wearing a seat belt and going at breast. Okay. So that particular trauma has to be asked. Otherwise, it's just any trivial trauma anybody will get into. Okay.
Yes.
Okay. So we have possibilities now, isn't it? So it could be malignancy. It could be a. Why did you ask for history of reproductive and menstrual history? What is the importance?
Reproductive menstrual history.
Menstrual history.
Sir,
We can go to that slide.
yes. Because for etiologies, to rule out etiologies, early menarche and late menopause can be a risk factor for developing of carcinoma of breast.
Etiology.
Risk factors. Risk factors.
So how is that a risk factor?
Early menarche can affect it can lead to a development of CA breast because of increased exposure of unexposed estrogen for longer durations.
So this is you're using it as an evidence that the breast may be exposed to estrogen longer duration.
Yes.
What else? But is that menopause early?
No, sir.
Okay. What other factors will influence exposure to estrogen?
History of breastfeeding, sir, for the child.
Number of pregnancies, no?
Nulliparity can cause.
Number of pregnancies also will change the exposure of the breast to estrogen. Yes. Is it important if these pregnancies are full term or doesn't matter? A pregnancy is a pregnancy. What is it? I mean, in terms of evidence,
yes.
Any pregnancy counts or a full-term pregnancy counts? So full-term pregnancy is definitely more protective in terms of reducing the exposure to estrogen than non-full-term ones. Okay.
Where are these things used? You said, no, early menarche is the risk factor, late menopause.
Yes.
So do you think they add to the diagnosis for this patient? Somebody with early menarche and breast lump, you think of breast cancer. Is it like that? Are you getting my question?
Yes. It can be an added factor to think of.
So they are actually used for risk prediction models.
Okay.
These numbers are more important for somebody who doesn't have a breast cancer.
Okay.
Models like GAIL, where you feed them and see what is their actual risk. The patient with breast cancer, these things may not be very relevant. They're good questions to know, but they won't add to the diagnosis per se. Can you go back to your previous slide? The third past history. What do you mean by radiation exposure to breast? The third slide, I saw something like radiation. Next slide.
No history of radiation.
What do we mean by that? Radiation exposure to breast means what?
Either patient would have undergone a previous history of surgeries, any like.
No, why is this important? Why you ask this question? Like, what information we want and what clinical decision we will take based on this information. So where people get chest wall radiation, where they get which condition?
Just
one common thing can be previous breast carcinoma.
Yes,
that is also a possibility. We cannot say that it is not there. That is one thing. What are the other common thing? What medical condition people receive radiation? Which are the tumor? The radiation.
Lymph
Childhood
nodes.
irradiations, lymphoma, childhood irradiations,
For lymphomas.
lymphomas.
Because that puts them at a higher risk. There's a
Risk of-
separate screening program also. I mean, they're supposed to do MRI-based screening. They've received radiation for a lymphoma. And suppose she has received radiation for breast. What you are interested in? So,
It's an contraindication for BCS.
Yeah.
maybe yes. But it's more important to know how many years back it happened.
Yes.
Because there is a concept of re-irradiation also, but as a rule, what you said is correct. It's not advisable, but you should know more in detail about what were the other things. Anything else you will ask in the past history? What is the importance of past history of breast biopsies?
Yes.
What is the importance of
So, if the patient has taken any biopsies prior, it may even look like an involvement of skin involvement. It may look like the scar.
not that? Suppose somebody had a previous benign thing, which is biopsy.
Okay.
Are you aware of any lesions which are sort of pre-malignant things in breast?
Yes.
Any pre-malignant lesion, I'm asking. Terms like ductal hyperplasia.
Yes, sir.
Lobular carcinoma in situ and Paget's disease.
Paget's disease is a malignancy actually. So lobular is, yeah, that is something
Considered
diagnosed on only biopsy actually. So that is a possibility, sir. She might have gone for some breast complaint, mammogram might have showed something. Biopsy would have picked up a LCAS. A biopsy would have picked up ADH, I mean atypical ductal hyperplasia. So all those things are pre-malignant things which can occur. So that can again give you some clue to the diagnosis. Coming to the family history,
Yes.
so why did you ask you put okay, PRC related breast is missing in that. You put pancreas, everything there.
Breast.
We assume that it is breast. Okay. Okay. Suppose somebody has family history. So what will
Yes.
you ask for?
The age of a diagnosis of the patient of families.
Before that, you have to have some order.
Degree of relative and generation. First degree relative or second degree relative. Vertically or horizontally, it's a generation.
Generation.
Okay, so which relative it is, whether it is a mother, sister, who had, and what age they develop, why what age?
Because screening has to start before the diagnosis of the patients. The patient who developed a carcinoma in the family, before that age, this patient has to start the screening mammography
So
for
suppose
this.
that mother has developed breast cancer at 75.
Yes.
What are the significance of it? Versus her mother has developed
दूसरा कॉलेज का भी आया है सर
75 years, if a patient is developing breast carcinoma, more commonly it can
नहीं
be to be
वो भी तो छोटा है
cause.
You understand? Somebody at
Yes.
25, 80 developing a breast cancer may or may not be significant.
Yes.
But if there are 3 aunts at 75 developing breast cancer, then it may become.
बाहर से भी आया है
Whereas 1%
मतलब
developing
तमिलनाडु के
also
बाद
is a concern.
Concern.
That will trigger some further genetic evaluation. That's
Yes.
the
What are her daughters? She's 65.
Yes, sir.
How old are the daughters?
23 and 26.
You can always ask slightly older patients, please ask for history of CA in the daughter also, if they have that bigger daughter. Otherwise, you tend to think only backwards. You know, enough times patients come, the daughters got diagnosed, patients go for mammogram after that and they get sick. So please do ask.
Yes.
You said what is the degree of relationship, first degree, second degree? That is one. Age at onset. Anything else which is important on family history? Number of relatives who have breast cancer.
नहीं वो इंडक्शन
More than
ऑर्डर
one.
किया था
Then you know
पर
you are going to be
यहाँ
a isn't it?
क्या बोलते हैं
More
नहीं
than
आया तो मैसेज
one
आया था
person having breast cancer, it
डिले हो रहा है
indicates
बोल
more
के
towards a genetic clustering. Anything else?
पता नहीं कुछ डिले हो रहा था तो आपको स्टिल चाहिए कि क्या बोलते हैं तो
Was
पापा
there
बोला कि
relative, more number of
मुझे बन नहीं
relatives?
रहा है
Anything else? Bilateral.
Bilateral.
Isn't it? Bilaterality of breast cancer also is a strong indicator.
General examination. She was examined in a well-lit room after taking verbal consent in the presence of a female attender. She is conscious, oriented, and afebrile, moderately built and nourished. Carnopsy score of 90. Body mass index of 21. Pulse rate is 80 per minute, regular, good volume, and character. Measured in right radial artery. Blood pressure 130 by 80 millimeters of mercury, measured in right arm in sitting position, and respiratory rate is 16 per minute. There is no pallor, icterus, cyanosis, clubbing, pedilema, or generalized lymphadenopathy. Examination of breast. Coming on to inspection. First position, sitting with arms by the side. Both his breasts appear asymmetrical in shape and size. Nipple position, right sided nipple is slightly in upper position when compared to that of the left side, and it is slightly retracted in. No nipple discharge is seen. Fullness noted in the right upper outer quadrant from 9 to 11 o'clock position with an overlying skin hyperpigmentation. Skin over the breast, color change is present over the lump. Dimpling and or puckering is present. Purely orange appearance is seen. There is no visible dilated veins or supraclavicular fullness. There is no evidence of any ipsilateral upper limb edema. Nipple areolar complex, brown color with no cracks or fissures. Sitting and raising arms above the head. Both the breasts rise equally on raising the arm above the head. Lump becomes more prominent with the puckering of skin over it, and lump moves with the breast tissue and raising the arm above the head. Inframammary area looks normal and no visible swelling is seen in the axillary. Sitting and leaning forward, both the breasts fall forward equally. Lump forms forward with the breast tissue. Palpation. Left breast soft with no lump palpable and no axillary lymph nodes palpable. Right breast, compared with the left side, there is no warmth or tenderness. A firm to hard, well-defined lump with irregular surface of size approximately 8 cross 5 cm, occupying the upper outer and lower outer quadrants. Skin over the lump is not pinchable. Lump moves along with the breast tissue when arms are relaxed. With arm pressed against the hip, lump is still mobile along the direction of the muscle fibers. A single anterior and central group of lymph node, each in a single group, is palpable, which is hard in consistency and mobile. There is no induced nipple discharge, no edema of the arm, no supraclavicular lymph node palpable. On examination of spine, there is no tenderness, no deformities or no paraspinal tenderness. Examination of cranium and pelvis is normal. Systemic examination, soft, no organomegaly, no mass palpable. Parietal examination, there is no pelvic deposit. For vaginal examination, no pelvic mass felt over the fornices. Fornices were found to be free. Respiratory system, bilateral air entry equal with no added sounds. Central nervous system, no focal neurological deficit. And cardiovascular system, S1 is clear with no murmurs. Summary, 65-year-old postmenopausal lady with an 8 cross 5 cm hard lump in the upper and the lower outer quadrant of 2 years duration in the right breast with the skin involvement with the purely orange appearance, dimpling or puckering, with no muscle fixity, with axillary lymphadenopathy.
You're looking for color change, lump, puckering, dimpling, edema. What about the nipple area? What do you look for in the nipple area complex?
Nipple is retracted, area level slightly hyperpigmented.
If the lesion is not there, if there's no lesion visible, but there's a change in the direction of the nipple, does that give you any clue?
Ductic tissue.
The nipple can be pulled towards the lesion. Why does that happen?
Because of the ductal involvement, the duct gets fibrous and pulls inside.
Okay. Right. Again, when there's no clear lump visible like this, ductal, you talked about discharge. What kind of a discharge is important?
In case of carcinoma, bloody discharge is important.
Bloody, what? It's not enough to say bloody.
Serous times.
Anything else that you're worried about when you talk about discharge? Is it from a single duct
or from multiple duct?
That's important. Because multiple ducts not very common for the malignancy. Can you go to the next slide? We're running short of time. Quickly run through this. It's good that you mentioned that the intramammary area looks normal when you raise the arms. And how did you, on inspection, can you make out what is the plane of this swelling? Is it possible for you to mention? Any clue that you get on inspection?
On falling forward,
Okay.
the breast mass falls forward, sir.
Okay.
So it is not fixed to the muscle layer, so it might be in the chest.
Very lax muscle, it's difficult to say. What are like, is it possible for the lump to be fixed to? It could be within the breast fat, or it could be fixed to the
Chest wall.
muscle. Can it also be fixed to something in between these two?
Fascia.
Fascia.
Okay, it could be fixed to the fascia without involving the muscle.
How will you proceed further? What's your clinical stage, you said? So,
Yes. Clinically, it's T4B, N1, and MX. It's going to be locally advanced breast cancer.
okay, what do you mean by MX?
As a metastasis is not ruled out till only in a triple assessments. We have done only clinical examinations. Further, radiological and after
So
pathology.
where you use the term X in staging?
If a metastasis is not assessed,
In TNM staging, where is this term X used? Say TX you use, NX you use, where it is used?
And it's not assessed.
It's not assessed, it's not accessible. Okay, so when somebody has already done a lumpectomy, you don't know the tumor size, then you put it TX. When somebody has done the axilla, you don't know anything about the axilla, then you put NX. There is no staging called MX because it is always accessible. You can always do a scan to rule out this CM0, that is the stage. You are not assessed. It's a very common mistake people do. There is no staging called MX.
Did you mention about the opposite axilla? You told about the breast. Opposite axilla, opposite supraclavicular, you mentioned.
yes.
Okay.
Not about supraclavicular fossa, but axilla.
You proceed further.
क्या बोलता है तेरे को यहाँ रुकना है तो ये बेड में रहना है तो हम लोग वहाँ चल जाएंगे
Following a clinical examination, we like to do next is radiological investigations. Initially, we'll as the age is more than 60, is at 65 years, we like to do a mammogram of the breast, both breast, which is a diagnostic for right, and screening for left breast. Following which, we'll like to do a true cut biopsy of the lump.
Why you want mammogram of the right breast? The involved breast, why we need a mammogram in this patient?
Yes. To support our diagnosis and to
No, suppose the radiologist says it is benign, like
yes.
what are we going to do? Let's say, for argument's sake, I'm saying they say it's some BIRADS 2, BIRADS 3, nothing to do. What are you going to do?
We'll proceed with
No,
biopsies.
are there any problems in doing mammogram with this patient? That's why I'm asking this question.
It's
In general, why you do, like what information you want in the mammogram?
in doubtful cases, we have to do a mammogram to look for how the lump is and its
Then only in
margins.
doubtful cases are all patients with breast cancer.
Not all patients, sir. In doubtful patients, to rule out benign and malignant.
Mammogram is done in all suspected patients.
Yes,
Whenever there is a diagnostic evaluation, it's an essential component. But in this particular patient, it's a T4B lesion. It's already
Yes.
ulcerated. Doing a mammogram for her will be very painful, and it won't give you any additional information. Suppose if it is T3, then it makes sense. Whether you are planning BCS later, you want to look at other lesion, you want to look at microcal, all that. So here, irrespective of whatever information your mammogram gives, her likely treatment is going to be a mastectomy later. And this have you seen a mammogram being done? How it is done? Like
Yes.
how it is done?
It is usually done in two planes. One is craniocaudal view and mediolateral oblique view is done, sir. And another is compression view is also done.
No, no. In a conventional mammogram, what is done to the breast? How the breast is positioned? Like
The breast is compressed between the two plates and it is
what I
taken.
mean. The compression is very bad for such a large
Large.
ulcerated tumors. In a large ulcerated tumor, it is acceptable not to do a mammogram because it will only increase to lead to patient discomfort and it won't help. Okay, suppose this is much lesser. What information do you want? Already I said some examples like you want to see the microcalcification.
Yes, sir.
You want to see any other
Any other
lesions which are
lesion?
not clinically palpable.
Yes.
Like
But
that, what
like
else you want?
if any non-palpable lumps in case of multicentric diseases, we can look for.
Fine. Why you want mammogram of the opposite breast?
Patient is develop. It can be a screening, sir. The patient can develop opposite breast also.
What is the chance that she will have something in the opposite?
1% is chance.
Less than 1%, but it's done. Okay.
Yes.
So will you do an ultrasound for this patient?
No, sir.
Sorry.
No,
For
sir.
nodal status,
To look for axillary.
Yeah, to look for the nodes, mammogram will not give you adequate information.
Yes.
Ultrasound is the most sensitive
Sensitive.
investigation process.
nodal status.
Axillary nodes.
Nodes.
So she needs an ultrasound also.
Ax
So why we have mentioned as image guided biopsy?
For
to
nodes,
false positive.
Image guided biopsy of what? Breast lump you have written.
Yes.
So can you do an unguided biopsy, or what was there in the imaging? Are you do we have the imaging findings? Do we have the mammogram findings?
No, sir.
We don't have. No, what in the mammogram will trigger a image guided biopsy? I'm asking.
If a lump is a very small lump is present.
Because here
Or
you
is-
said it is a 8 into 8 centimeter lump.
Yeah, yes.
So is it really needed to do an
No,
image
sir.
guided biopsy? No, what I was interested was it different in the
Needed.
mammogram? Was it more like a cystic lesion? That's why we wanted a guided biopsy. Is that the case?
No, sir.
Okay. So in a large palpable thing, it's okay to do unguided biopsy. But if your imaging has shown something else, then it's preferable to do a
Image.
guided biopsy. So what will you look for in the core biopsy? Like, so what will be the size of the gun? Like, so how many cores you take?
Yes.
6.
6 course we'll take, sir. And ideal, it should be 18 gauge, sir.
But smaller guns are, I mean, larger guns are preferred, no?
Yes, sir. 8 to 18 we'll prefer, sir. 16 gauge is preferred, sir.
Most people go with 14.
Hmm.
That's the common thing which is used actually. How many cores you will take?
6, sir.
4 to 6. So what's the good core?
Mm.
When you take a core biopsy,
Yes.
when you say that it's a good core, because you need 4 to 6 good cores.
Yes.
Good core will,
It should not.
when you put it in formalin, what will happen to that? It will sink.
It should
It will
sink.
sink, and it will be like a uniform cylinder. It should not be fragmented. So you need good core. So what will you request the pathologist to look for when you do the core biopsy?
To look for invasiveness.
Invasive or in situ carcinoma, we will do that, sir. And to look for a hormonal status of this biopsies.
What
Like
do we mean by, can you be more specific?
like estrogen receptor, progesterone receptors, and HER2 can be seen, sir,
K67.
with K67.
Okay. Suppose HER2, how will you assess HER2? Like, how does the pathologist report HER2 on IHC?
0 or 1 plus, 2 plus, and 3 plus, sir.
How we interpret those numbers?
0 or 1 plus is negative, sir. 3 plus is positive or proven, sir. 2 plus, we have to proceed with the fish, sir.
K67, how it is reported in general?
Low and high.
Okay, so what is low, what is high? Less than 14 is low, more than 14 is high.
High.
Some people simply report it as low. But why it is important?
To look for mitotic index, proliferation index.
That's right. But how does it help in treatment decisions?
It helps in differentiation between basal type and claudine low type.
It's used to, there is molecular subtyping of breast cancers, no? So luminal A, luminal,
Luminal
B.
B.
So luminal A is ERPR positive,
Between the
Return
K67
negative.
low, B is ERPR positive, and K67
High.
high. So it's more of a prognostic thing. Treatment may not change dramatically, but prognosis
Prognosis.
changes between luminal A and
Back to the confirmation. So you said mammogram, no? You can do ultrasound, or you can do X-ray mammogram, you can also do MRI mammogram. Yeah. So which is the better one of these?
Ultrasound mammogram.
How is it like one for all, or it varies depending on situation?
Except for high risk group people, it's a ultrasound mammogram. For high risk group people, we can go for MRI mammogram.
That is not how it is. No, so fatty breasts, X-ray mammogram shows lesions better.
Dense
Non-fatty or
breast.
denser
That is
breast,
MRI.
ultrasound may be glandular breast ultrasound may be more informative. But if you have, suppose you have MRI available in your hospital, will you do MRI for everyone? You have, there's no cost limit. Okay, MRI is available, and you have patients coming to you for evaluation. Would you rather, because that is going to pick up lesions most easily?
Yes.
Would you go for MRI for all patients?
No, sir.
Why?
MRI indication. There are indications for MRIs.
I know, but
Yes.
there's no limit on cost, right? Then why not do MRI for all? Because then what will happen is your number of negative breast biopsy will increase. You'll end up biopsying a number of breast patients without getting a better yield. Okay. So you would still stick to the same guidelines that you decide whether you have it or not. Go on.
See, you've lined up all these investigations. Why should you do a CT abdomen, pelvis, thorax, and then proceed again to a PET CT?
So in most of the hospitals, this skeletal survey and CCT abdomen, and in most hospitals, PET-CT will not be available. In that times, we can proceed with skeletal survey like bone scan, CCT abdomen and thorax, and ultrasound and MRI brain if needed.
Recommended metastatic workup for a locally advanced breast cancer. Madam asked, you listed a lot of things. So what is the recommended thing? Like, so
CCT,
availability is different. What is the recommended thing?
CCT thorax and abdomen, CT brain and bone scans.
Sorry?
CCT thorax and abdomen, CT brain and
Thorax, abdomen, and pelvis.
Pelvis.
CT brain and bone scans.
CT brain for what?
MRI.
Sorry, MRI brains.
Why
To look for
MRI brain?
secondaries.
MRI brain or CT brain is not a part of standard workup. It's a symptom triggered thing. Somebody has got no symptoms, you don't image the brain in a patient with breast cancer. Whereas you do a bone scan and a CCT. That's the standard metastatic workup. So then what is the role of PET scan? Where does
It will-
PET stand? Like?
To pick up occult primary in case of one positive axillary lymph node.
Here you have, I'm asking about a patient with locally advanced breast cancer. PET is also an option. Even PET is available, that is also an option. But what is the problem with doing PETs? In our setup, particularly, we pick up a lot of false positive lesions in the mediastinum. We get a lot of nodes in the mediastinum, which leads to more confusion if you do a routine PET actually. So PET is used more like a problem-solving tool. Like when you have some discordance between CT and bone scan, then you do a PET. Or sometimes CT showed some limited meds, then you want to be really sure that it is limited meds, because limited meds we treat with a different intent. So then you do a PET scan. But broadly speaking, PET scan is also an acceptable option. Bone scan with CT is also an acceptable option. Skeletal survey, I'm not sure. I don't think it is being done nowadays actually. Like so, there is no need to routinely image the brain in any patient. And ultrasound abdomen is also redundant since we are already doing a CT scan. So what was the metastatic workup of this patient? Do you have any information on that?
We had done a TrueCut biopsy which showed a well-differentiated tumors with ERPR positive and RTNU negative, which showed an invasive ductal carcinoma of not otherwise specified type. And these are the skeletal surveys. We took a skull X-ray and cervical spine and a lumbar and a hip X-rays and upper limb X-rays and pelvis we took. There is no evident findings in skeletal surveys. You see, this is a bone scan and a CCT chest we took, sir. When we come to management.
Only chest.
And abdomen pelvis also, the film is not available. So we have done abdomen pelvis. No metastasis scenes.
Proceed further.
As a size of the lesion is more than 5 centimeter, which is planned to do a neoadjuvant chemotherapy for the patients.
Neoadjuvant chemotherapy.
To downsize the
Operate list.
Size is more than 5 centimeters.
downstage the
Downstage the size.
Sorry.
To downsize the tumor.
Okay, and do what?
Why do you want to downsize?
Yes.
Downsize.
Yes. To make it operable, sir, because rather
What makes it inoperable now?
To plan the management between major BCS, or we can go for a modified MRM.
Is it inoperable? What do you understand by inoperability? Is it not possible to do a mastectomy for this patient?
Possible.
Possible. So why then we call inoperable like so? But what is not possible? If you do mastectomy, what you won't be able to do? You can remove the tumor, but what you won't be able to do?
closure will not
cover. No, you won't be able to close it.
cover. Closure of the wound will be
You'll
difficult.
be able to unnecessarily do a flap. You know? That's what neoadjuvant helps. No,
Yes.
if you do that, mastectomy with closure will be possible. So by inoperable, we mean that here. Truly inoperable is what in breast. What lesions are truly inoperable? That's where you cannot remove the tumor. It has to be fixed to the
Chest walls.
bulky nodes, fixed nodes. They are the truly inoperable ones. No? So even though the term inoperable is used here, it is more of a treatment philosophy where you want to give chemo to decrease the extent of surgery.
Naresh, you see the management, neoadjuvant, MRN, and then adjuvant chemotherapy. This adjuvant chemotherapy, I think, is actually a continuation of the neoadjuvant.
Yes.
Chemotherapy drugs will be more or less the same, but the objective will be different between neoadjuvant and adjuvant and palliation in metastasis. That objective you must know. The chemotherapy.
Of giving neoadjuvant chemotherapy, what are the proven benefits of giving neoadjuvant chemotherapy? One you already said, it makes inoperable tumors
to operable.
Then any other benefits?
Yes.
Downsize the tumor. Nodes size can be reduced, or nodes can become not palpable following neoadjuvant chemotherapy.
That a benefit.
So it will take care of micrometastasis if it is present, microcalcifications, which is not palpable or which is not radiographically not screened.
Both terms are different. Microcalcification is a radiological term. Micrometastasis is a pathological term. They both are completely different entities.
Yes.
So
to look microcalcifications.
The question is there a survival advantage? If you have two groups of patients, one group gets neoadjuvant chemotherapy, other does not get neoadjuvant chemotherapy. Is there survival advantage for the group getting neoadjuvant? Will they live longer?
No. No. No.
There is no obvious survival advantage between neoadjuvant and adjuvant chemotherapy, but there are some settings where it may be useful.
Like you want to do breast conservation surgery.
That is one of the obvious benefits. We can conserve the breast. Maybe not in this patient, maybe in a slightly different scenario. That is one of the proven benefits. When you have a HER2 positive disease or TNBC, then the response will guide you further treatment based on the residual disease. That is one of the proven benefit. The terms you said, no, it will take care of micromets, all that. They are all hypothesis, but it is not shown to be that actually. Like whether you give it neoadjuvant or adjuvant, it works the same.
This or that's
So after neoadjuvant chemotherapy, like so, Any idea what drugs are used in this particular patient? See, GRPR positive.
Yes.
What regimen is preferred?
Ideally, it's cyclophosphamide, hydramycin, and 5-fluorouracil is given, or cyclophosphamide, methotrexate, 5-fluorouracil. Currently, we are giving hydramycin and cyclophosphamide. 4 cycles of hydramycin and cyclophosphamide is given, followed by 4 cycles of taxanes is given.
The last one you said is the current regimen. No?
Yes.
AC or epirubicin followed by, epirubicin or
hydramycin,
cyclophosphamide.
followed by taxanes.
And the key here is they are dosage regimens. That is also shown to have survival benefit.
Yes.
At 2 weeks, you give 7 cycles. You can give both ways. You either gives like a sandwich, you give 3 cycles, operate, and then give the rest. But most people are moved to giving everything upfront. So that is also one way of treating it. After chemotherapy, surgery will you do?
Right, modified radical
What do
mastectomy.
you understand by that term?
Removal of
What
component.
do you mean by modified radical mastectomy? What is it that you're doing?
Yes, it's a removal of a complete breast tissue with nipple areola complex along with axillary tail of breast and axillary dissection with the preservation of angular vein, axillary vein, and the median lateral thoracic nerve and long thoracic nerves, and the thoracodorsal pedicle can be preserved.
So there are axillary levels, no? What levels do you say?
3 levels.
Level 1 and level 2 will dissect.
So is that modified radical mastectomy?
Plus level 3 is also dissected.
Technically means you do all 3
3
levels.
Yes.
But why do people omit level 3?
If level
When
2
you
is
do total mastectomy with level 1, level 2 dissection, why
Yes.
do we omit level 3?
If level 1 and
Level
level 2 are not involved,
most-
level 3 might not be done, sir.
Sorry?
If level 1, level 2 is not involved, level 3 need not be done, sir. Because
Why?
it might
Why?
trigger a lymphedema of the upper limbs.
No, no. That is not the reason why you don't do it. The incidence of skip metastasis to level 3, we thought involving 1 and 2 is very low. So what you would gain by doing level 3 is very less. The gain is less. There may be a gain, but the gain is very less. While the risks of lymphedema are much more higher. That is what you should say. Incidence of skip metastasis is very low. So when level 1 and 2 are negative, level 3 to be positive is very low, less than 5%, less than 3% actually. That's why you don't routinely talk about level 3 dissection. So that's okay. We'll close now. We've had enough discussion. Thank you very much.
Thank you.
Thank you, sir. Thank you.
Thank you, sirs and ma'am. I now request the examiners to award the certificate of presentation to Dr. Naresh.
Next other.
And Dr. Sivaguru.
Share screen போய் screen select பண்ணிட்டு share. அதுக்கப்புறம் நீ about பக்கம் டிஸ்பிளே கான்சன்ட்ரேஷன் இப்போ போடக்கூடாது ஜட்ஜு when they give the moment now you change it look on this make next
Dr. Anjali Raju. And Dr. Nandakishore Manoj. We thank the examiners for chairing the session and Dr. Naresh and Dr. Sivaguru for their presentation. Now we have an interesting panel discussion on strategies in the management of chronic pancreatitis, moderated by Dr. Sharma M.D., Additional Professor, JIPMER. I would also like to invite the panelists for the session, Dr. Vishnu Prasad M.R., Dr. Adi Narayanan S., Dr. Ram Kumar G., and Dr. Anuti Katruvella. I welcome you all, sirs, to the dais.
ಮಾರ್ಕರ್ ಇದೆ ಲೇಸರ್ ಮಾರ್ಕರ್ மார்க்கர் வேணும் அந்த ஸ்க்ரீன்ல பாயிண்டர் வேலை செய்ய மாட்டேங்குது இல்லை ஸ்லைட் ஷோவில் வந்துடுது கேமரா ஆன் பண்ணு கேமரா ஆன்ல தான் சார் இருக்கு சார் மார்க்கர் மார்க்கரா மார்க்கர் இருக்குது நீங்கள் ஐடி வியூன்னு சொன்னீங்கன்னா ஐடி அதை போட்டால் தான் அதெல்லாம் மார்க்கர்
Good morning to all. I welcome you all for this panel discussion session on chronic pancreatitis. Chronic pancreatitis, most common condition. Chronic pancreatitis is a condition which is less discussed in academics, but more commonly seen in practice. And it is a condition which is also less cared and neglected patients. And most of them are undertreated in the management of chronic pancreatitis. So this panel discussion is on strategizing the management in management of pancreatitis. So by definition, chronic pancreatitis has undergone lots of changes over time with advance in understanding of the pancreatitis. And in 2016, by International Association of Pancreatology and other associations came up with international consortium guidelines in defining chronic pancreatitis. They gave up a mechanistic definition saying it's a fibroinflammatory syndrome due to persistent inflammatory response to parenchymal injury or stress in a patient with a background of genetic susceptibility and exposed to environmental and other risk factors. So I have taken up this management of chronic pancreatitis and identified certain domains which need to be addressed when you see a patient with chronic pancreatitis and plan for the management. So for a comprehensive management of chronic pancreatitis, you need to address these 6 domains. So primarily these patients come with abdominal pain to the healthcare service, and we need to look into other components in the management of chronic pancreatitis like exocrine insufficiency, endocrine insufficiency, local complications in terms of presence of pseudocyst, biliary stricture, venous complications, and duodenal stenosis. And also subgroup of patients may present with the inflammatory head mass, and you should give due importance in evaluating this inflammatory head mass. And also this chronic pancreatitis pre-malignant condition and prone to develop malignancy over time. So they also have to be evaluated and screened for malignancy. So based on these domains, I have listed up determinants in the of strategies in management. The brain characteristics, pancreatic functional status, pancreatic morphological characteristics, local complications, nutritional evaluation, and risk assessment for malignancy. First, to the panelists, I put this first question. What does abdominal pain in chronic pancreatitis means? First, I go with Adinarayan sir. He is Dr. Adinarayan sir is an anesthesiologist here in JIPMER.
Thank you. First of all, thanks for this opportunity. Thanks to organizers for giving me this opportunity. Okay. Okay now? Yeah. Thanks for the opportunity. First of all, I'm happy to be here. Coming to the question, what does abdominal pain? Abdominal pain can be very vague and can be even misleading in a chronic pancreatitis patient. And first they come to us with pain, and then we look at what is the organ involved. So we do the clinical examination, the physical examination, history taking and all that. So there's a characteristic pain which goes to the back and they get relief. on leaning forward and all that. This doesn't happen in practically all patients. And sometimes the patients, especially in JIPMER patients, come to us in very late stage. And sometimes when we see their pain, the generators have gone beyond the pancreas to the upper surface of the stomach, the retroperitoneum, the duodenum. And in chronic alcoholics, we have even the liver also is more or less quite damaged. They present with so much of pancreas destruction and all that. So abdominal pain is a very vague thing unless it is very specific. Some very few cases present in a very classical way. Otherwise, we have to evaluate the patient, maybe go for imaging and then start some therapy and then see whether it responds to that. And then only we can progress and we can say it is typically a pancreatic pain and it has not spread. Very early cases, yes, we can be very classical presentation.
Okay, sir. What a medical gastroenterologist will look at the abdominal pain?
Hello. First of all, I'd like to thank organizers for this opportunity. Generally, initially, chronic pancreatitis starts as acute pancreatitis or directly as a chronic pancreatitis. So in chronic pancreatitis, generally it's the upper abdominal pain, radiation to the back, or some people can have continuous pain also. If there is any change in the pain characteristics, then you have to be careful because then there is a risk of malignancy in that time. The pain can be due to like central, or it can be due to, there are multiple reasons are there. Ductal hypertension is one of the cause. In that patient can have strictures or stones in the pancreatic duct causing the pain. And other causes are like central causes. Because of central sensitization, these patients can have continuous pain. Those two things we have to be careful because the treatment will vary between both of them.
You can add up that some patients that increase initial acute pancreatitis, they have very severe pain for a few days to weeks, and then there is a completely absence of pain. The disease settles down, and for months to years they may not have pain. Other type is they have a continuous background, unrelenting pain, and keep on having some exacerbations now and then.
Yes, sir. Got it.
And as it said, it can be due to multiple reasons: pressure in the pancreas, or it's inflammation, neurogenic inflammation. So those things also.
So pain in pancreatitis is variable causes are there, multifactorial, and as said now, so it may be due to the obstructive causes like strictures and stone can give rise to the pancreatitis, and anything that goes beyond that, giving autonomic component to that, and can give rise to pain. And how a surgeon also sees. So for a surgeon, when the patient comes with pain, most of the patients will present with the chronic pain. And pain is an important component in deciding what is the disease activity that is going on. And it doesn't reflect just pain due to chronic pancreatitis per se. So that is what I would like to highlight from this discussion. And as said partly from the panelist, that pain is due to from the pancreatic origin because of obstructive causes, or it could be sensitization of the peripheral and central neurons to pain. So from surgeon's point, what you feel, sir, this pain?
What we see in our group of patients, they usually...
Concisely, you can give your opinion, sir.
So as you said, there are two types of pain. One is a pain which is perceived locally, which radiates to back. And when it is become chronic, the patient, they may develop the central type of pain. So they have a sensation of pain occurring. So these two need to be recognized where the drugs modification is needed, where you can give pregabalin and tramadol may work in those who are having that central perception of pain. So because of the chronicity.
Okay, sir. Okay. So pain, understanding of pain is very essential in management of a chronic pancreatitis, and characterization of the pain is very important because the initial presentation in the early stage of disease, the pain will be entirely different. As the disease progresses, the pain character will change, frequency, intensity, everything will change, and it may also reflect the local complication that they develop following these acute events or over the period of time with the chronic pancreatitis. So various pathophysiological hypotheses have been put forward in defining this cause for pain, and they are characterized as plumbing issues with organ or related ductal hypertension, ischemia, and local complications, and also the widening issues that, as I highlighted by the panelist, the peripheral and the central sensitization. This is an article which described about this pain description from animal studies, and there is a different mediators at the tissue level in the pancreas that cause increase in the nerve fiber numbers, and also hypertrophy of these nerve fibers, and increased infiltration of the inflammatory cells also trigger the pain response to in these patients. And also this peripheral stimulation also cause a central pain sensation in the terms of activating these astrocytes and macroglial cells, and increase and inhibition of this pain inhibition reflexes from the central system. So it's a quite complex and multifactorial cause, and different components contribute for pain. So additional factors like the effects of opioid alters the bowel microbiome, and that can cause pain, bacterial overgrowth, and sequelae. And this increase in CCK levels and norepinephrine and diabetes-related sequelae in the form of mesenteric ischemia can also contribute for the pain. So this chart I have put not to elaborate in detail about the pain management. This is to tell that the pain is multifactorial and lots of components are involved in pain management, and not just opiates and analgesics are required in management of pain. And still the pain management is difficult. That is what this algorithm reflects. So the next component is the determining the pancreatic functional status. So the first component that we see in the form of insufficiency is exocrine insufficiency. When 90% of the pancreatic function is compromised, then they manifest with exocrine insufficiency. So this question is to our physician gastroenterologist. When do you suspect exocrine pancreatic insufficiency in a patient with chronic pancreatitis?
So patient is a non-case of chronic pancreatitis or newly diagnosed chronic pancreatitis. Whenever patient comes with weight loss or new diabetes, and if they have having like non-specific symptoms like bloating, some patients can have nausea also. These are the rare symptoms: bloating, borborygmy, flatulence, and diarrhea. Steatorrhea is seen only when there is 90% of pancreatic function is compromised. Other nutrient like nutritional things, like because pancreas is required for the digestion of and it requires for the absorption of ADEK, like fat soluble vitamins. The deficiency of those vitamins can be seen. There's osteoporosis also well documented in those patients. Then other malabsorption and maldigestion can be seen in those patients.
So primarily, it is a GI symptoms due to malabsorption, maldigestion, and malabsorption. So these features lead on to manifestate with bloating, borborygmy, increased flatulence, and osmotic diarrhea, and steatorrhea. Associated with this, there is a malabsorption of fat-related vitamin
these features
absorption.
are not very clear in our patient because their type of diet more common probably in the Western patients, where their fat content in the diet is more. We see less often such symptoms.
Okay, sir.
But sometimes we happen to see, but less often we don't see this very commonly.
So how do you manage exocrine insufficiency?
So first we can document exocrine insufficiency with pancreatic elastase like serum and fecal elastase test. If it is less than 100, it tells that the patient is having a severe exocrine pancreatic insufficiency. In those patients, first we'll give dietary management. Dietary management, they have to take high carbohydrate, and along with it, pancreatic supplementation should be given. And they will give like pancreatic lipase, like in Creon or pan lipase, they are the medication we give around 25,000 3 times daily. The main point with this replacement is it has to be taken in the middle of the meal. It should not be taken before or after. So after taking food for 5 minutes, then he has to take the tablets. Then he has to continue his feed. If we don't direct them to take this kind of this thing, then the utility of pancreatic supplementation, enzyme supplementation will be futile. And other things like we have to address micronutrient deficiencies like vitamin A, D, E, K, and calcium supplementation and vitamin D supplementation, because this osteoporosis, osteopenia is there in those patients.
So it's clinically mostly diagnosed, and we assess the general nutritional status, and nutrition is taken care in addition with primarily giving this pancreatic enzyme replacement therapy. So normal pancreas usually secrete 90,000 international units with each meal, but we don't supplement so much because some amount of secretion will be there from pancreas and also from the stomach. So 500 units of lipase is given per calculated per kg, and per meal it is given. So around 40,000 international units are to be given with each meal, and it should be given with the meal, and that will take care of the nutrition. And we have to reassess how much the absorption is happening over time, and we need to know whether it is really enzyme insufficiency or any other factors giving rise to this malnutrition or symptoms related.
40,000 will be too much for Indian population.
Okay.
So better we give 25,000. And if they are taking any snacks, 10,000 will be sufficient. We give 40,000, they will have more symptoms related to this pancreatic enzyme replacement also. They can have colonic stenosis and other complaints. So better, that is for foreign standards, but for Indians, 25,000 is sufficient.
Okay. So how do you see diabetes mellitus in chronic pancreatitis? From a physician only.
So diabetes, it's called type C diabetes. In those patients, there because of chronic inflammation, there is the damage to insulin secreting beta cells that leads to diabetes mellitus. And in those patients, most of them initially we can manage with oral hypoglycemic drugs, but in long term they may require like insulin. And one more thing is there's something called brittle diabetes in those patients, because if we don't supplement pancreatic enzyme replacement in the chronic pancreatitis patient, when we give insulin, the digestion will be like erratic. So whenever if like there can be like rapid gastric emptying in those patients, like slow gastric emptying. So there will be fluctuations in the glucose, like hypoglycemia, hyperglycemia can be there. So we have to be careful while titrating the medications also in those patients.
Very well said. So in patients with exocrine insufficiency in the chronic pancreatitis, due to inflammation and fibrosis, there is a decrease in the number of cells and volume of the islet cells, and the functional component of alpha, beta cells and other cells also gradually comes down. That is the reason why difficult to control blood sugar in chronic pancreatitis. They become more brittle because they go into two extremes, one hypoglycemia or hyperglycemia extremes, because of the underfunction of this glucagon and insulin secretion. So a systematic review and meta-analysis of 8,970 patients from 15 studies showed new onset diabetes mellitus in nearly 30% of patients over the period of over time. And insulin dependence was seen in 17% of the patients, and nearly 15% patients had diabetes at the end of 3 years, and it increased to 1/3 of the patients with the chronic pancreatitis to develop pancreatitis diabetes in 5 years time. And there was minimal association with alcohol-related chronic pancreatitis, sex, age, and body mass index with development of diabetes mellitus. And this forest plot clearly shows the trend in diabetes development over a period of time. There is heterogeneity, but still there is a significance. So management principles are to prevent hypoglycemia, hyperglycemia, and prevent exacerbation of malnutrition, and treatment of diabetes-related comorbidities. So they should be subjected to small frequent meals. Well-planned mixed diet should be given with starchy carbohydrates, so with a low glycemic index. And they should avoid consuming alcohol and smoking. pancreatic morphology. Anybody looking at this image will tell that there are extensive calcifications in the region of pancreas, and they will tell it's a chronic pancreatitis. So, is this diagnosis sufficient, sir? This is to our radiologist, Dr. Ramkumar, sir.
Most of the times in our setup, where patients present for a long period of time presenting with chronic abdominal pain or with recurrent abdominal pain, we diagnose late. So we end up with a picture like this, where you see extensive calcifications in pancreas, either in CT or ultrasound. So all the modalities can be used in the diagnosis of chronic pancreatitis. Each has its own advantage. But when a patient presents early, the earliest changes can be picked up better in endoscopic ultrasound. So the advantage is to see subtle changes like lobularity of the gland, the strands, echogenic strands, and echogenic foci without after shadowing, where frank calcification has not happened. So these are some of the early changes which we can pick up in endoscopic ultrasound. And CT and MR both help. They have their own role. So CT, one is to pick up calcifications in the parenchyma, as well as to see for calculi in the duct, and to see for duct dilatation, strictures in the duct, multifocal dilatation, and also to see for complications of pancreatitis. MR also has a role with respect to the morphology of the parenchymal changes, as well as the ductal anatomy. So each modality has its own advantage and role, and depending on when the patient is presenting.
Very well said, sir. Anything, Dr. Anudeep, want to contribute?
So in early chronic pancreatitis, endoscopic ultrasound is the gold standard. So we generally follow like Rosebud criteria, in that we follow if any hyperechoic foci with shadowing. Means if any stones are there, they will cause the shadowing in the ultrasound. And along with that, there is a ductal dilatation and strictures, and there can be cysts in the pancreas, and any collections are there. All these things we'll look into it, and finally we conclude it as a possible or probable chronic pancreatitis.
So just reporting a case of chronic pancreatitis is not sufficient in the management of chronic pancreatitis. So we need to see more comprehensively into the changes in the pancreas in terms of the calcifications, duct dilatation, presence of strictures, involvement of secondary radical, secondary pancreas, side branches, and involvement of the bile duct, and involvement of the vascular involvement. So all these things need to be looked into carefully in deciding the management for patients with chronic pancreatitis. So standardization of the definition is more important in management of chronic pancreatitis, so that this data will be more useful in generalizing our data on management of chronic pancreatitis, and reporting will be better. So this is a picture just to show that by anatomy, we classify regions of pancreas as head, neck, based on this first picture, which is seen above. But on radiology, we don't follow the same principle, and defining a head is based on the portal vein and the left of portal vein, whereas the body will be at the left end of the left border of the aorta. So the body component, what we actually see by the reporting will not be corresponding to what the radiologists give a report based on this reporting system. So we need to standardize so that it becomes more comparable, and the quality of management and for auditing and management, it helps in better management. So evaluating early chronic pancreatitis is important, so that you identify this group of patients early, and then keep them on regular follow-up and instruct the high-risk factors, so that the sequelae of this chronic pancreatitis may be delayed or managed early in time. So as of now, there is no any clear definitions in the defining early chronic pancreatitis. And the international consortium also not came up with any clear definitions. But as of now, the definition given from Japanese association shows that based on the imaging, if there are any definite findings in the form of calcification, duct dilatation, it obviously goes and fit into the definite chronic pancreatitis. Whereas those patients who have got early findings based on the US, MRC, and ERCP, they are subject to these evaluation items of listed here. And when they are fitting into this, they come into this early subgroup, early chronic pancreatitis group. So identifying this group is important so that it helps in delaying the development of insufficiencies and follow-up of patients for a risk of developing malignancy over time. And the treatment response can also be assessed, and disease progression with early intervention may also be studied in detail. So these are the different imaging modalities available currently, and their sensitivity and specificity in detecting early chronic pancreatitis. So in detecting early chronic pancreatitis, this is the investigation of choice, where they have to fulfill these 7 criteria. At least they have to have two of these 7 criteria to diagnose early chronic pancreatitis. In the presence of fibrosis, the sensitivity is 84% and goes to 100% specific. So regarding the endoscopic treatment modalities, how do you choose a patient for endoscopic therapy?
First, after diagnosing the pancreatitis, like chronic pancreatitis, we have to see what is the duct size. So that is the main determinant factor whether patient go for endoscopic therapy. In that also, we'll treat as a duct, whether we do stenting or we do management of with ESWL. Those things will be dependent on the duct size. So if duct size is more than 6 mm or 5 to 6 mm, with patient is having strictures or any stones, then we'll consider endoscopic treatment. Ideal patient will be the patient who is having a stricture in the head of the pancreas, single stricture, or single stone in the head of the pancreas. In those patients, we can try for endoscopic management. Even though recent studies have shown that patients who are having multiple strictures and multiple stones in the PD, like head, body, tail, the response rate is better when we can achieve complete clearance of the pancreatic PD calculi. Initially, how we approach is first we'll do the imaging of the pancreas and we see how much burden of the calculi. And then we'll based on if duct size is more and calculi are noted and patient is symptomatic, those patients initially will give epidural anesthesia. And after that, we'll do ESWL. ESWL means it's the same machine which urologists use. So with that machine, we'll do fluoroscopic, under fluoroscopic guidance, we'll be blasting those stones. So ideally, patient should undergo 2 to 4 sessions. After once we are happy with the lithotripsy of the stones, pancreatic lithotripsy, then we'll consider patients taking for the ERCP. In ERCP, they will stent the pancreatic duct. There are different opinion between European consensus and Indian consensus. Europeans, they do only ESWL, means they will do only lithotripsy. They will blast the stones and they leave it like that. And patients are benefited with that. But in India, we have experience of around more than 5,000 patients in AAG hospitals. So in that, what we have seen is after doing ESWL, if you place PD stenting, the patients are benefited more. More than 90% patients achieved success. And we recently published in the endoscopy journal also the factors determining the recurrence of pain. Those patients who have having a chronic pancreatitis, those patients continues to take alcohol, smoking, and the patients are non-compliant with the medication. They are the patients more prone to develop recurrent pain. That is the alcohol cessation and smoking cessation should be clearly explained to those patients.
Very nicely compiled. It is the same slide from a AIG review article where they have listed the indications for management of painful chronic pancreatitis and the sequelae that they develop because of chronic pancreatitis, as elaborated by Dr. Anand. Same management. So this is an article reviewing the role of ERCP in pain management. And this article shows that this table shows that a study from Tadinuma in 2005, where 117 patients managed. More predominantly, the stone disease was in the head, and where the stone fragmentation and the clearance was very well achieved with 96%, and they had a very good pain relief, and the follow-up was also very long period, and had a significant pain relief for long term. And similarly, other study from Hugh et al. Also showed a very good response when the stone disease was there in the head region. And a study Landon et al. With a very large study cohort with a stone distribution in the entire body and tail also was included in the study. Still, he also showed the fragmentation ratio, fragmentation rate of 72%, and with pain relief achieved in 94% of the patient, and complete pain relief was achieved in 82% of the patient, but the follow-up is short, 6 months. So this is a flowchart given from AAG Hyderabad, the same article. So it is more meaningfully structured algorithm. So patients who are unsuitable or with a head mass, definitely they are out of endoscopic therapy. And those with extra pancreatic treatment or complications also, they have to be out of endotherapy. So when they have ductal problems, so when they have strictures or intraductal calculi, when the calculi is less than 5 mm, ERC indicated. And when it is more than that, ESWL, subsequently ERC stone clearance is done. So when there is a stricture, stent placement with multiple and fully covered metal stents are indicated. So from concluding this endotherapy in chronic pancreatitis, assessment of suitability for endotherapy is very essential, and it is the first step in deciding the endotherapy. So, and patients who are refractory to endotherapy are definitely a contraindication for endotherapy from imaging. And poor responders on imaging, poor responders like factors seen on imaging should not be subjected for endotherapy. And decision for choosing a patient for endotherapy should be based on patient preferences, available resources, and expertise. Since many studies and systematic review and meta-analysis have shown that surgery is fares much better than endotherapy. But choosing a right patient is more important for endotherapy, where you still get a very good success in pain management. Now we see the surgical management strategies. Surgery as such is categorized into 3 categories, primarily drainage procedures, resectional procedures, and a combination of drainage and resectional procedures as hybrid surgeries. So the procedures described under each category is listed here. Pancreaticoduodenectomy, pylorus preserving pancreatectomy, Begus, and total pancreatectomy with islet transplant as resection and drainage procedures, and hybrid procedures, phrase procedure, Burns and Hamburg. Of this phrase we do, and DPHR comes under this one. So this is a pictorial representation of a different technique. The first one, just laying open the dilated ductal system from tail to head region and do a pancreaticojejunostomy. And when you do a head coring, then it becomes a phrase procedure. And when you resect the head portion with the coring out of the head C loop, preserving the duodenum when you do, then it is Begus procedure, and you have to do a 2 anastomosis separately, one at the distal pancreatic stump and the C loop of duodenum where the remnant pancreatic rim is there. So when you remove entire pancreas with the duodenum, it is pancreaticoduodenectomy. So this is to Dr. Vishnu Prasad, sir. So how do you plan surgery in a patient with chronic pancreatitis? What components you take into consider to decide what procedure?
Again, surgical management of a patient with chronic pancreatitis depends on the expertise available in a center, whether the medical gastroenterologist is more active or a surgical gastroenterologist is more active, and availability of ESWL, availability of endotherapy and all. So if medical gastro, though there is a trial also, you must have heard the ESCAPE trial, which prefers early surgery. Surgery is better than endotherapy. Right? And ESWL, though there are advocates of ESWL, it takes more session and it is costly also. Even in an early case, I would prefer surgery. But if the endotherapy is easily, cheaply available, then probably I would consider in selective group of patient. So before choosing surgery, I would like to look into whether the duct is dilated or not, or whether there is a pancreatic mass, right? Or there are associated problems in and around, if there is a pseudocyst, or there is other problems in the form of a fistula. So all this, the entire pancreas, I would like to take into consideration patient symptoms as well as the structure in the around the diseased gland. Yes, so based on that, I will plan the surgery.
Yes, sir. Thank you, sir. So what all things you take into consideration when you plan surgeries? When there is a suspicion of malignancy, there is no any drainage procedures. It should be a resectional procedures and no hybrid procedures as well. So you should plan for a pancreatic duodenectomy or a pylorus. So if there is an head mass with dilated pancreatic duct and it is not suspicious, then you can plan for hybrid procedures like a duodenum preserving pancreatic head resection, biggest procedure, phase procedure, and burns. Burns are not practiced now. And then when there is a pancreatic head mass with a small pancreatic duct, then Hamburg's procedure modification is done, where you just resect a V-shaped resection of the pancreatic duct till the head region with the coring out of a head mass. So when you do only just undilated duct, when you do a resection of that ductal segment, V-shaped resection and exposing the duct and doing a pancreatic jejunectomy, then it is a His-Beck case. In hereditary pancreatic syndromes, the role of total pancreatectomy comes into play because they are at high risk of developing malignancy, and over their lifetime, the risk of developing malignancy is quite high. So those subgroup of patients are indication for total pancreatectomy, and other indications are where they failed previous surgical procedures and severe pain. They may be a candidate for total pancreatectomy. This CROPAC trial, where they compared DPPH with pancreatic duodenectomy, it's a multicenter trial, superiority RCT, from 18 centers in Europe. The primary endpoint was quality of life for 2 years' time from surgery. They used EORTC scoring questionnaire for assessment of the quality of life. The quality of life based on this radar chart shows that clearly the purple one and green one indicates score to the intervention, and maroon and blue indicates the score after the intervention. So the score is centered at 0, and as it goes outside, the score becomes more, and as the score increases, the quality of life is improved. So there are 5 domains in this questionnaire, and all the domains have been found to be improved with surgical resection in the form of DPR, DPPHR, and PD. And both are comparable. In the same way, the pancreatic pain-related symptom scores also found to be coming down following the surgery. So here the score, when it comes down, the pain score is less, and so the quality of life and is improved. So this also reflected with the surgical intervention. So the next question is whether to go ahead with the endoscopy or surgery as a first option in the management. So this is a ESCAPE trial published in 2020, where it is a RCT with superiority trial with 30 centers from Dutch. So it recruited 88 patients with chronic pancreatitis. The primary outcome was a pain score after the intervention. And in the early surgery group, there was pain score was 37, and in the endoscopic first group was 49. So when the score comes down, it indicates a better quality of pain, a better reduction in the pain. So there was a difference of 12 points between the surgery and endoscopy. So this chart shows clearly that pain score was significantly less in the early surgery group, whereas in endoscopy group, endoscopy first group, the pain score was more. And this chart also clearly shows the dark green shade reflects the pain. In the surgery group, it was significantly less compared to the endoscopy first group. So these different shades indicate the complete pain relief and partial pain relief and no pain relief.
You should take these results with a pinch of salt, because that was 2011 to 16 patient. That time only second generation was there. Now third generation ESWL machines have come. In that also the duct clearance is only around 60% or 70% in this trial. The clearance is not achieved in most of the patients. In subgroup analysis, what they have seen is the patients with duct clearance who have achieved very good duct clearance, the pain relief is same in both groups. So there is like if it is surgery, patient agrees, like well and good, you get the surgery done, patient is happy, everybody is happy. If the patient is not willing for surgery, there's a scope for endoscopic therapy. With the advanced treatment now, definitely endoscopy has a role. And if we can achieve good clearance, if the burden of stones are less, then we can consider endoscopic treatment. With the very good pancreatic lithotripsy followed by pancreatic duct stenting, still has a role. I feel that is it.
So it's clearly highlighted also. There are few
Around 3
patients,
sessions, like mean will be 3 sessions.
few patients who are indicated for ESWL couldn't undergo the procedure in the study. So those subgroup of patients had been excluded from the study. So that would have also altered the results in this study. So there is yet another meta-analysis comparing the long-term effects of surgery versus endoscopy therapy. So it included 3 RCTs, 267 patients. So in this study, the pain relief was this forest chart clearly shows that pain relief was achieved in surgery group compared to the endoscopy group, and the heterogeneity was almost not significant in this study group. Complete relief was achieved in surgery group compared to the endoscopy group. Next, they couldn't identify a significance in the quality of life with using SF36, but physical health score was showing some trend towards significance in surgery group compared to endoscopy therapy. There was no functional improvement in the form of exocrine or endocrine insufficiency following the surgery, but most of the patients had to develop these sequelae following the surgery. Nearly 75% of the study populations had developed post-surgery exocrine insufficiency. I'll go to this inflammatory edema. Inflammatory edema is a subgroup of patient which needs extra care in planning the surgery. So there are no any clear definitions in defining inflammatory edema. Multiple studies have used a different definition, but most commonly used is more than 3 centimeter, 4 centimeter diameter of the pancreatic head on this one. So how you identify how the main implication of this inflammatory edema is differentiating a malignancy, underlying malignancy in the inflammatory edema. So these are the points that you can take into consideration when you define any suspicion of malignancy in the inflammatory edema on imaging. So management will be imaging first, and then US to assess in detail about the inflammatory edema, and subsequently an FNA or FNB will help in making a diagnosis. But still, if false negative rate is high with the FNB, the intraop frozen is essential when you have a strong clinical suspicion and intraop suspicion. Nutritional management is also an important component in the management of these patients. And this is the recent ESPN guidelines on nutrition management in chronic pancreatitis. This is the final thing which I would like to put up here in the management of chronic pancreatitis. Thank you very much for the sharing this session.
Thank you, sir, for that wonderful panel discussion. I hereby request Director Professor Dr. Pavlendra Lal to kindly come on to the dais to felicitate the panelists. Dr. Adi Narayan. Dr. Ram Kumar. Dr. Anudeep Katravella.
Thank you, sirs. I now request Professor Dr.
Bhavanendra Lal and Dr. Vishnu Prasad sir to kindly remain on dais for the next session. Now we have a guest lecture on fluid and electrolyte management by Dr. Welcome you to the dais. I also welcome Indian Samarasan and Dr. Suresh Kumar to chair this session.
ये नहीं है, it's not moving forward.
So, good morning. So it's my pleasure to introduce Dr. Pavan Lal. He's currently the Director Professor of Surgery at Maulana Azad Medical College. Previously, also held the position of Executive Director and CEO of National Board of Examination. And he is also the Vice President of International College of Laparoscopic Surgeons. Has many awards and publications to his credit, so including Sardar Vallabh Patel Awards 2021, NAMS Distinguished Award in 2019, BC Rai National Award in 2016. Right, so he's also the Fellow of Royal College of Edinburgh and Glasgow. Right? So his areas of interest is minimally invasive surgery, advanced laparoscopic surgery, colorectal surgery, and hernia surgery. So today is going to talk on one of the important topic from the postgraduate's point of view, fluid and electrolyte management, which is often neglected, but it's very important from the surgeon, from the patient point of view.
Thank you. Thank you very much, Dr. Vishnu. Thank you for this very kind invitation. And I thought I saw in the first few minutes that most of the postgraduates are relaxing in this very comfortable auditorium, and I can't blame them, because they're all exam going, and this is like a breath of fresh air for them, both academically and, from the ambience of the whole thing. So they're catching up on their sleep and rest. But this is time to wake up. So I've taken a mobile mic and I'm going to leave the podium and I'm going to be in between you. And I'd like you to interact and enjoy this next few minutes. And we'll stop whenever the chairpersons tell me to stop. The time is over. We'll stop there because this is a long topic. And I plan to finish only the fluid part of it and a little bit of electrolytes. I will not touch the acid-base balance because that's a bit longer component. So I bring greetings from my institution, MAMC, from where I have just completed 25 years of my service. In June, I will be completing 25 years of my service in the institution itself. Thank you. And also tell you that we take 250 MBBS students, 16 postgraduates, and 2 fellows in minimal access surgery from the National Board. So during the course of this, I would like to take you over the understanding of basics of fluid volume replacement. How do you estimate losses? What happens when the patient undergoes trauma? And this is something that you're going to deal with and you are dealing with day to day. You are managing this on a day-to-day basis. There's no reason why you should not know it already. And it may be a repetition for that. So, and then try to understand some of the conditions where we alter the fluid requirements according to the special conditions. And then time permitting, we'll go to some other topics as well. So the start of this is the total body water. We have 60% total body water. in males and 50% in females. So my first question is, why do we have higher total body water in males and lower in females? Anybody? Yes, ma'am. Yourself? Just keep sitting and just give a shout out. Come on. So male, females are equal. We are supposed to be all equal, no? It's a gender neutral society nowadays. You fight for rights and everything. You tell God Almighty why we are not equal on this front. And why this is important from fluid dynamics from point of view. So that's the answer. The total body water is directly proportional to lean body mass and inversely proportional to body fat. So if you have higher body fat, you're going to have lesser total body water. If you've got higher lean body mass, muscle mass, you're going to have higher total body water. Okay. So what is the importance of this? Except for understanding that, yes, we are 60% water, you are 50% water. How does it make a difference to a surgeon? Does it or does it not? Raise of hands. Does it make a difference? Yes or no? Does it make a difference? Yes or no? For yes, raise your hands. Okay, now you're committed. Why does it make a difference? Okay. So for the same amount of fluid loss, same amount of blood loss, who is going to have shock first? A female and a child. That is the corollary of this slide. Okay, for your journal understanding, for 500 ml of blood loss during surgery in a male cholecystectomy versus a female cholecystectomy or a liver resection or anything, this person, which person is going to have greater problem? Person who has got lesser amount of total body water will be more vulnerable. That whole amount is different in that person, because once we start this, then comes the, this has stopped working. They don't want me to move. We want to study how this total body water is distributed inside the body. This 60% is distributed 20% in the extracellular fluid and 40% inside the cells, right? Very simple. And we're talking of 60% of what? Body weight, weight in kilograms. Now, out of the 20% which is extracellular, we are talking about 5% which is the plasma and blood which you are measuring in your through your samples, and 15% is in the interstitial fluid. Just understand, whatever sodium, potassium, acid-base balance, whatever blood sample you're taking, which component of the compartment are you taking it from? 5% of the whole body, not 100%. It is not the mirror image of the entire body. It is just that reflection. Now imagine that 500 ml of blood loss in a patient who has got unequal volumes, how this is going to be a challenging situation. So this is what we are measuring. This 5% is what is our change. Now this is the intravenous solutions. That's again very important slide for you. 5% dextrose has got what? What is 5%? Come on, fast. I'll have to move in. What is 5%? What does 5% mean? In 1 liter. Wrong answer. 5% means what? 5 mg per deciliter. Wrong answer. 5 mg. Mg. Okay, okay. Let's change it. Yeah. 5. When you say 5%, any damn thing, fluid, anything, when you talk of percentage, what is it donating? Grams in? Yeah. So 5 grams in 100 ml. So how much of dextrose total in 500 ml bottle? 25 grams. How many calories? 100 calories. Yeah, right. Now 0.9% saline has got 154 sodium and 154 chloride. And then what is this solution? Have you ever heard about this solution called 4.3% dextrose and 0.18% saline? What is this solution? Anybody? Give me a raise of hand. It is not seen in India. I don't blame you. This is the classical dextrosaline. 4.3% sugar and 1/5 normal saline. 0.18 into 5 is 0.9, right? So 1/5 normal saline plus 4.3 is the actual dextrosaline. It is not available in India. For what reason? I can't understand. We are now at 75 years since independence. We still don't have dextrosaline. What dextrosaline you have is a different fluid which you use in the OT. I'll just come to it. And this is the last one, which is Ringer's lactate, which is 131 sodium, almost equal to blood minus RBCs, WBCs, and plasma proteins, right? It is the closest. So, but we still don't use it except for burns. We use it mainly when we are using for trauma. We'll tell you we are using saline. Okay. Now, why do you use 0.9% saline and 5% dextrose? What is the basis of 0.9? Why is it not 0.8? Anybody? Come on, this is basics. You are final year MS exam going students. Why is it 0.9? Tell me the logic behind 0.9. Anybody? I should not be partial to this side. I have to be equal. I need to go into this side also. Yes, sir. Anybody? 0.9? Okay, that's the answer. 58.5 grams, right? What is 23 sodium, 35.5 chloride, 58.5 grams in a liter of solution will give you 2000 milliosmoles. Why? 1000 milliosmoles because of sodium ions and 1000 milliosmoles because of chloride ions. So 2000 milliosmoles. Now we want isoosmolar solution which is near about 300, 290, 280 to 300. So when you have how much osmolarity to get how much amount of salt will you dissolve to get an osmolarity in the range of 300. So you can see 154 makes it 308, right? So that's happening when you put 9 grams. So that is the reason why you have got 0.9% logic because why you want to have 0.9 and not any other number. Everybody has understood. At the end of this class, if you have understood this, my visit here has been successful. Now, why is it 5% dextrose? Same logic. 5% dextrose is what? What is dextrose formula, sir? Dextrose formula. Keep sitting. Dextrose formula. C6H12O6. C6H12O6 total is 180. When you combine all of them, C is what? How much? 12. Right? 6, right? H12O6. You do it. So now why does dextrose in a liter of solution have only 1000 milliosmoles? Sodium has got 2000 milliosmoles because it does not break up into ions, right? So it will produce only 1000 milliosmoles. So how much will you dissolve to get a value in the isoosmolar range, right? We are working simple mathematics. So when you dissolve 5 grams, you get 100 divided by 180 into 5, which is 278, which is in the isoosmolar range. Have you understood? That is the reason why 5% dextrose and 0.9% saline are isoosmolar solutions. Okay, so how do we control the water intake? We have got thirst center in the hypothalamus, which is stimulated by increase in plasma osmolarity or a decrease in the extracellular fluid volume. Either of these two. Plasma osmolarity increase will cause increase in ADH. ADH will do what? Conserve water, right? And increase in thirst, person will take more fluid. If there is a contraction of the ECF. How does contraction of ECF take place? Arey, come on. Blood loss, diarrhea, vomiting, anything, any high output enterocutaneous fistula will, with a fall more than 5 to 10%, will cause decreased stimulation of the atrial type B receptors, leading to increased sympathetic stimulation, leading to vasoconstriction, decreased pressure at the renal afferent arteriole with increased stimulation of the renin-angiotensin system, and invoking the renin-angiotensin pathway, which is going to what? It will produce angiotensin 2, which is the strongest vasoconstrictor in the body, right? Produced where? Lungs, right? And consequent effects will be seen. So that is the renin-angiotensin system in front of you. And what stimulates renin-angiotensin system? Decrease in pressure, arterial pressure, which is called in ECF volume, and decrease in concentration of the sodium concentration at the macula densa. So both of these things will stimulate the GJ apparatus, and that will lead to the conversion of angiotensinogen to angiotensin 2. ADH is released from the supraoptic nucleus of the posterior pituitary, and increase in ADH causes our increase in plasma osmolarity, decrease in ECF volume, but very importantly, this is where this is important for you, post-operative stages, trauma, stress, surgery and trauma. Everything is going to invoke secretion of ADH. So if any one of you normally just is NPO for a or any one of us, sorry, not you, any one of us undergoes any elective operation like a hernia surgery, but we are post-op, the urine output will be normal after surgery or less? It has to be less. So if there is a normal less, that doesn't mean that you will start pushing fluids to the patient. That's a normal. If the pulse is normal, BP is normal, everything is normal, you know that the decrease in urine output is because of the normal stress response. So opposite is true for the other causes. So the sodium balance intake, we take about, how much do we take in a day? 80 to 100, which corresponds to 5 to 6 grams of salt per day. Why do you take it? Because you lose all of that in one day. That is how the body homeostasis works. Secretions add to it. We lose some in feces. Plasma levels are 136 to 144. Kidney losses passively in the proximal convoluted tubule, 75% is absorbed. Loop of Henle, 22%. DCT, 4 to 5%. And collecting. So that maintains the homeostasis of sodium. Normal potassium, 50 to 80 gram per day, 50 to 80 millimoles per day, because we lose that much. So secretions add 40 milliequivalents. We lose about 7 to 15 in the feces. The plasma levels are 3.5 to 5 milliequivalents. You all know that level. And this is the way the kidney manages. In the proximal convoluted tubule, 90% is reabsorbed, 10% in loop of Henle, and in the DCT and CT, it is secreted in response to? It is secreted in response to aldosterone, right? It is secreted in response. So you start putting bells, it is giving me atrial fibrillation. This is the recommended daily requirement, but I don't want you to know anything else except this particular one. Sodium 1 to 1.5 milliequivalents per day, per kg per day, and potassium 1 milliequivalent per kg. You know this. Potassium is easy. Sodium is what I've just added. Sodium deficit. So how do you calculate the sodium deficit? Normal sodium minus the measured sodium times 0.2 times body weight. Now, why does this 0.2 come in? So normal is 140, 136 to 144, average is at 140. 140 minus, suppose the measured is 130. So it is the deficit is 10. Why it is 0.2? I want you to answer me, please. Morning, sir. Good morning. Yeah. 0.2 is, where is this sodium? Where are we taking the sample from? 5% volume. But it is representing, it is in homeostasis with the remaining 15%, which is interstitial. So we are talking about 20% in the extracellular space, which is 0.2, right? Some books will say 0.3. I'm not able to define 0.3. So that is the reason I'd say that this is defensible by you, that this is 0.2 is the extracellular fluid times the body weight. So how do you treat? You have to give volume 50% of the deficit plus the continuing losses plus the normal requirement for the day. So normal sodium requirement 1 to 2, 1 to 1.5, fluid requirement 30 to 35 milliequivalents per kg per day. So you have to, this is the treatment for most of the hyponatremia situations which you will get because of excessive fluid loss from high output fistulas. Now this is the normal urine output. Insensible loss about 700 ml, loss in the feces, total 2500 ml. That is the way you have to calculate the normal losses which are happening. So that almost equates to 30 to 35 ml. If you multiply it with 70 kg, then it is going to be equal to this 2500 ml. So body maintains it homeostasis. So now this is the formula for pediatrics. All of you remember this from your pediatric posting? I just wanted to tell you, consider 0 to 10 kg as A, 100 ml per kg per day. For the next 10 kilograms, B, 50 ml per kg per day. And for the beyond that, 20 ml per kg per day. This formula for pediatrics holds true even for adults. Look at the formula for 70 kg. 70 kg, 100 ml per, for the first 10 is 1000 ml. 50 ml for the next 10 is 500, that is 1500. And 20 ml for the next 50 kilograms, 1000 ml makes it 2500 ml. So both ways you can calculate. This is the child formula. We don't normally use it like that. We use 30 to 35 ml per kg per day as the normal fluid requirement. You may add, if there is excess, hot temperature and everything, you may add a little bit extra for that. Now, what happens after surgery and trauma? Look at this, to the urine output. Very carefully, please look at this. Some of you may not be able to see if I'm coming on the way. So, normal 1500 ml, in the post-op 500 ml. This is happening because of ADH, right? This may continue for 2 to 3 days. That is when the stress hormones are working. Sodium excretion normally, I showed you, is 70 to 90 milliequivalents. That is why we are taking that much in our diet. What happens after trauma? 5 to 20 only. Sodium conservation is happening. This continues for again 2 to 5 days. What is the lesson? What is the lesson? You don't have to give saline in the post-operative period for 24 to 48 hours because the body is conserving sodium. What happens to potassium? Potassium is normally 50 to 80 milliequivalents. It is getting lost more. From where? From the cut surfaces of because potassium is mainly a intracellular cation. So when you do traumas, incision from the surgical skin, everything that you cut, all cells that are bleeding out potassium. Everything that you are destroying and cutting is releasing potassium. So there is a potassium loss and potassium is more in the circulation. This continues for 1 to 3 days. Again, you don't give potassium in the first 24 to 48 hours if pre-existing everything is normal. So in the first 48 hours, due to metabolic response to trauma, body conserves water and sodium and potassium is released from the surgical or the trauma site and you don't need to supplement anything. So this is again a quick revision for you, just for you to remember once again, what are the fluids that we are giving? We are giving 5% dextrose and saline normally. So essentially, The post-operative requirement of fluid in the first 48 hours in the absence of any pre-existing derangement will be 2.5 to 3 liters, that is 5 to 6 wax of 5% dextrose only, that is water without any added electrolytes. Now tell me with a raise of hands, how many of you do it routinely? In the post-operative period, how many of you say 5% dextrose, only 5 wax, 6 wax? I know it. You don't do it. I know it. I know the thing happening because that's a disease, and neither of us, none of us, we are all to blame. All of us faculty members are to blame for this because we are so very scared that patients should not go into hyponatremia or hypokalemia. But this is the fact of life, that the first 24 to 48 hours, you don't need anything except 5% dextrose if there is no pre-existing loss. And no elective patient has any pre-existing loss. All elective patients are absolutely normal. Okay. So now what happens after the first 48 hours? Now that is the now the mathematics starts. That is the interesting bit. So now first thing is to calculate your sodium. What do you do normally? Do you ever calculate sodium first? All right. So the first thing is to calculate sodium. So sodium is 1 to 1.5 milliequivalent per kg per day. Potassium is 1 milliequivalent, which has to be given over 24 hours. So therefore, if you calculate 1 to 1.5 for a 60 kg, it becomes 60 to 90 milliequivalents. How much does a bottle of sodium have? I've just told you. 154 milliequivalents in a liter. So in a bottle, it is 77. Rough calculation, 75. Right? One bottle of NS, 500 ml is 75. So if you want to give 75 as an average, one bottle is enough. So with that answer, the first thing is to give 1 vac of NS, and then your remaining is how much? For out of 2.5 liters. 1 bottle is NS, remaining is what? 2 liters of 5% dextrose. So your volume is out of the way. Sodium has been given. Then you have to give what? Potassium. And potassium is 1 milliequivalent per kg. So if it is 60 kg, add potassium ampule to any 3 vacs of 5% dextrose. This has to be written. It has to be written and signed. That this is the order for the sister to follow and to be given alternate. So you give 5%, then sodium, then 5%, then 5% like that. If you want to give higher sodium, which is the formula with 2 saline, then you got 1 liter, and then the remaining, suppose you want to give 3 liters, then the remaining 2 liters is 5% dextrose, which is B. And then add 60 milliequivalents or 80 milliequivalents, whatever the weight of the patient is, and then you complete. So you have to work backwards after calculating sodium and calculate it first. And this is all happening when the patient does not have any sodium derangement. Okay. Now, this is the losses. For if you have got saliva, these are the secretions. If I ask you, you can just know sodium-rich areas, stomach, duodenum, small bowel, pancreas, bile. These are sodium-rich. Potassium-rich, saliva, and then mainly colon. Right? So if a person has mucus diarrhea, the patient is losing potassium. If the patient is vomiting because of an esophageal stricture, and is throwing out a lot of potassium. So when a patient has got, can I have, sir, 5-10 minutes more? Yes, sir. After that, there will be AED will be required. So this is the loss. Now, what I'm trying to tell you, when you put your NG tube or when you put this bag here, or the patient is vomiting, can you find out how much is saliva, how much is stomach, how much is duodenum, ileum, bile, pancreas? No. So I want you to learn only one number here, which is on the floor. which is known as mixed gastric aspirate. This is 120 sodium and 10 potassium. Finished. Full stop. And this is all I need if I have to calculate any extra loss. So now, again, revision for you. Fluid. We have got some colloid volume expanders. We use hexaethyl starch. We use dextran 70 for their high molecular weight. They stay in the fluid for longer time. This one, I think I put it because stay time in the circulation. 5% dextrose stays in the blood for only 7% at the end of 1 hour. Did you know this? What do you mean? If I give 1 liter of 5% dextrose at the end of 1 hour, how much is remaining in the blood volume? 70 ml. Can you use it for shock? Yes or no? Never ever. How much saline stays? 22%. Still, you have got, if you add 1 liter, 250 ml is going to stay. Very good. At the end of 1 hour. If you give colloid, everything stays. So these are the alternative colloid volume expanders. Hemexyl is the heat degraded gelatin, which again stays for about 4 hours. Hexaethyl. So this is the chart which I want you to remember. 5% dextrose at the end of 1 hour, only 70 ml. 0.9% saline or Ringer's lactate, about 225 ml. Roughly, you can imagine 200 ml or 250 ml, you will be fine. 1/4 of it. 1/4 of it. Okay. And albumin or blood or plasma will stay 100%. So now, let's calculate that problem of beyond 48 hours and high output failure. 60 kg man, Ng aspirate is 2 liters, urine output is 1.2 liters, sodium is normal, potassium is normal. So we add 800 ml for insensible loss. What is the total volume? What is the volume to be given? Come on. 4, isn't it? 1 liter of urine, 2 liters of extra loss is there, Ng aspirate, and we have got 800 ml, it's hot ward, your JIPMER ward is there, 700 to 800 ml you are losing there. So 4 liters. Now let's see how you calculate. First, calculate sodium. So loss in the Ng aspirate for 2 liters, 20 ml in 1. So 2 liters is having 240, right? So, and potassium is 10, so it is 20 for potassium. So normal 24-hour requirement for sodium, around 60 to 90. So let's say if it was 60, we will add 300. Yes, 240 for the loss and 60 for the day. For potassium, 60 was the normal requirement and the loss is 20, 80. Finished. My fluid is ready in front of me. How much wax you need for 300 ml of 300 millicoulombs of sodium? Come on, 75 in 1. 4 wax. So 4 wax of sodium, I had to give 4 liters. So remaining 4 is 5% dextrose. So finished. That's it. And then how much of potassium to be added? 20 millicoulombs, 1 ampule in each vac of 5% dextrose. Both solutions to be given alternate. You can't give only 5D, 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 only NS. So this all, do you write all this? Do you write like this? This is the rate. Now the next question is, so this is everybody clear about it? So this is beyond 48 hours plus extra losses. This is the way you are going to calculate. How do you calculate the drip rate? I can stop at any time, sir. If we are accessing, we will stop at any point of time. This is the last concluding slides for the fluid part. This is very important, rule of the thumb. See, how do you write drip rate? How will you start? Let us ask. $2.5 liters to be given. What is the drip rate? Don't calculate. Tell me. on the face. How much will you give? What is the drip rate to be given? 5 wax I have to give over 1 hour. How much? What is the drip rate on this? Yeah, that's all right. What is the drip rate, I asked? How will the sister calculate 100 ml per hour, yeah? Huh? Good answer. So you knew it. Anybody else knew how to do it? I'll tell you the quick way to do it. Excellent. Excellent. Well done. So for ease of calculation, 25, I've converted to 2400. So 100 ml per hour. Right? Now, how do you do it? So first step is to calculate how many ml per hour. That is the first step. Break it down to that. Then normal drops is 15 drops in that normal vac. And if you know the micro drop, do you know the micro drop PDA drip? It is 60 micro drops. You know this already? You knew that, right? You didn't know that? 60 micro drops is 1 ml and 15 drops of our normal drip rate. That everybody knew. Then, so the drip rate per hour equals the micro drops per minute because this is equal. So now if I had to give 100 ml per hour, I have to give 100 micro drops. Yes or no? Is everybody with me? Yes or no? Awake? Right. So 100 ml per hour is 100 micro drops per minute. So divide by 4 and you get the adult drip rate. Finished. Because that was the conversion I taught you. So go that way. 25 drops. So this is what you have to write. There on the fluid, how do you calculate? So 3.5 liters, suppose I give you another challenge. 3.5 liters is 3600 ml in 24 hours for sake, which is 150 micro drops. Divide by 4, 37.5, 35 drops per minute. Or make it more easy. How many 5-second groups are there in a minute? 12. Approximately 3 drops every 5 seconds. Did you understand this or not? Okay. So that's not given in books anywhere. Okay. So we just go ahead. Oops, sorry. This is just going on the loop. Oh, this has got stuck. What has happened? Yeah. Again, start presentation, is it? From the next one. So last few slides, sir, just to finish. So fluid therapy do not chase the urinary output. A higher previous 24 output could be due to excessive fluid in the previous day. For trauma, this is scenario B, 60 kg young male patient with profound hypovolemic shock due to blunt chest and abdominal injury in a road traffic accident. In the first instance, you start crystalloids and colloid volume expanders and then arrange blood and start it as soon as the bleeding is controlled or we manage the outgoing loss. Dextrosaline in India is different from the dextrose. So I told you the dextrosaline actually, what we get in India is 5% dextrose plus 0.9% saline in one bottle. So is it isotonic or hypertonic? It is a hypertonic solution. It has got 600 milliosmoles, not 300 milliosmoles. All right. So this is the teaching for you. It should be known that we should not give dextrosaline in India. Is not a good fluid. You may give one off in an emergency, but if you have to give it separately. What is the role of 5% dextrose in daily ration? The answer you say is calories. I asked somebody calories in 5% dextrose. Yeah, you were there, ma'am? Who did I ask? 5% dextrose. So if you give 4 wax, 100 in 1 times 4, 400 kilocalories. It's not for calories. What is the reason you give it for? You give it for the obligate aerobic cells, which is brain, RBCs, WBCs, and the renal medulla, so that they don't go into anaerobic glycolysis. And in burn patients, critical level of shock is defined as more than 15% of body surface area in adults and more than 10% in children. So we use the Parkland formula for the first 24 to 48 hours, 4 times the body weight times the percentage of burns. So half of the volume is given in the first 8 hours and the remaining volume is given in the next 16 hours. And when does the time start? From the burn time, not from the time of arrival in the hospital. All right. So that is the example for you. And the other formula is the Muir and Barclay formula, which is using human albumin, which is difficult to get. And then because we are getting, yes, I'm just finishing, sir. Because the volume is less, you give only half an ml times the body weight times the percentage of burns. And this amount which you get is given over these rations. So if you divide it into 12, 12, 12, then 3 times in the 4 hourly in the first 12 hours, 2 times in 6 hourly in the next 12 hours, and then once only in the 12 hours, that is the third 12 hours, that is over 36 hours. You give this ration over a period of time. So the slide to show you, the single slide to show you how the fluid moves and how edema forms. The fluid moves out from the arteriolar end because of the increased hydrostatic pressure and comes back inside because of the colloid oncotic pressure. And if there is a mismatch because of plasma protein deficiency or because of high pressures, because of DVT or congestive heart failure or because of sepsis, then there will be edema and tissue fluid will be formed. So we'll skip all this. And just important one to show, potassium and acid-base balance in hypokalemia. For every 3 potassium which comes out from the intracellular compartment, 1 hydrogen ion and 2 sodium goes inside, causing an extracellular alkalosis and an intracellular acidosis. So we'll skip on this also for sake of time. And thank everybody for this invitation. Sorry for exceeding time.
Thank you, Dr. Pavan. Basically, going back to the basics, and it's a very important, topic from the students' point of view. Many times we take this for granted. It is left to the interns to write the thing, and obviously we don't pay much attention to it. So thanks for the lecture. Any other questions that you have? We are running short of time, so any questions? Oh.
Thank you, sir,
Okay,
for
thank
that
you.
enriching session. May I request Dr. Inian Samarasan to felicitate the speaker, Dr. Pavanendra Lal. And Dr. Suresh Kumar. I request Director Professor Dr. Pavanendra Lal and Professor Dr. Vishnu Prasad to kindly remain on stage for the next session.
Now we have Dr. Shivraj and Dr. Nikhil, final year postgraduates from JIPMER, presenting a case of liver mass. I invite the examiners for the session, Director Professor Dr. Pavanendra Lal, Professor Dr. Vishnu Prasad, Dr. Debasis Nayak, and Dr. Shaktivel to the dais.
There will be no formal tea break. So you can proceed for tea as the session is happening. Thank you.
Good.
Hello. Sheik. Hello.
Good morning, everyone. I'm Dr. Suvraj and my friend Dr. Nikhil are here to present a clinical case on right hypochondrial mass. So we have a case of 47-year-old gentleman, daily wage laborer by occupation, belonging to lower middle class according to modified Kupusamy socioeconomic scale, hailing from Kodalur, presented with complaints of abdominal pain for 1 month. The patient was apparently well 1 month back when he started experiencing abdominal pain. It was more so in right upper abdomen, dull aching type, continuous, mild to moderate in severity, non-radiating, with no aggravating or relieving factors, and no association with food intake. He also complains of loss of weight, which was unquantified, and loss of appetite. He had no history of fever, no history of yellowish discoloration of eyes, hematemesis, or abdominal distension. There was no history of vomiting. The next slide. Early satiety or ball rolling movements. He had no history of podrectal bleeding or melena. Past history. He had a history of jaundice. He noticed yellowish discoloration of eyes himself, but it was not associated with fever or clay-colored stool. That was 1 year back, for which he had taken local medications, after which it was resolved in a month. He had no past history of upper abdominal pain that was radiating to back or epigastric burning sensation. He has no known comorbidities. He hasn't had any hospitalizations or surgeries in the past. No history of any cancer in family members. He takes mixed diet with normal sleep pattern. He is alcohol consumer for last 30 years, with last beans 10 days back. He consumed 300 to 500 ml of local alcohol daily. He also gives history of smoking for last 30 years, about 10 cigarettes in a day, with pack year of 15. Treatment history. For the complaints, he had gone to his local hospital where he had taken over-the-counter analgesics, but the symptoms did not subside, so he came to JIPMER. Here he has undergone imaging and blood investigations. Summary of my case: 47-year-old gentleman with no comorbidities, habituated to alcohol for last 30 years, with dull aching right upper abdominal pain for 1 month, associated with loss of weight and loss of appetite, with no history of vomiting or jaundice, but has a past history of jaundice.
Okay. Yeah. So what do you make of it? What is your impression? You have to commit yourself. What is
Yes.
your impression at the end of history with the information that you have just provided? What is your differential diagnosis at the end of history? Then we'll go back to the details.
Yes, sir.
Let's put your money on the diagnosis.
With the history, the pathology is confined to right upper abdomen, sir. Mostly liver or gallbladder. It could be either malignant or benign in etiology. Malignancy pointers are age of the patient 47
So,
years.
no, just we don't just put your differential. So 1, 2 like that. 1, 2, 3. Possibility of this.
Primary
Number 1, what would you like to put?
liver malignancy, sir.
Liver malignancy.
Yes.
Okay. Number 2.
2 GB malignancy.
GB malignancy.
Oh.
Now, so why liver malignancy? Why both are malignancies?
Yes, sir.
Both are malignancies, liver malignancy and GB malignancy. So the common in your differential is malignancy.
Yes.
Right? Now, why do you say malignancy in this and not benign? 1 month history.
short history, not short history with association with loss of weight and loss of appetite, sir. And also he has a long history of alcohol consumption, sir, about 30 years of alcohol consumption. And also gives history of jaundice 1 year back. So it could be like risk factor for liver malignancy, sir.
So normally malignancies are painful or painless?
Painless, sir.
So now your first symptom, if you go back now, you go back to your first slide. Your most important complaint is abdominal pain. Do you think this is actually abdominal pain?
Could be abdomen.
Could you classify this as actually as pain? Because that is where we are getting stuck.
Could be abdominal.
If it is 1 month pain, then what would be the cause of a painful lesion in the right upper abdomen for 1 month duration? Normally, if a person says I've got pain in the right upper abdomen for 1 month, what will be the differential? Will the differential ever be malignancy?
No. Cholecystitis, like infected cause.
Cholecystitis, yes. What else?
Hepatitis.
Hepatitis. Anything else? Surgical?
Biliary colic, sir.
Like biliary colic, okay. So why these are not your differentials in this particular case with this particular particular slide? Because you see the past history, when you finish your present history, the diagnosis is over. The past history will contribute only 10% to your present diagnosis. So when you come to the end of your history of present illness, your case is actually over. Very rarely we will reflect on a past history to make your present diagnosis. Like past history of tuberculosis, repeated attacks and things like that. Majority of the times your diagnosis will be over by the end of your HOPI, history of present illness. So with this particular one, why you are putting a diagnosis of malignancy first and not a benign condition? As you are saying, benign causes pain.
Loss of weight and loss of appetite, like not quantified, but still loss of weight and loss of appetite would point towards the malignancy.
Oh, that's not very strong, no?
And the characteristic of pain also constant aching, like continuous constant pain. So if it was benign pathology, then
this is exactly what I'm trying to tell you. What is pain of biliary colic?
Intermittent type of pain, sir.
No, what is the pain of biliary colic? Yeah, okay, describe that pain. Pain of stone disease of the gallbladder or biliary area. What is the pain? How do you define that pain and say this pain is actually biliary colic?
Pain confined to the right hypochondrium, which is in intermittent and moderate in intensity, sir.
It is the colic. Is it a colic?
No, it's a misnomer, sir.
No, it's not a misnomer. It waxes and wanes. Why did you say it's a misnomer?
So,
which colic is a misnomer? A renal colic or a biliary colic?
Biliary colic.
It's the other way around. Renal colic is a misnomer because there is no muscle in the pelvis, but there is muscle in the gallbladder. Is the biliary colic coming from the gallbladder or from the biliary extrabiliary tree?
Gallbladder.
Gallbladder. Gallbladder is a muscular organ. It's trying to push, and that gives you the pain, and then the inflammation begins. Now imagine that kind of a pain, acute severe pain, and then if you do the pain score, then that pain score is pretty high. Versus this pain which you're talking about is a dull, aching, constant discomfort. That is where you're getting stuck. This is actually a painless situation, but a discomfort. So I would personally say, I don't know what my colleagues think, could be a dull, aching discomfort over 1 year. I would not put pain
as complaint.
As a factor.
No, why our Shivraj is telling biliary colic as misnomer, because we have taught them the colic which occurs in the urinary stones is more often intermittent in nature, occurs very frequently. So that's why it is colic in nature, and biliary pain, it lasts longer Hence, we have taught in the classroom as misnomer. So he's quoting the same. It is not his mistake. Okay.
Misnomer is a legal point.
Yes.
There's no point. Here, there is actually a pain. It goes, comes. That's why the biliary colic is the pain which lasts for less than 24 hours. As soon as it crosses 24 hours, it becomes acute cholecystitis.
Yes.
Anything less than 24 hours, we will be putting it as biliary colic. We can still, operate the patient like an elective patient. But if the patient has pain beyond 24 hours, then we will suspect acute cholecystitis and provide everything according to.
Yes.
Here, I am trying to ask my colleagues whether they are happy to say a discomfort rather than pain, because with this pain, you are getting stuck with your differential. If you had put discomfort and not actually a pain, patient perceives it as pain, but if you see a problem, it's a dull aching because of a stretching of a Gleason's capsule over a period of time. So it's not a pain of a biliary colic, not pain of a liver abscess, the way it causes pain. Those are the things which happen on the right upper abdomen.
Yes.
So similar patient, if he comes to OPD, immediately will not be able to make a diagnosis of malignancy.
Yes.
Usually, say probably is having a gallbladder stone or something and send for an ultrasound. Here probably biased because you know the case. So this happens. So in the examination, it is better not to know the case when you are going for it. Better to avoid any clues from the your colleagues and other things. Your mind will be clear.
Yes.
If you know the diagnosis, then the problem usually occurs. So better to avoid taking clues, seeing the patient before going to examination is far better than already having a bias.
Yes.
Right? So whatever you have written, it indicates based on what you have written there, pain, a short duration, weight loss, and history of jaundice. So there is some clue that it is pointing towards malignancy. I agree, but your way of defending has to be different. That's what the professor is trying to cover.
Yes.
It becomes a painless problem. Typically,
yes.
So you will have no problem in defending the differential that you give.
So especially in this patient who's having not a very clear symptomatology, presenting only with the pain abdomen. So, I mean, maybe you will be biased based upon your examination finding that it's more like a mass or a malignant. But you should define more, because after the history, we want you to critically analyze the history and come out with a differential diagnosis. So what we are going to expect as an examiner is how are you interpreting the history, how your thought process goes in analyzing. Or for example, this patient has a past history of jaundice. It could be a jaundice because of a passed out stone. So when you summarize the history, you told straight away it could be either a gallbladder mass or a liver mass. So instead, your thought process should be only on the history. You can't confine or narrow yourself to those only two particular diagnoses. Instead, like Sar said, you should think about other features. Like you said, hepatitis, and it can be most common is biliary colic or acute cholecystitis. So you should be able to bring out the clinical symptoms and negative history factors related to that in your history. And other thing, in the history, you asked about history of jaundice, but the patient didn't have fever and clay-colored stools. So why exactly you asked about that?
To know what kind of jaundice he had at that time, sir. Was it hepatocellular or obstructive, or if he had any episodes of cholangitis? So
how do you make out hepatocellular jaundice based on history?
Hepatocellular jaundice without any urine color will be dark, sir. But stool color will be normal. But in obstructive jaundice, they'll have.
So by hepatocellular jaundice, what do you mean exactly?
Arising from the hepatocyte, pathology in the
what
hepatocyte.
Exactly is the etiology, most common etiology?
Sorry, sir.
So what is it due to? The medical jaundice, what is it due to? What is the etiology? What is the cause for it most commonly?
Due to the disruption in hepatocytes.
Yeah, so it's something due to viral hepatitis or something like that. What is the most common?
Viral hepatitis.
Yeah, so history-wise, you should try to elicit it, whether the patient had some prodrome, followed by jaundice, and how was the cause of the jaundice. So whether you're able to make out the difference between a medical jaundice and a surgical jaundice. And after that, if it is a surgical jaundice, then you can bring about whether it's a painless jaundice, painful jaundice. So you should elaborate more on the jaundice history also.
Yes.
And jaundice resolved in a period of 1 month. So what do you think it could?
Although he did not have any episodes of prodromal symptoms, sir, but it could still be hepatitis, sir. The natural course of hepatitis will be like with 4 to 6 weeks, it will resolve on its own. So maybe because of hepatitis, it would have settled.
Could be one possibility, but you said the patient is a chronic alcoholic for around 30 years.
Yes, sir.
So could it be something related to that? So instead of just confining yourself to one particular, so based on whatever points you got in the history, try to include that. So 30-year chronic alcoholic.
Yes.
So definitely he might have had some decompensation. He might have had a chronic liver disease. He would have had a decompensation because of which he would have some jaundice. After that, he would have compensated again. So jaundice would have resolved. So that could have been another possibility also. So like that, you think
Yes.
wide based on history and give a broad differential diagnosis based on the history.
Next slide.
Here actually, I took this history retrospectively, sir. After examining the patient, we could feel like the liver mass, sir. So whether it was primary or
We know it, but then once it comes in the history, you defend it as a history component. Don't say that you've done it in retrospective.
yes, sir.
So if otherwise also you have said that, what were you looking for? For the rectal bleed and bleed.
Like any malignancy in colorectum, sir.
So what could be there in the right upper abdomen which can lead to a bleeding per rectum? That's what we're trying to ask. So
Yes,
that's
sir.
what my colleague was trying to say. We keep your options open in the history stage. At the history stage, you don't have anything. I've not even seen him, not put my hand on it. So you can be very wide, but depending on the findings that you have given, include them. So just defend it. That's what he's saying. You're trying to rule out
Another
colonic
prime
cause. Number one, a colonic cause.
Yes.
What else could be there in view of his history of alcoholism for so many years? What could be the cause of melena?
gastric carcinoma could be there, sir.
Why are you stuck with carcinoma? What else could it be there? Long standings, shrunken liver,
Cirrhosis, like
cirrhosis,
decompensated varices, sir.
Yeah, so that is how. I mean, I don't know why we are thinking how you are going to. You should be able to say that I asked for rectal bleed for a mass which could be coming from a colonic lesion. Hepatic flexure is also here. Right side of the transverse colon, ascending colon, right hepatic flexure, gallbladder, liver, extrahepatic biliary tree, kidney. Everything is here in the right upper abdomen. Now the question is, you need to come to narrow it down. So you're trying to rule it out. Is there any bleeding in the urine? So kidney is out. Is there any bleed in the colon, in the rectum? So the bowel is out. Any bleeding, mucus or pus discharge or any alteration of bowel habits? So that did not come out here because your differential, you got fixated to something else. And then everything is evolving that, and the examiners easily come to know that you are working from a diagnosis. What Professor Vishnu said, that your everything then gets localized to one diagnosis. So keep yourself open, and all of you, when doing the cases in the ward, when you're doing your long case, please ask your resident, do not tell me the diagnosis, because it is a natural human tendency to get focused. You can't help it. That's the way the brain works. You always try to focus it to the area, and other areas get blanked out. Whereas when you are inquisitive, that inquisitiveness in the history comes. Is it this? Could it be that? Could it be that? Could it be that? You are searching. That searching component comes in the history. So you have to be, try to rule out all these things like that. Sir, I ruled out kidney, I ruled out colon, I ruled out extrahepatic biliary tree. I'm now left with only liver. Like that.
Yes.
Next, come to the past history of
I would like to take on the examination part. It was examined after taking informed verbal consent in a well-lit room. General examination, it was comfortable, oriented, afebrile, and ambulant. It was well-built and nourished with BMI of 21 and ECOG performance status of 1. No pallor, icterus, generalized lymphadenopathy or edema. There were no signs of liver cell failure. Blood pressure was 107 by 90 mmHg in the right arm, measured in sitting position. Pulse rate was 78 beats per minute. Regular rhythm, good volume measured in the right radial artery. Coming to abdominal examination, inspection wise, abdomen was flat, flanks were free, umbilicus was situated in the normal position, inverted. All quadrants of the abdomen were moving equally with respiration. No visible fullness was noted elsewhere. And then no visible pulsation, dilated veins or scratch marks noted in the abdomen. Hernial orifices were intact. Spinal renal angle were normal, and external genitalia was found to be normal. Palpation wise, abdomen is soft, no areas of local warmth or tenderness, and lower part of the liver was palpable, 3 centimeter below right costal margin in the midclavicular line, moving with respiration, hard in consistency, nodular surface, irregular round border, and non-tender. Unable to insert the fingers into the right subcostal space. GB was not palpable, spleen was not palpable, and no other masses were palpable elsewhere. Spine and renal angle were normal. Coming to percussion, superior part of the liver dullness felt at the right fifth intercostal space with liver span of 14 centimeter along the midclavicular line. No shifting dullness was noted. Auscultation, normal bowel sounds were heard. And coming to digital rectal examination, no mass at deposits noted, normal stool staining. Coming to like rest of the systemic examination, RS normal vesicular bed sounds were heard, no added sounds. And then CVS normal S1 and S2 and no murmurs were there. Summary wise, like when combining both history and examination wise, 47-year-old gentleman, chronic alcoholic with no comorbidities, with right upper abdominal pain for 1 month and palpable non-tender hard nodular liver. My provisional diagnosis would be suspecting liver malignancy in a 47-year-old gentleman. Coming down to differential diagnosis, could be HCC, could be liver secondaries.
In the inspection, you couldn't see the mass. You written no mass visible.
No abdominal. Yes, sir. No abdominal fullness was noted as such. On inspection wise, only on palpation wise, we could palpate the mass.
Exactly did you look for the signs of liver cell failure?
Sorry, sir.
How exactly do you look for the signs of liver cell failure?
Signs of liver cell failure, like palmar erythema, gynecomastia, testicular atrophy, any dilated veins in the abdomen, any enlarged parotid, temporal hollowness, air loss, like these words, and flapping tremors.
When you say all these signs and questions comes like this, better to group it into a head to toe,
Head to toe.
so that either group into that or group into what is the most commonly seen. Like signs of liver cell failure, when you say most important which you see is the hepatic encephalopathy.
Yes.
You check for the sensorium, check for astral cells, flap tremors, so those things. So instead of starting it straight away from palmar erythema, which you not see in every patient. So try to group it into most common or head to toe so that you go in an order.
Yes.
And why do you say for check for signs of liver cell failure?
Like he's a chronic alcoholic, sir, history wise. So he might be having decompensated chronic liver disease. So that will manifest as that.
No.
Yeah.
Why did you say you put your money on malignancy of the liver? Then you have to put it one way or other. You put it on both. It could be benign, it could be malignant. Like that, you have said it could be primary, it could be secondary.
Like that is a differential diagnosis, sir. Like yes, sir. Yes, sir. On clinical examination wise, like in the abdomen, there is no RIF mass, like colonic pathology can be there with liver metastasis, or no epigastric mass, like CA stomach with liver mets. Like abdomen wise, there is no RIF mass, and then history wise also like there was no altered bowel habits. So rectal exam, yes, sir. Sorry, sir. Yes, sir. Distal rectal examination I had done, sir. Like no mass deposits were noted and normal stools. Well, rectal tone and like if there's any presence of clay colored stools or melina. Yes, sir. No, sir. Like normal stools. Yes. Yes, sir.
So it is by exclusion that you put secondaries. There is nothing on the palpation. Go to the palpation of the liver.
Like
see this, what I'm trying to say is again in the history of present illness was your most important point that needed elaboration. Similarly here, liver is your only finding. You need to be elaborating it very clearly. What is the span? Would have appreciated a diagram. If you are taking a long case and a copy has been given to you, you should be able to draw it also there so that the examiner can match it with what findings he sees. And you said 3 centimeters below all along. That means from the Xiphi sternum right across to the anterior axillary line, there is a 3 centimeter of a liver which is palpable. That is what I understand. Maybe mainly in the mid-clavicular line.
Yes, sir.
3 centimeters maximum in the mid-clavicular line. But then, is it uniformly hard? Is there multinodularity? Is there any umbilication in the nodularity?
No umbilication was
If-
found.
So I'm just trying to say, so this needed to be expanded to defend. How does a hepatocellular carcinoma look like? It's a single large mass. It's a single large thing. It's not coming out. Nodular, multiple nodularity could be metastatic. It could also be macronodular
cirrhosis.
Liver. We don't know. So you need to define how it is looking. Hard inconsistency, rounded borders, you said. Is it all along that? So it was the 3 centimeter thing vertically was there, but how broad it is it looking like a single nodule and you are able to feel some part of normal liver on one side and some part of the normal, or the entire palpated width of the liver? All that is missing in this.
So based on your clinical examination, is it a liver mass or a diffusely enlarged liver that you got?
It looks more like a liver mass only, sir.
But the way you described is more like a hepatomegaly. It's not like a.
That is why how I am imagining it you are feeling it, but it's not getting translated in the way you expressed it.
So how does it correlate? Because if suppose in a clinical scenario, in a patient with a chronic liver disease who's having a shrunken liver, in which the liver is not going to be palpable.
Yes, sir.
So when the liver will be palpable in this set of patients? If you suddenly get a palpable liver in this patient with a massive enlarging liver, so what happens at that stage?
Nodular change, sir.
No, nodular change, fine. But anything else? Anything more severe than that? In a cirrhotic liver, if the liver suddenly gets getting enlarged,
Decompensation.
so it's a malignant transformation. So that's another thing. Another thing. So clinical. Did you put your stent in the liver?
Yes, sir. Like no audible bruit was heard in that.
Particularly mentioned.
Yes, sir.
Unless you mention it, we take it for granted that's not examined.
Yes.
So why do you check for that?
Yes, sir.
And the other thing is, you said in palpation spleen was not palpable. So because right now, based on the history and examination finding, we got like a CLD picture. So you should also see whether the spleen is enlarged based on your percussion finding. So
Trop
you have to
space.
percuss for spleen also. So how do
Yep.
you know how to do that?
Yes, like percussion, the trop space.
Yeah, so drop space, you should know all those things. And that also has to be mentioned to make sure that you look for all signs of portal hypertension. Based on your history and examination, can you summarize your history and examination together and put a differential diagnosis so that we can go?
Like 47-year-old gentleman, chronic alcoholic with no comorbidities, with right upper abdominal pain for 1 month and with palpable non-tender or nodular liver. My primary diagnosis will be liver malignancy, like could be hepatocellular carcinoma, because like chronic alcoholic could have underlying cirrhosis and he had history of jaundice also. That could explain that the patient would have had hepatitis. We know that like hepatitis and chronic alcoholic are risk factors for hepatocellular carcinoma. And then against secondaries, like on examination wise, I couldn't palpate any other mass, and also like there was no history suggestive of.
Please say that you would like to keep secondaries as a second
Yes, sir.
possibility, but we are primarily thinking in terms of a primary hepatocellular malignancy. That's the way we'll proceed. So you work up, how would you work up this patient?
I would like to do ultrasound first, sir. Mainly to look for the mass, to look for any dilated biliary radicals, and also like to look for GB, pancreas, and to look for any secondaries that is there in the abdomen. That also we need to rule out specifically. Ultrasound we had done for this patient. Liver was normal in size, appears heterogeneous evidence of multiple isoechoic lesions with hypoechoic rim with internal vascularity noted diffusely scattered in both lobes of the liver, right more than the left, and no IHPD was noted. GB was partially distended, but there was no calculus or no sludge, and pancreas was normal, so no free fluid abdomen was noted.
Do next.
With that, I would like to do blood investigation, sir, like to do.
Suggestive of. What is the ultrasound finding? Suggestive of.
First thing is like.
Ultrasound?
So one thing is Doppler we can see for the portal vein flow and like vascular involvement. Other than that,
So when there's multiple lesions in the liver,
yes, sir.
what are the two things which is in your mind? So what are the things which is coming in your mind?
One is can be liver secondaries. We can like hypoechoic rim, multiple isoechoic lesions are noted.
Then?
Multifocal HCC can also be another possibility, like involving bilateral lobes.
Anything benign?
Nodular cirrhosis can be like macronodular cirrhosis.
Some cystic lesions in the liver? Biliary cyst adenoma. So apart from that, they've not commented anything on the spleen, on the portal vein, especially in this patient.
Yes,
Who has the, so that also has to be taken.
Yeah, you like to look for free fluid. You like to look for spleen, splenial portal axis, and lesions elsewhere, lymphadenopathy elsewhere, if any, noted. So there's a lot of information that can be given. If it is not there, at least you should say that I'll look for all these things. So based on this, what is your next step? You said blood investigations.
Yes, like
Yes.
Yes, sir.
Which bloods would you do?
First thing is I would like to go ahead with liver function test, along with my primary diagnosis is a liver function test.
The liver function test. Stop. How will the liver function test help you in reaching the diagnosis? Patient is not jaundice clinically.
Yes.
Patient is not having any, should not have, has enough normal liver. Patient has no signs of liver failure. What do you expect? Even if the OTPT is raised.
Not like.
So one is baseline investigation. You will
investigation.
do all baseline investigations. What will you do to clinch the diagnosis?
AFP, AFP, alpha fetoprotein can be done if it's elevated, like that can point towards HCC.
Is this going towards a primary or a secondary? Based on this report.
Yes, sir. Ultrasound wise.
These reports in the clinical exam will be just given hypothetically by the examiner. Okay, if the ultrasound report shows a single large lesion, what do you do? If the ultrasound shows this, what will you do? This is how we talk, just to give you a scenario. So you have given the scenario yourself. So what is this going towards?
This is going towards secondaries, sir. Actually, we want to do CCT to
So when
confirm
you are
that.
going towards, just see how you are building your case. You are going towards secondaries, then you are saying, I want to do alpha fetoprotein. How does that help your cause? So what would you like to, just rethink the whole strategy. Okay. You would need to do some bloods. You will need to do something to look for the primary within the abdomen. So from that angle, you have comprehensive answer.
Yes, sir.
Next
Next,
is to like how Sir saying is first you can say like a baseline investigation, and depending upon your case to clinch your diagnosis. Like for example, in this case, you need to do a liver function test. So why you are doing the liver function test? I want to see the synthetic functions by seeing the albumin level, by seeing the INR. I want to see the excretory function of the liver by seeing the bilirubin, and I want to see the tumor markers, serum AFP, PIVCA. So like that, case oriented. So to clinch the diagnosis, first baseline. Basically need to know the counts because platelet count you have to see whether portal hypertension is there or not. And renal function, because next year investigation is going to be a CT examination.
Yeah,
so you have to see the renal functions. So like that you explain your investigations and go ahead for that.
Will you do a CA 99 in this?
Definitely, sir. We would do, sir.
We will do.
CA 99 or CA?
C.
Or both?
What's you're considering the secondaries, na?
Secondaries, sir.
CA is better, CA 99 better.
CA for primary, but like I'd like to first see in CT, sir. If there is any primary, then I'd like to think for the CA for the primary in colon. We'd like to do, sir. For any C. Sir, CA to look for any like primary in the colorectum, it will be elevated, sir. Or in the biliary pathology also, CA and CA 199 will be elevated. We would do both. Sir.
Area for both.
Yes, sir.
I tell you CA 99 is 5,000. CA is 100. CA 99 is 5,000.
Something that is coming from biliary epithelium, sir.
Biliary, where is it biliary?
Because CA 199 is elevated and CA 199 is secreted from biliary duct epithelium.
Like then the question will go now to what are the conditions in which CA 99 is replaced. So avoid saying this kind of very pathological answers instead.
The marker for CA pancreas.
CA 199.
How does that get elevated in CA body of the pancreas? It be elevated in CA body of the pancreas?
Yes.
Yes or no?
Yes, sir.
So don't get into the mechanism. So I'm just trying to tell you that this is how you're going to say you do tumor markers and do baseline investigation, and I will do some endoscopic investigation. Would you like to do an upper GI endoscopy?
Yes, sir.
So why would you like to do an upper GI endoscopy?
To look for any looks like a metastasis, sir. To look for any primary in gastrointestinal, like upper GI malignancy will also metastasize into liver. Or that's yes, sir.
Primary source, primary in the stomach. It's not a very important differential, even in the absence of melena and anything. And then a CT.
Yes.
What does the CT show?
Patient is having an EGFR of 55. Will you go ahead with CT?
55, sir. No.
Enough to just calculate the urea and creatinine. So you should calculate the EGFR. And how much should be the normal EGFR?
More than that.
So you should know all these things because these are all the part of the clinical workup. So only if the patient is a normal GFR, you're going to give a triple phase contrast CT because it's a high dose of contrast. So anything marginal and below marginal, you should know what you anticipate. What is the risk of contrast-induced renal failure in these patients? So below this much, I won't do CECT at all. This range, I'll do with some precautions by consulting with my nephrologist. So this part you should know. And after that only you should go for contrast.
Yes, sir. creatinine clearance below 30. Yes. So yes.
So what's the CT showing?
Yes, arterial phase CT, sir, showing big hyperenhancing lesion occupying most of the right lobe of liver, sir. And there are few hyperenhancing lesion in the left lobe of liver also. So next is the venous phase, venoportal phase.
I'm just curious why the plain phase is not given an input. I mean, that's also important, right?
Yes,
To see the plain phase.
Yes.
So what are the things you look for in the plain phase CT?
Plain, any metastasis into the lungs, sir. Free fluid abdomen.
Abdomen CT.
Free fluid abdomen. In the venous phase, there is a washout of the enhancement that is seen in the arterial phase, and also the lesions that were there in the left lobe also shows washouts. Tumor is occupying most of the right lobe of liver with multiple nodules in the left lobe also. Tumor markers in this case was AFP was 45.8, CA 5.1, CA 199, 184.9. ALP was elevated 353, otherwise AST was 79, otherwise LFT was normal. INR actually was 1.09. Upper GI endoscopy was also done for this patient, which did not show any varices, did not show any other primary.
CT, what is the appearance of the liver? So what is the extent of the tumor?
Tumor is extending from, like it is occupying whole of the right lobe of liver and also some left lobe also, sir. Basically all of 4 segment and 5, 6, 7, 8, all the segments are involved, sir.
So is it a liver malignancy or a secondary, or what is it? Or is it an abscess, or what is it?
CT wise, it looks like primary malignancies are
Why do you
hepatocellular.
say so?
Because arterial hyperenhancement with portal washout is there. Even though in the smaller nodules also there is arterial enhancement with washout, sir. So we think it is hepatocellular carcinoma, and also AFP is 45.8. Although it is not diagnostic of hepatocellular carcinoma, but still it is elevated.
Why are you seeing lesions on the left side?
Left side of the liver, sir. There are 2 to 3 hyperenhancing lesions in the segment 2 and 3 of the liver, sir. Multifocal, multifocal HCC, sir. One set nodules also, sir. Yes.
Like it's a primary, that's the second. What's the next step? This take time to this faster.
Yes. So with all this workup, it looks like hepatocellular carcinoma involving both the lobes of the liver, sir. AFP is not in favor, like AFP is elevated, but it's not diagnostic. It should be more than 200 to say that it is diagnostic of HCC. So still, in 60% of patients only AFP is elevated in cases of HCC, sir. So it could be false positive cases are also there. So it could be.
Is there any other marker which can be very sensitive for HCC?
Here it's not there, sir. It's not available here, but we can do PBIK.
PBIK is not available here.
Any other reason for AFP level low? It indicates vessel involvement, a rise in AFP. Usually, if there is a vascular involvement, AFP is significantly less.
Yes.
but sometimes may not be right. Okay. Then what next? What would you like to do?
Now, it looks like hepatocellular carcinoma according to CT, sir. So BCLC class will be C, sir, like advanced stage. So would like to go ahead with
What is his performance status?
performance status is 0/1, sir. And liver function parameters are also normal. CTP child A, sir.
Do you like to do any other investigation? Do you like to do a PET scan?
PET scan is not indicated in hepatocellular carcinoma, sir.
You see such a big lesion involving mainly one lobe, but other small lesion at the other lobe.
It shows that if uptake is there, then it shows that the tumor is poorly differentiated. Otherwise, the role of PET-CT.
So actually, you can't say that PET doesn't have any role. So, but you should go into the literature and see what exactly is the role of PET. So you should see how much percentage is PET avid, and if PET is avid, whether it is a biologically aggressive tumor or non-aggressive tumor. Based on the PET features, how is the treatment is being changed now? So it's still not like PET is not doesn't have any role in it. It has a role. So you should be able to list those points. So you should do some homework on this.
There is a role for PET scan, right? Because especially with the advent of newer modality of therapy using the downstaging modality, using the combination of TARE with the stereotactic body radiation and immunotherapy, then what we can bring down the size of the tumor, right? It's possible nowadays, right? Because before that, you should rule out the systemic metastasis, right? If you want to try newer therapies. It is there in the, if you look into the newer staging, which is BCLS 8. So it says it is there in the ABC. So if you look at the flow chart, it is given, right? There's a role for the new modalities of treatment. So what do you do in your setup now?
Sorafenib, sir.
No role for taste.
Multiple lesion, both the lobes of liver are involved. So
why taste is not possible? Patient is in child state.
Child A, sir.
Why it's not possible?
Like vascular involvement was also there in this patient, sir. There was left portal vein thrombosis also in this patient on CTOS.
There?
Yes, sir. There was left portal vein thrombosis. Sorry, right portal vein thrombosis, not left. Yes, sir.
Can you show that CT again? The venous space.
Will you do a biopsy in this patient?
No, sir.
Because he's not raised. So you want to confirm by a biopsy?
We don't do biopsy in cases of hepatocellular carcinoma, sir. Like usually,
actually, this is not a state.
The thing is that. So how do you have to defend your examiner is you should say that for HCC diagnosis, the clinical characteristic imaging features is enough for the diagnosis. But if you want to do a biopsy, there is a 2% risk off. So you should give the numbers by evidence. The guidelines say.
Why the biopsy?
because of tumor seeding.
0.4% risk of bleeding and 1.3 to 3.6% of seedling is there, sir. So if there is clear-cut hyperenhancement, enhancing lesion with portal washout in CT with diagnostic AFP raised.
Characteristic. Biopsy.
Will you list this patient for liver transplant? Because you can't do a resection because the tumor is everywhere. So, and it's going to the tumor thrombus, I mean, portal vein also. So is liver transplant an option for this patient?
No, sir. BCLC-C, we don't usually do liver transplantations.
Multiple lesions, sir. Size is also more. If we take Milan criteria, sir, more than 3 lesion of more than 3 centimeter size. So the single lesion that was present in right lobe of liver was around 10 cross 15 centimeters. If abstinence, if he is willing to stop.
One last question. Suppose if this patient has a 5 centimeter lesion occupying only segment 5 and 6, no evidence of chronic liver disease, and no evidence of portal hypertension. Liver functions are normal. AFP is highly elevated with contrast and washout. What will you do for this patient? It's in segment 5 and 6.
Resection, sir. Surgery is the best modality,
Yeah.
sir.
What surgery you will plan for?
Segment, sir.
What surgery you will plan for?
Tumor was in segment
5 and 6.
Non-anatomical.
Yeah. Right hepatectomy has to be planned, sir.
And you would have managed enough hepatectomies in your ward. So what is in the post-operative setting, what is one important complication which you want to see and you want to assess?
Liver.
And how will you pre-operatively look for the risk of that complication?
FLR should be adequate, like to prevent liver failure in the post-operative period. Like it should be 25% in the normal people, and in cirrhotics and all, it should be at least 40%.
There is a new concept in liver transplant which is coming up. No size criteria means you have to carefully evaluate that there is no vascular involvement. It has to be ruled out completely. No vascular involvement, no systemic spread by looking at a PET scan. Then you can downsize using the combination of stereotactic body radiation and a tail procedure along with immunotherapy. And then there is a, what you call the concept of palliative transplantation, where there is a available disease, liver available based entirely on the family wishes. It has been done by some of the centers in India, right? So this concept is there, look into that. Okay, thank you.
What about studies on nuclear event or SSD? You're aware of?
We'll stop here because of the lack of.
Actually, I had a doubt, sir. Like regarding this case where, like my doubt is where to draw the line. Sometimes we'll ask so many questions to the patient regarding history taking, and then examiners will be like, you have asked too many things that like you should concise your history. And sometimes, like in this case, in this scenario, I've taken so less of a history that I have to go.
No, if
like,
you don't know the case, then you will take the better history. If you know the case, you will end up.
I think that's
Yes.
in this case, you got lost out because you started with the pain. It was actually not there. So the patient start having a discomfort in the right arm and abdomen for 1 month. Then your thing would have been better.
Okay.
And then you could have gone a little bit more into the findings that you got. But you must, history is always something which we are all, the examiners will always interrogate you because they want you to know your thought process. That's it.
Yes.
Then this is just one case, but if another situation comes, you are in the clinic, is your thought process sorted out? That's what we need.
Yes.
Well done.
Thank you, sir.
Thank you, sir.
Nice presentation. And the trick is better to lead the examiners to the things you know in the exam. So that's how you have to answer. And answer the clinical based answer instead of going too much into the pathology and histological basis of it.
Thank you, sir, for the engaging discussion. I now request the examiners to award the certificate of presentation to Dr. Shivaraj. Dr. Nikhil. May I request Director Professor Dr. Pavanendra Lal to felicitate our examiner Dr. Debasis Naik. We thank the examiners for chairing the session and Dr. Shuvraj and Dr. Nikhil for their presentation. I request Dr. Shaktivel to kindly remain on stage for the next session.
Next up, we have a guest lecture on surgical management of portal hypertension by Dr. Shaktivel. We welcome sir to the dais. I invite the chairpersons for this session, Dr. Krishna Kumar Ji, Dr. Shanmugam, and Dr. Rajkumar to proceed to the dais.
Hello, check.
Volume control பண்ணுங்க.
Yeah, I'll change it. Good morning. My talk will be on surgery for portal hypertension.
Just an introduction, Dr. Shakti. So, Dr. Shaktivel has an illustrious career. He's a UG and PG student from JIPMER, completed his MCH from Stanley, went on to do his fellowship in liver transplant from King's College. And he also secured the Professor Rangbasham gold medal in MCH. So, plus he has got about 25 publications in the PubMed, all index journals, and his interest is in parenchyma preserving liver surgery. Over to you, Dr.
Thank you, sir, for the introduction. And good morning, everybody. And first of all, I thank Professor Vishnu Prasad and the JIPMER surgical team for giving me this opportunity to speak in front of the budding surgeons and the teachers. And so my talk will be on surgery for portal hypertension. It will be basically a teaching-based lecture with some limited experience, which I have encountered and I have done in the past few years. And so the agenda of today's discussion will be definition and diagnosis of portal hypertension. So what are the treatment options? Indications of surgery, what are the emergency indications, elective indications? Shunt surgery, what is the role? What is the type of shunt surgery? What is the role of devascularization surgery? What is the changing trends now, especially after the advent of IR, and the role of liver transplantation? So portal hypertension, by definition, it's a portal pressure higher than 5 millimeters of mercury. So basically, it's a clinical diagnosis. But if you want to objectively measure portal hypertension, it's done by measuring the hepatic venous pressure gradient, which is done by a right heart catheterization by cannulation in the internal jugular vein, where we measure the free hepatic vein pressure and the wedged hepatic vein pressure after inflating the balloon. And the difference between that gives the hepatic venous pressure gradient, which is actually a direct correlation with the portal pressure. So objectively, we routinely don't measure the portal pressure. It's basically a clinical diagnosis. But if you want to see the response to treatment, it's best objectively assessed by measuring the HVPG because it's an invasive way of monitoring. So these are some the cutoff beyond which specific complications of portal hypertension develops. The normal portal pressure is up to 5 millimeters of mercury. More than 10 millimeters of mercury, we call it as a clinically significant portal hypertension. And more than 12 millimeters of mercury, there is a risk of rupture of varices. of portal hypertension, it can be cirrhotic, non-cirrhotic. And again, in non-cirrhotic, it can be further classified into a hepatic cause, intrahepatic cause, and a post-hepatic cause. For your exam purpose, it's better to have a look at this table. It's in the EASL review article about the different causes of portal hypertension. So you should be able to group it into prehepatic, hepatic, again into a pre-sinusoidal, sinusoidal. So try to find the most common cause which is there. Like a prehepatic cause is EHPO, which is common there. Intrahepatic, sinusoidal, cirrhotic liver, and post-hepatic like a Budd-Chiari syndrome. So you should be able to list this, and you should be aware of this classification. Again, the classification, it's given in the Bloomgart book. So what is the natural history of portal hypertension? So basically, the portal hypertension surgery is mainly to deal with the complication. The one important complication which adds to the mortality is a variceal bleed. So it occurs in 30 to 40% in compensated cirrhotics and 2/3 of decompensated. So even if there is no varices on the first endoscopy, there is an annual incidence of new varices of around 5 to 10%. And the progression also, as the year goes on, the rate of appearance of new varices and the incidence of bleeding also is high, around 4%. So what are the clinical scenarios of variceal bleed? It can be an emergency scenario where there is an active variceal bleed, or the other clinical scenarios in which you have to manage is a pre-primary prophylaxis, which is basically before the advent of origin of new varices we are treating. Primary, after the varices, preventing the bleeding of varices, which is these two, pre-primary and primary, is basically by endoscopic and beta blockers medical treatment. But what usually is done in our management is a secondary prophylaxis. Once the patient has bled, you've done an endoscopic therapy, how you are going to prevent a rebleed. So there comes the role of surgery. So treatment option, they're both non-surgical and non-surgical are available. Non-surgical is pharmacologic agents like beta blockers, endoscopic therapy, now endoscopic variceal ligation. I don't think sclerotherapy is anymore done. And presently, TIPS and BRTO by the interventional radiologist is being done more in case of portal hypertension. Surgical, one, devascularization, shunt surgeries, and the ultimate curative treatment option will be transplantation in most of the cases. So for management of portal hypertension, the basic thing is treatment of the underlying cause of the disease. That's going to be the final end stage goal. But in the meantime, so how are you going to manage the other complications of portal hypertension? Of which one important complication which you're worried about is the variceal bleed. So now the changing trends in the management of portal hypertension, before in the beginning, it was mainly surgery, even for a variceal bleed. So I just had a chat with Professor Jagdish outside. So he was telling during his time, he used to do a lot of devascularization. But now with the advent of endoscopic treatment and IR treatment, now it's going more towards a multidisciplinary treatment. And this is one of the article published where it's clearly showing a recent change in the trend of management of portal hypertension, where the role of endoscopy is gradually coming down with the advent of combined technique like both endoscopy and IR, and along with the medical management. This is the article published in 2017. I think now the IR techniques are being more commonly done for portal hypertension. So again, indications, it can be an emergency indication for an acute variceal bleed, or an elective indication for a rescue therapy after a failure of endoscopic therapy, or a primary therapeutic modality. So emergency surgery, there are various criteria. You just basically see whether the patient becomes hemodynamically unstable by various clinical parameters based on the fall in hemoglobin, whether the patient is hemodynamically unstable, depending upon the need for blood transfusion. And elective surgery, once a patient has failed this endoscopic therapy, you can plan for an elective surgery. So absolute indication is medically or endoscopically refractive variceal hemorrhage. Severe hypersplenism, there is pancytopenia in which the platelet count is around less than 10,000. Fundal varices which are not amenable to glue injection. And other symptoms of portal hypertension like hepatoencephalopathy, hepatopulmonary syndrome, and portopulmonary hypertension. There are some relative indications like symptomatic hypersplenism, massive splenomegaly affecting the quality of life, growth retardation, especially in EHPO in children, ectopic varices, and portal biliopathy. So there are two surgical options. In elective indications, it's mostly shunt surgery. And if it's not a shuntable disease, we go for devascularization. In emergency, it's more of a devascularization surgery. Shunt surgery has also a role in emergency. And liver transplantation will be the ultimate curative treatment option. So how to select the right surgery for portal hypertension? So based on the patient's clinical hepatic functional reserve, the patency of the splenoportal venous abscess, whether the patient is a candidate for liver transplant, and based on the available surgical expertise, whether you have a good vascular surgical team along with the liver transplant expertise. So when comparing the shunt surgery in portal hypertension, in cirrhotics, surgical is usually not preferred, particularly with the advent of IR techniques. It's more of a TIPS. TIPS is the main shunt which is done for cirrhotic with the portal hypertension, which alleviates both ascites as well as variceal bleed. Always the decision has to be made between a risk of rebleed in a medically treated patient and the post-shunt encephalopathy in a patient who is shunted. So, so these are the basic shunts. So if you want to classify, it can be a non-selective shunt, which completely diverts the portal flow into systemic circulation, a partial shunt, which allows only a proportion of the blood to be shunted, selective, only a particular component to be shunted. So these are the non-selective shunts like an end-to-side portocaval shunt, side-to-side portocaval shunt, mesocaval shunt, and a PSRS, in which the shunting is not completely into the portal flow. Entire portal flow is not shunted. So it's basically, sorry, in non-selective shunt, the entire portal flow is being shunted. So this is a prototype of the non-selective shunt, which is the end-to-side portocaval shunt, which is not routinely done. It is just the portal vein is divided end, and there's an end-to-side anastomosis of the portal vein to the IVC. So other non-selective shunts, all other non-selective shunts, they maintain the portal perfusion to the liver. So basically, it reduces the intrasinusoidal pressure along with the splanchnic pressure. So thereby, it's very effective for ascites. So one of the non-selective shunts, which is routinely done for portal hypertension surgery, is PSRS, which is proximal splenorenal shunt. So for proximal splenorenal shunt, what we mean is the part of the splenic vein, which is in the splenic hilum, is actually the proximal splenic vein. So the one which is close to the splenomesenteric confluence, near the portal confluence, is the distal splenic vein. So in a proximal splenic renal shunt, we do a splenectomy. It's an essential component. And the end of the splenic vein is anastomosed to a systemic vein, which is the left renal vein. So the rationale is low rebleeding rate in a PSRS, good long-term patency, standardized procedure, removes the enlarged spleen, thereby it cures the hypersplenism, reverses growth retardation if done in children, no post-shunt encephalopathy, and effective one-time therapeutic procedure. So selective shunt, so it selectively decompresses one particular component of the portal circulation. For example, here in case of, especially for the variceal bleed, so we decrease the pressure only in the variceal, intravariceal pressure. So how it is done? So we divide the, sorry, the highlight is not working. So we divide the left gastric vein. So that way, so basically what happens is we disconnect all the tributaries to the gastroesophageal varices. So for that, first we divide the left gastric vein, followed by division of the gastroepiploic vein, and then the spleen is preserved here because the decompression of the esophageal varices is through the short gastric vein, through the spleen, and through the splenic vein into the renal vein. So it's basically a selective shunt which selectively decompresses only the varices. So this is the selective shunt called DSRS or the Warren shunt, whereas PSRS is a non-selective shunt. Okay. So another shunt which is not routinely done is basically it's an Inokachi shunt where you take one particular varix and anastomose. Like here, Inokachi shunt is basically a large dilated coronary vein. If it's a sizable vein, it's anastomosed to the side of the cava. So that way it decompresses the varix. The partial shunts are basically interposition graft of smaller size, which shunts a portion of the blood flow from the portal pressure, from the portal circulation to the systemic circulation. So another important
As I said
complication
before, portal biliopathy is basically the cholangiographic abnormalities because of the dilated collaterals which impinges on the bile duct, causing cholangitis, causing biliary colic, and causing jaundice. So these are the various cholangiographic abnormalities which can happen because of the portal cavernoma associated with EHPVO.
And you can see a dilated intrahepatic biliary radicle because of the compression of the bile duct. So these patients will ultimately need a shunt surgery, and shunt surgery most of the time relieves it. But if it doesn't relieve even after the shunt surgery, they might need a biliary bypass in the form of a hepaticojejunostomy. So some of the clinical scenarios, which is a young patient, a 31-year-old patient who came from Ooty with variceal bleed. He had investigation hypersplenism, normal liver function, and imaging showed a portal cavernoma. with a pattern splenic vein. So preoperatively in the imaging, we mainly see whether it's a sizable splenic vein. So splenic vein, the criteria, they say usually 7 mm, but most of the time, any vein which is shuntable, we see the quality of the vein, which is shuntable is being taken. The size of the renal vein is not of main concern for us because it's usually a side anastomosis on the renal vein. So we can enlarge the opening as much we want to match with the size of the splenic vein. So this is one proximal splenorenal shunt, which is done by my professor in Stanley, Professor Jaswant. The video is not coming. Sorry. It's coming. Can disconnect the Zoom? Fine, okay. I just have some 4 videos of shunt surgery so that you'll have a better. Fine. Duplicate. Share screen. Yeah, fine. Thank you. Thank you. Okay, sir. So this is a proximal splenic shunt. So you can see, I don't know whether the video is very clear. You can see that. So this is the end of the splenic vein which is being found in the and there's the diagram from the renal vein. So using a pot scissors, we are opening the. Just minutes. Right floating control. Okay. Stop it. So we revise that's the end of the splenic vein which is being cut. So there is a side biting clamp on the left renal vein. This is after splenectomy. So using the pot scissors, we open the side of the renal vein. So that's the renal vein which is being opened up. And above you can see the splenic vein being clamped. So the end of the splenic vein and the side of the left renal vein. And then we use 5-Proline switches using vascular instruments, gastro, and we do end to side continuous splenorenal shunt. So that's a proximal splenorenal shunt. So at the end of the shunt surgery, we remove the clamp on the lower pressure side first, the renal clamp first, followed by the splenic vein. So most of the patients with EHP with PSRS, they do well. And so we also measure the pressure before and after the shunt. So by cannulating the omental veins to see whether there is significant reduction. So that's the shunt after releasing the clamps. So the next patient is another 32-year-old patient who presents with hematemesis. He presented with jaundice and intermittent jaundice and pruritus. His LFT showed, his investigation showed normal. He didn't have any hypersplenism, but his LFT showed slightly deranged bilirubin. He was having on and off jaundice with pruritus. His AST and ALT was slightly high, and ALP and GGT was 232 and 338. This is the CT finding. There is a volume redistribution of the liver with the intrahepatic biliary radical dilatation. You can see the IHBRD, and you can see the portal vein is completely thrombosed with the portal cavernoma. And so you can see a large splenic vein. The spleen is not very massively enlarged, but you can see a good sizable splenic vein for the shunt surgery. So this patient, for the reason of portal biliopathy, we planned for doing a shunt. So this is, we did an interposition shunt because the length of the splenic vein, which was coming to the renal vein was not sufficient because it was under tension. Plus, the pancreas was preventing the easy positioning of the shunt onto the renal vein. So in this case, there was a paravertebral collateral which was draining into the renal vein. So we divided that. So that stump of the paravertebral collateral, we used an interposition graft to shunt the splenic vein end to the renal vein, to that paravertebral vein which was actually draining into the renal vein. So basically, a interposition graft, proximal splenorenal shunt, and obviously after splenectomy is done. So next patient, we have a 21-year-old lady, no hematemesis, with onset of jaundice and high colored urine. So she also had portal biliopathy with the deranged liver function. So unfortunately, this patient didn't have a shuntable vein. So this is a CT image which showing a intrahepatic biliary, grossly enlarged intrahepatic biliary radicals with the portal cavernoma, and she didn't have superior mesenteric vein also. So either a splenorenal shunt or mesocaval shunt was not possible, but she had a large dilated first jejunal vein. So that first jejunal vein was dilated. So this we did with Professor Biju. So what happened? This is the intraoperative video. So after so the patient didn't have a superior mesenteric vein. So this is after mobilization. So the duodenum is lifted up. So that's a cava with the left renal vein, and we have a large dilated the first jejunal vein. So we decided to decrease the shunt, the first dilated first jejunal vein to the cava with an interposition graft. So this was the shunt which was created between the first jejunal vein and the IVC. So basically, we did a jejunocaval shunt for this patient. So after shunting, we found one of the collateral, which was draining from the splenic vein, was high pressure, and this patient also had varices. So we thought we'll shunt this so that the variceal pressure also will come down. So this was the collateral which was having a significant flow. So we did that shunt of the collateral also. So that is the small collateral with a significant flow, with a good portion, and that was anastomosed to the left renal vein. So that is in brief about the non-selective shunts. So PSRS, and if the superior splenic vein is not shuntable, we try for a mesocaval shunt if the SMV is fine. If SMV is also not fine, then we have to think of makeshift shunts like what I shown, like jejunocaval shunt. So rarely in other situations like side-to-side portocaval shunt is mainly contemplated in case of a Budd-Chiari syndrome, where the patient who has not developed into a florid cirrhosis with portal hypertension, the side-to-side portocaval shunt will help to reverse the changes before progressing towards cirrhosis. So this is one side-to-side portocaval shunt. So fortunately, this patient, usually in Budd-Chiari, the caudate lobe will be massively hypertrophic, which prevents the opposition of the portal vein and the cava. But this patient didn't have such massive caudate hypertrophy. And so we isolated the IVC and the portal vein, and that did the side-to-side portocaval shunt without any interposition graft. So that is a side clamp being placed on the cava, and the yellow loop is on the portal vein. So the IVC is being divided now. That's the portal vein being divided, the side of the portal vein. So it's not easy in all cases of Budd-Chiari, because usually in Budd-Chiari, the caudate lobe will be hypertrophy. Can I take 5 more minutes? Thank you. And then once the mobilization is done, we open the cava and the portal vein, and we do a side-to-side portocaval shunt using 5-oproline. So that's a finely constructed shunt. The side-to-side portocaval shunt is functioning well, and this patient had a very good post-operative recovery with the reversal of the liver functions, and the cirrhotic changes also, pre-cirrhotic changes also reversed after the portocaval shunt. So a brief note on the portal hypertension surgery outcomes. So PSRS is the most studied portal hypertension surgery. This is the AIMS group by publication by Professor Nandi et al., who analyzed 160 patients and showed very low operative mortality with a very low rebleeding rate also of 11% and a good survival rate. So they concluded that PSRS is a one-time procedure with a low mortality rate and a good long-term result. And again, there's another study from PGI, which in PSRS, especially in children, which also showed a 10% rebleeding rate with a shunt patency rate of 87%. So the Western experience also has showed a very good, this from the Orlov's group, where they showed a rebleeding rate of only 2% with a shunt patency rate of around 98%. So shunt surgery in non-cirrhotic portal hypertension, especially in EHPO and non-cirrhotic portal fibrosis, is a one-time therapy that provides excellent long-term results. It has the potential to modify the natural course of the disease, and it's also cost-effective in the long run. Another one important shunt surgery, which is especially done in children, is a mesenteric left portal vein shunt, which is well studied, especially in children, and has a good outcomes there, where after the extrahepatic portal vein obstruction, we shunt the mesenteric vein to the left portal vein in the Rett's recess. And the results are published in long before, and they showed that after the shunt, especially in children, younger children, the flow in the bypass graft increased. And as the time increases, the flow, the portal vein diameter also, especially in the left side, increases. And there's always an inverse correlation between the flow which is achieved after the grafting based on the age of the patient. So it's better done in a younger age group, 6 to 10 years, than in the adult patients. So it's usually now the surgery is usually preferred in children. So you don't have any shuntable veins. The only surgical option is going to be devascularization. So devascularization mainly to prevent the future variceal bleeds. And the basic concept in devascularization is basically you're going to disconnect the portal system, which is connecting the connecting the gastroesophageal varices. So the portoesophagus disconnection, how you are going to do? You are going to do both extramurally, intramurally. So for extramural, you ligate all the collaterals, which is visibly seen outside the wall of the esophagus as well as the stomach, the GE junction. Intramurally, many of the devascularization procedures, they also describe a stapled transection, but which is being widely debated whether it should be done or not. So the stapling is basically to ligate the intramural collaterals, which is running in the wall of the esophagus and the stomach. So devascularization procedures is to prevent the bleed. And also intra-op, we decide if you don't have any shuntable vein, then you do a devascularization procedures. So what are the scenarios where devascularization is done? As I said, it's an emergency procedure where all the methods of variceal bleed to control variceal bleed has failed. Patients are not candidates for transplantation and need varices-directed surgery. When TIPS is unavailable, now with the advent of TIPS, most of the patients who have endoscopy failure go for TIPS. But if TIPS is unavailable, you go for devascularization. And there is a non-shuntable vascular anatomy, as I said. So there are various devascularization procedures. Segura procedure, which is basically done by both thoracotomy as well as laparotomy. This is the first said procedure about devascularization. After which it was modified to do only a abdominal procedure, a modified Segura procedure. Then it was further modified by Hassabs, in which it did a splenectomy. So all this devascularization procedure, the basic concept is you devascularize the gastroesophageal junction. So you ligate the collaterals meticulously in the lower third of the esophagus as well as the gastroesophageal junction, and do a splenectomy if needed. So there is a Mathur's modification of devascularization by another senior surgeon from KEM. So he has his own modification, but he did esophageal transection along with the devascularization, and he also produced good results of around 95% free of varices, but with the esophageal stricture rate of 15% because of the stapling due to the esophageal transection. There is one study which is published from Stanley, in which they published the results of devascularization without the stapling, to prevent the stapling related morbidity, and they achieved a good result in which the stapling related esophageal morbidity was reduced because of avoiding the esophageal transection. So in a nutshell, so what I explained, EHPO and NCPF. So the differences I'll summarize in the next slide. Indications of surgery, I explained to you. The ideal surgery in most of the patients is if there is a shuntable vein, go for a PSRS. If not, if the SMV is patent, go for a mesocaval shunt. If not, then you look for a mesocaval or a makeshift shunt. So some of the common differences between the EHPO and NCPF, which is the most commonly the common causes of a massive enlargement of spleen and portal hypertension in India, is EHPO and NCPF. So these are the main differences. So to conclude, the last word in the optimal management of portal hypertension is still not defined. So the role of surgery continues to be redefined with the advent of the newer IR techniques and endoscopic techniques. Surgery is still not obsolete. There is a modest success has been achieved in the treatment of non-cirrhotic portal hypertension, in which surgery still has a significant role to play. And advanced liver disease with recurrent variceal bleed, liver transplantation will be the main treatment option. Thank you, everyone, for giving me this opportunity.
Thank you, Dr. That was my picture. I have a few questions. For the benefit of the PGs, is there any alternative to renal vein for the shunt?
So usually, if sometimes you look for the arterial vein also. So arterial vein sometimes will be largely dilated. So if the arterial vein is significantly, you can use the arterial vein. So the other thing, we can use the gonadal veins also. So adrenal and gonadal vein are two good options if the renal vein is not. But most of the time, we'll be able to go ahead with the renal vein. The renal vein only thing is the anatomy of the renal vein. There is the multiple polar veins which we are not able to treat.
And is there any role of endoscopy in portal biliopathy?
Sorry, sir.
Role of endoscopy in portal biliopathy.
Role of endoscopic treatment is mainly if the patient is in cholangitis or if the patient has stones. So ERCP with stent placement and removal of stone is definitely as an indication. But ultimately, all these patients, the treatment the definite treatment will be a shunt surgery. And the study from Professor Nandi has shown complete reversal of the portal biliopathy after only shunt surgery without needing for an endoscopy intervention.
And your comments on DIPS?
Sir?
Comments on DIPS?
I'm not, I don't have much experience with it. So.
Thank you.
Very nice presentation. I have got a few questions. You spoke about the conventional shunts and conventional makeshift shunts. So any data you can share about the outcomes of that makeshift shunts and the patency rate and any rebleed rate in that non-conventional shunts?
So data, I'm not exactly sure, but in Stanley, we routinely do adrenal and ovarian vein gonadal vein shunt. So most of the shunts which we have done, so like for example, I would have encountered around 7 to 8 of these makeshift shunts. And most of them, they remain patent, they do well. If the flow is good if the portal pressure is high, the patency is maintained well. And and usually it's done after splenectomy. So the splenectomy itself decreases most of the portal hypertension. And the shunt functions well post-operatively, the patient has additional benefit of the variceal decompression also.
So other question is portal biliopathy. How you approach this portal biliopathy in a patient who presents with acute cholangitis or stones, acute cholangitis.
So in acute cholangitis, definitely ERCP is the role for this thing because we have to decompress the drainage system. So, but thing is that ERCP is not very straightforward in this patient because of the presence of large collagens. So we need to discuss depending upon the expertise available if they're happy to do. Otherwise, we can do a percutaneous PTBD kind of procedure. If it is not possible, then the only option is going to be shunt surgery. But we have to do in stages most of the time. If you're going for a surgical option, the first we have to do a shunt surgery. Wait for around 6 weeks so that the collaterals come down on the porta, and then only we can approach the HTA. If there is no other group, you want to go straight away, I think it's better to be done in a place where you have good vascular expertise with the liver transplant, where you can tackle all the large collaterals.
One more question. In non-cirrhotic portal hypertension, where they also have a background CLD changes, so how do you plan your shunt surgeries in those subgroup of patients?
Sir, always we see the liver. The liver is grossly cirrhotic, we avoid shunt surgery. The liver is cirrhotic, it's because it will further decompensate. But most of the time in EHPU, they don't decompensate because liver functions are preserved. Only NCPF, sometimes they go to end stage, very less percentage, around 5% they go to end stage. So we always do a assessment of the liver, see whether ascites intra any features of ascites, liver decompensation is there or not, and then only take forward. If it's grossly cirrhotic, we don't go ahead for surgery, shunt surgery.
How to keep these patients on follow-up? Do you put regularly anticoagulants or?
We start on warfarin in all these patients regularly and titrate to continue for 6 months.
Few questions. From the PG's point of view, what is the role of propranolol?
So propranolol is basically now the role of propranolol is secondary prophylaxis of the varicose bleed. So we give 40 mg twice a day. So that's basically to decrease the splanchnic pressure. So that the pressure to the intravascular pressure comes down, and the risk of a varicose rebleed is less. So it's more of a secondary prophylaxis now to prevent recurrent varicose bleed.
Any role for a prophylactic shunt, especially in children?
Children, definitely so, because in children, one is the quality of life, next is the growth retardation. And so definitely prophylactic shunt, even without any symptoms, especially in EHPO, shunt is definitely indicated.
GPJ series, they published one. Thank you.
Thank you.
Beta blockers after the varices have been taken care of by endoscopic treatment. The evidence for that is actually virtually nil. We know that in those who don't have varices, giving beta blockers does not reduce does not prevent the development of varices. Why should it theoretically be expected that those who had varices and where varices are taken care of by endoscopy, beta blockers would prevent? I think it's just the wishful thinking of people. Beta blockers have a lot of adverse events, which we don't realize beyond cardiovascular system. They make a person dull, they reduce a person's ability to work, they cause sexual dysfunction. So I think one should be very careful. Many people are using it, but evidence for that is extremely, it's just not there actually, not even say limited.
Worth just doing a splenectomy followed by keeping them on endotherapy, because if you use a synthetic graft, there's a chance that there is a penetration, migration of the shunt, and you need to put them on anticoagulants. It would have been better if you had just done a splenectomy and put them on endotherapy.
It's mainly decided based on the flow of the index. The splenic flow is very good, and if the initial portal pressure, which we measure by calculating the omental vein, is very high, it's more than 20, then we always think of shunting the vein. The initial pressure is low.
My only objection is the complication of the patient with EHPO, the shunts, the foreign body, you need to anticoagulate for a longer period and all this. And shunt penetration also, there are instances where the shunt has penetrated, migrated, all that.
So that is the only point of time an opportunity to have a shunt. So that definitely relieves the pressure in this group of patients with portal hypertension and especially high portal hypertension.
And the shunt thrombosis rate is 30% in patient with HPO.
But HPO, based on the evidence, is the shunt pendency is good unless the patient have a recognizable hypercoagulable state, like an antiphospholipid antibody syndrome, factor failure documentation. Otherwise, they do well. The shunt pendency is. Thank you, sir. Thank you for giving me this question.
Thank you, sir, for the enlightening session. May I request Professor Dr. Vikram Kate to felicitate Dr. Shaktivel.
Thank you, sirs. Next, we have Dr. Parthasarathi G for a lecture on complex abdominal wall reconstruction. This session will be chaired by Dr. Uday Shamrao Kumbhar and Dr. Suresh Kumar S. We welcome you to the dais, sirs.
Good. His areas of interest are mainly minimal access and robotic surgery and complex abdominal wall reconstruction. He is also a teacher for the super specialty trainees by National Board of Examinations. Over to you, sir.
Check. Thank you for the introduction. I thank Professor Vishnu Prasad and the organizing team for giving me this opportunity to present our work in front of my teachers and mentors. This fairly simple topic on repair of hernias, the bread and butter of every surgeon. But there is a paradigm shift in the problem itself, and accordingly, the solutions also are evolving quite rapidly in the last 1 decade, we must say. So today my talk will be on complex hernias. So what do you mean by complex hernias? Like, it is not just a big hernia. For every surgeon, the hernia he does is the most difficult hernia. That's what we come out and like to tell the others. There is no standard definition of a complex hernia, but by and large, when a hernia which is very large, more than 10 centimeters, or if it is recurrent after multiple failures, or if you have issues with the skin, if it's an ulcerated skin or an infected skin, hernias which are in the lateral locations or parastomal hernias, and if you have loss of substance, like because of previous repairs, infections, or previous oncological procedures, if you have lost muscle mass, or if there is a loss of domain, when there is a lot of bowel which has come out of the abdomen, the cavity has shrunk and you cannot put it back inside without raising the intra-abdominal pressure. These are generally referred to as complex hernias, which need specialized care a little more than the regular cottage variety hernia repairs. So by abdominal wall reconstruction, what we don't mean is just doing a big hernia. It is a scenario where you would be required to do either extensive adhesive lysis, you might be required to manage the scar, you might have to do a component separation to achieve a good midline closure. There might be a need to take down a previous intracutaneous fistula, previous intestine to mesh fistula, or tackle a loss of domain. So this is what is called not a hernia operation, it is called an abdominal wall reconstruction. It is not a fancy name, it has got a meaning to it, like I outlined. The basic principles, like every hernia repair, is a tension-free approximation of the well-vascularized tissue. Get the linea alba together. Bridging repairs are not okay. You cannot have a mesh which is just bridging the two cut ends of the linea alba. Unless you connect both the sides of the abdominal muscles, your abdomen will not be a mechanically sound one. Reinforce your repair with a mesh and make sure that you take precautions to avoid surgical site infections in terms of which plane you choose to position the mesh and how vascularized is your flap and tissue and other precautions. So this is the regular type of hernia we all see. What are the options? The options are innumerable. Every surgeon here will have one option for this. You can do a laparoscopic IPOM. You can do an open onlay mesh. You can do an open sublay mesh where you put it below the rectus muscle. If you are the fancy types, you can do an E-tap, you can do a TAP, you can do a TAM, and there is no end to the number of acronyms which are coming up every week. All these options are okay for this hernia. So there is no single best option for this. But when this comes, you don't have many options left. So you have to choose, pick and choose the right option for this. And this is where your surgery becomes from a hernia operation to an AWR. If you try to fix this hernia with an onlay repair, the traditional ones which we all learned, we all were doing for a major part of our career, is to raise a big skin flap. This is a hernial sac. Put the hernia back inside, excise the excess peritoneal sac, close it, put a very large mesh, leave it to your junior to quilt it with a million sutures, and then close the flap. This is what we are doing. Unfortunately, this doesn't work in many cases. One of the most common issue you have is a flap necrosis. That is not the end of your problems. There are other issues also which come because the basic premise is you try to close a very large defect under tension. You place a mesh over the sheath, which is not the best place to keep it. You have a large skin flap because the large hernia needs you to mobilize a large skin flap to create space for your big mesh. And that skin flap is bound to have vascular necrosis. You can develop seromas, mesh infection. Can I have the screen here? No, it's stop playing. Yeah. So here I would want to introduce the concept of component separation. It's very simple. Like you've all seen your suitcases which have an extra zip when the suitcase is overloaded, when there is a lot of stress on your zip. What you do is open the releasing zip and the capacity of the suitcase increases. This is exactly what you do when you do a component separation. When you try to bring in two widely spaced linear but defect together under a lot of tension, to prevent that, you release the layers of the abdominal wall so that they come in without tension together. One of the good planes to put your mesh is a retrorectal plane. There is no evidence as of today that onlay plane is bad, but more and more surgeons now prefer to put the mesh behind the rectus sheath because it has good vascularity, chance of infection is less. But the problem is your retrorectal space is a limited space. Like you have the space not between the two Spigelian lines, you have only a space between the 2 points where your neurovascular bundles enter the rectus muscle. You cannot cross that. So you get to use only half of the space behind the rectus muscle on each side. You don't get to use the entire space. And also your Spigelian line is also a barrier for you to create more space because there are times when if you want to get an approximation, you need to mobilize or you need to put a larger mesh. So a retrorectal space, when you want to extend it beyond further, the Spigelian line and the neurovascular bundles are a barrier to it. And that is when the concept of TAR came in, which is called a transverse rectus abdominis release. A normal retrorectal entry will have to go through here. And if you have to enter and release the transversalis muscle, you'll have to cut this neurovascular bundle and denervate the rectus abdominis. To prevent that, what you do is from the retrorectal space, you dip down, incise the transversalis muscle and enter the plane beneath the transversalis and then you lift up the entire neurovascular bundle, which is entering into the rectus sheath superiorly. So you don't have to cut this nerve and enter the space. You actually dip down, cut the transversalis muscle and enter this. This way your space is unlimited because now from the midline, you can go all the way on the TAR plane. Once the transverse muscle is lifted, all you have is the transversalis fascia and the peritoneum below you. And this can go all the way to the flank up to the psoas muscle. And this is the concept of TAR. And now here you see, once you have cut the rectus muscle and entered into the TAR plane, your initial mesh size, which was only possible to halve both the rectus size, can now extend much beyond that. And you can achieve a wider coverage. So this is a lady who came with a large neglected hernia and there was a loss of domain also, you can see, and the skin obviously with many years of neglect had undergone ulceration. So this is the defect we were left with after the adhesive. It was a 15 by 12 centimeter defect. Any attempt to close this primarily would be disastrous because you will create a lot of tension and it is bound to fail. So this shows where we incise the posterior rectus sheath. And once you incise that, you always make sure you are incising medial to the neurovascular bundles. So they are safe. You incise the posterior rectus sheath, and once you incise that, you see the muscle fibers of the transversus abdominis. You incise that, and the next layer you see is the transversalis fascia. So that is called the TAR plane. Here you can see that you're hooking the muscles of the transversus abdominis, fleshy muscles which are usually seen well in the upper part of the abdomen. And once you incise that, you see the glistening white transversalis fascia below that. And this is the entire length of the incision before entering the TAR plane. And you can see the neurovascular bundles are lateral to that. So they are all safe. Your nerve supply to the rectus muscle is preserved. The next step is you start raising the flap where you are lifting the transversus abdominis muscle with the forceps and you're entering the plane between the transversus abdominis and the transversalis fascia. And this is the plane which will take you bloodlessly all the way laterally up to the psoas muscle. So you can see that the transversus abdominis seen by the transverse fibers here, that is getting lifted up. The rectus muscle, anterior sheaths are all here. And here, this glistening white layer is the peritoneum and the transversalis fascia. And that is a completed TAR on one side. You can see the amount of enormous space you have created. You can go all the way laterally. You can see the transversus abdominis muscle all lifted up. And this is the amount of space you create. This way, you have mobilized the posterior rectus sheath to come closer to oppose without tension. Also, you also created a large space for a big processes to sit. And this is the closure of the PRS or the posterior rectus sheath, which is made of a strip of posterior rectus sheath on either side. And beyond the strip, you have the visceral sac, the peritoneal sac, which has got the peritoneum and the transversalis fascia. So we close this with a PDS suture, and you can see there's hardly any tension on the suture. Once you can see the entire bowel inside the visceral sac, which is very freely moving. There is hardly any tension on that. And this is the head end. You can see the falciform fat here, and this is the cut end of the posterior rectus sheath. There is no tension on your visceral sac, and you can see the anterior rectus sheath and the rectus muscle here. So now the first aim of the operation is achieved, where you have reduced the contents and you have achieved a tension-free closure of vascularized tissue in the midline. The next step is finding a prosthesis. All TAR procedures invariably need a large mesh. On average, you need a 30 by 30 centimeter mesh and to cover the entire defect. And this is skin closure. And you can see that at 3 years follow-up, this lady was doing very well. You can see the abdomen is a functioning abdomen. When she coughs, you can actually see the muscles tightening. And it is not just a cosmetic closure. You converted a dysfunctional abdomen into a functioning one. But there are scenarios when even this TAR may not suffice, because you might have an additional issue of a loss of domain, where just getting a release will not be enough, because even if you get a tension-free closure, you might end up with increased intra-abdominal pressure. So we use something called a Sabah index. It is just a ratio of the hernial sac volume to the overall peritoneal volume. So if it is more than 20%, we say there is a loss of domain. So in these patients, if you try to push the contents inside and close it, they will end up with high IAP. So this is where the concept of Botox injection has come in, where you use Botox to paralyze the abdominal muscles, which creates a temporary paralysis of the muscles, so that you achieve a free closure. The muscles become very elastic. And this is a reversible thing. Once you give Botox over a period of 3 to 4 months, the Botox effect wears off and the muscles gain back their strength. But that is all the time you would need for the abdomen also to adjust. So this is a procedure where we choose 3 points on the lateral abdominal wall, and under ultrasound guidance, we inject Botox. Not only that, you also put a catheter into the abdominal cavity and start. So the Botox paralyzes the muscles. The air which you inject gradually, every alternate day you call and inject air into the abdominal cavity. You create, like in laparoscopy, what pneumoperitoneum you create in 10 seconds, you create that pneumoperitoneum over a period of 2 weeks. So slowly the abdominal wall stretches. So you're actually regaining the domain which was lost to the hernia. And this is the pre and post Botox. The post Botox playing first, you can see that there's a lot of air into the abdominal cavity and also into the hernial sac. Yeah, and this is the pre-Botox, where you see the defect is so wide. And this CT will tell you the benefit of a Botox. You can see the length of the flat muscles from their origin to the spigelian line. The external internal oblique is only this much. After your Botox and neoperitoneum, over a period of 2 weeks, you're able to stretch that muscle so much. So you will have an easier closure. The white line you see here is the central end catheter, which we place into the abdominal cavity to inject air. The patient comes to the OPD and you keep serially injecting air till they start feeling discomfort. Then you send them home, again call them after a couple of days and keep doing that. So this is one way of handling this loss of domain. Like I told you, the other group of complex hernias are the ones where you have previous failed repairs. Like this is a guy who came with us with multiple, almost 5 times he had undergone a hernia repair, mesh infection, and failed repairs. And using this technique of TAR and Botox, we were able to give a good outcome. This was at 1 year follow-up. Lateral hernias are always a challenge. This was a post-cholecystectomy hernia where you find a huge lateral defect with a large hernia here. And again, using a TAR technique, we were able to achieve a very good closure. And this is one of the early post-op pictures. Patient was on follow-up for 2 years and is doing well. The next group of hernia, which is complex, is a giant groin hernia. So this is also, in India, it's quite common to see giant hernias which are neglected, like the one here where the patient had a scrotal abdomen. So here again, you have a problem of loss of domain. If you try to fix this hernia by pushing back the contents inside, patient will have IAP. We did the same thing. We did a Botox and did a progressive preoperative pneumoperitoneum. You can see the abdominal wall has descended. You can't avoid the air entering the hernial sac also, but it also stretches the abdominal cavity. So this patient, we did a laparoscopic hernia repair. So it was quite a challenging repair, but it worked out well. And that's the central end catheter, which you see once you enter the abdomen, which you've used for. We always inspect it to see because if there is any pus or any infection at that point. So we keep the catheter till we put the port inside. The first main challenge in this patient is reducing the content. That itself will took around 2 hours for us, where a lot of momentum and there was a sliding component of bladder and the sigmoid. He had bilateral hernia. So this is the hernia on the left side. For want of time, this was a 7-hour surgery. So I shrunk it to a 3-minute video. So a lot of steps have been skipped. So that is the right side sliding component. When you pull on a large intestinal content, it's advisable to you to pull it on the mesentery rather than on the bowel, because a mesenteric tear only causes a bleed, but you don't want a bowel hole. And that will jeopardize your entire operation if you're doing a hernia operation. So this is a peritoneal flap. We planned for a TAPP. This is a peritoneal flap we are raising. This, because of a long-standing hernia, there was too much fat in the preperitoneal region, and a very slow, painful surgery. But there was very limited space into the abdominal cavity. But the advantage is, as you create more and more of the flap, more and more space gets created. Your orientation and your bearings also get stronger. This is a flap on the left side. In this patient, we had taken a consent for bilateral orchiectomy. So we didn't want any recurrence. So he was an elderly patient. So we did a bilateral orchiectomy. That's the spermatic cord being sealed and cut with a ligashore. And we use an infant feeding tube to measure the hernial defect for most of our laparoscopic hernia operations. And this to get an idea as to what is the size of the mesh you would need. This patient needed a 20 by 25 centimeter polypropylene mesh. And the mesh is rolled and kept inside, and it is fixed to the Cooper's ligament with a tacker. And this mesh was fixed more than usual in multiple places because of the large defect. So we use an ethibond suture to fix the mesh, especially around the defect and at multiple places. Normally in a tap, fixation is controversial. There are people who do not fix the mesh at all, but we do a 3-point fixation, just similar to what Dr. Vishnu had shown yesterday. In this patient, we did more fixation, and this is the closure of the flap. We had connected the right and left flaps to get more space. Normally in a bilateral tap, we would do independently without crossing the midline. We are using a 3-0 V-lock to close the peritoneal flap again. That's almost the end of the procedure. This patient had to be shifted to the ICU. Despite the Botox, he had respiratory complications in the post-op period. He was extubated on day 1, but he did well after a few days. And that is the finished flap closure. The redundant sac is also hitched to the flap. You can see it here. We hitched the redundant peritoneal sac, and that's the closed flap. And this was the preoperative picture. And at 1 year follow-up, we also did a scrotoplasty, and this was the 1 year follow-up. This patient is doing well. So our experience the last 5 years with this TAR, we have performed around 68 patients who need this transdermal release. We used Botox initially for only 2 patients. Later, we realized it's always good to add a neoperitoneum to the Botox. And we have done that in 8 patients. And the mean defect size was around 12 centimeters in all these patients. Subba index was 16%. In 2 patients, we had to go in and re-explore, both for adhesive intestinal obstruction. Both we had to remove the mesh. There was no mortality. Morbidity was 12%. We had a DVT. We had surprisingly, surgical site infections are quite less when you put the mesh in the retrorectal plane. Despite the long surgeries, despite the ulcerated skins, these patients do quite well on the infection front. We have a follow-up of 22 months, and the one recurrent, that was a lateral hernia. The take-home messages is hernias are not just hernias anymore. The number of laparotomies will continue to rise despite minimal access surgery catching up. You will encounter more and more hernias in your practice. A thorough preoperative evaluation and prehabilitation. Like you plan your strategy, you prehabilitate the patient, you are going to have better outcomes. Hernia is definitely a good area to subspecialize for people who decided to carry on with general surgery. There is no dearth of challenging case in this. So it's a good branch to, there is no formal training or fellowship as of now, but this is a good area to put your interest in and start working on. And minimally invasive and robotics are exciting prospects in this. We are doing quite advanced minimally invasive procedures in hernia, in laparoscopically, and we're also taking up robotic surgery also. And this is the greetings from Kim, and this is our team. Thank you. Thank you for the opportunity.
Okay, sirs. I request the chairpersons to felicitate Dr. Parthasarathy Ji.
No, wait. We'll have some questions.
Thank you, sir, for the wonderful lecture. Would have made few points clear to the postgraduates. Sir, a few questions. You've shown a video of open TAR. Do you prefer open or lab?
See,
choose the cases.
We have to choose a case carefully. When you're expecting a lot of adhesions, ulcerated skin, it's always better to do open TAR. Whenever we do an ETEP RS and we have ended up doing a TAR, it's usually the original plan was usually most of the times it is only a ETEP under IVIS TOPA. The TAR is usually an intraoperative decision. So when we find a large hernia with adhesion problems, it is better not to go directly into the extraperitoneal plane. Try and do an open repair, because adhesive also is a very important thing. Because postoperatively, if you don't do a good adhesive patient has an adhesive obstruction, you are in a fix. Because if you open, you are undoing your entire operation. So it is preferable to do for complex hernias. Open it's always better.
Okay, sir. And progressive neoperitoneum, like.
Yes, you have to exercise the bad skin also anyway.
Like you face any challenge in creating pneumos? Like you're doing it in OPD basis, and how you.
This procedure is done on
a lot of logistics here.
No, we have a good IR team. So they it's done in the same sitting when they give the Botox. We finish the Botox, and the same sitting they get a needle puncture into the peritoneum, inject some air, then they shift the patient to the CT scan. And the IR team in this may not be relevant to an institute setup, public sector setup, but in a private sector, you take the patient to CT, the patient gets billed. So one way we bypass that is when an IR person takes the patient to CT, they are not questioned because they get multiple CTs during the procedure. So we use that, and then they take the patient to the CT scan room. They make sure the air which they injected is intra-abdominal. Once they are sure there, Then they pass a guide wire just to do like you do a central line catheterization into that, dilate it and put a central line into that. A CT guided is what we prefer. It's always safe because we don't want any morbidity of intestinal holes in that. We don't do a blind procedure at all. We don't do it. We always IR people, but we stay with them throughout the procedure.
And the patients are compliant, sir, like because the patient have to come very frequently for.
They're compliant because by the time they have this sort of hernia, they are like, by the time they come to us, they are like really motivated to get a solution for this. So these hernias are always very motivated. They'll come every second day. They come, they take a room in the lodge and stay and come also. Outstation
So
patients.
we have to admit the patient because our like public sector institute, that most of the patients cannot afford to stay outside issues. And what any preference over meshes? Like what kind of mesh you prefer? And like
For most of our minimally invasive regular inguinal hernias, lightweight meshes are always better. But if you're doing a TAR, if you're doing a complex AWR, we always prefer a heavyweight polypropylene mesh only, because you also have to understand that TAR is a procedure which solves a lot of problems, but it also creates its own issues. You are cutting the transverse abdominis muscle, which is a very important muscle, very underappreciated muscle. It is a corset. That is a muscle which actually allows you to create the core strength and power for your cough, for your sneeze and everything. You are actually disconnecting that muscle from the midline. So your right and left transverse muscles are not functional after this. You are trading off that to achieve a closure and a mesh. So it's always good to have a heavyweight mesh because your mesh should not break.
Was very nice and elaborate.
Role. These are the most important. None of them were smokers in our group, but if they are there, obviously we need to ask them to smoke. Stop smoking.
Another question: any role of imaging in this complex, particularly CT scan?
Yeah, actually, I had to restrict those things because the time was limited. How to use a CT scan before you plan a complex AWR itself is a separate talk. What factors you need to see? Like we have our CT reports, if you see, it's a very different report when they give for a complex hernia patient. You get a report on the width of the rectus muscle. You get a report on the length of the flat muscles. You have a SABA index, which is a ratio between, they do a volumetry of the abdominal cavity plus hernia cavity. Then a hernia cavity volume alone, see the ratio. So that is a SABA index. So they give that index. Then post Botox, they compare it and the report will have the comparison of change in volume. How much of abdominal cavity volume has increased? What is the percentage increase? Many of these are not standardized. It is still an evolving procedure. So we are also trying to collect as much data as possible so that we can figure out something once we have adequate numbers. But also we are also doing a 3-point measurement of the abdominal cavity in when we start giving Botox. So we measure the girth in 3 points and we are also maintaining that data. A number is around 10 cases now. I think when we reach 30, we'll be able to make some sense out of all these things. But it's important to have your radiologist primed to reporting a complex hernia because they cannot, otherwise the report is always about the viscera and a simple mention about ventral hernia 10 by 12 centimeter scene with small bowel as contents. That is not the report which you want when you're planning an AWR. You want a very focused report on rectus muscle, any denervation of the rectus muscle, any atrophy, what is the length of the strap muscle, volumes, and loss of domain percentages, basic things.
Okay. About whether you will decide regarding TAR based on the image, particularly the musculature, abdominal wall musculature, whether anything is there like that?
Usually what we see is one other index which we use is what is the size of the defect, what is the width of your rectus muscle. There are people who come with a very broad rectus muscle, meaning you will have a good length of retrorectal space in them till you hit the neurovascular bundle. So if I find a 5 centimeter defect with a very wide rectus muscle, I might not require a TAR because when I create a retrorectal space, my postrectal sheath is quite wide. So I'll be able to bring it together and avoid a TAR. But if I have even a 5 centimeter defect with a very narrow rectus, then I'm prepared for a TAR.
So another last question. Regarding, you have come across a situation where you have taken all preoperative preparation of this patient and intraoperatively you did the TAR and it was not possible to approximate the fascia and it needed to put an interpositional mesh.
No, we have encountered that in a couple of scenarios, but what we don't put interposition mesh, we use something called a peritoneal flap technique. We don't excise the sac till the end of the procedure, the peritoneal sac. So the last case we did also was that only, where you leave the peritoneal sac is the continuation of the visceral peritoneum outside. So when you incise, you have flaps on both sides. One side you leave the flap with the anteroabdominal wall, other side you leave it with the posterior rectus sheath. You can use
I request the chairpersons to felicitate Dr. Santi Ji.
If someone spent, this is still your.
This is that.
Thank you, sirs. I request Dr. Suresh Kumar to remain on the stage for the next session.
Next up is a guest lecture on simulations in surgery by Dr. Dinka Pai, chaired by Dr. Suresh Kumar and Dr. Seville. We welcome you, sirs.
next, we are going to have an excellent lecture by Dr. Dinkar Pai on simulation-based surgical training. Sir is a professor of surgery and director, Medical Simulation Center, MGMC, Puducherry. And Sir's area of interest is simulation-based training center. And Sir has excellent simulation lab in MGMC. I've been there, and Sir conducts regular simulation courses. Sir has over 50 publications in various national and international journals for his credit. Over to you, sir.
Thank you very much. I know I'm standing between the audience and lunch, and also Professor Inan has to go, so we'll try to be as quick as possible. So it's a slight change of pace from the hardcore surgery topics that you've been getting so far. And I'm just going to talk to you very briefly an overview of the role of simulation training in surgery. We all know that when we talk of simulation in surgery, a lot of simulation is used in therapeutics, in planning, surgical planning. So I'm not going to be touching upon that aspect. I'm going to be touching only on simulation training. Okay, this is working. Change our slide.
No, it's not.
Will this work? Okay. Yeah. Thank you. So this is the, there are many definitions of simulation. Essentially, simulation is nothing but replicating in an artificial environment something, from reality in order for you to train and achieve a certain amount of competency to manage the same condition in the real situation. Okay. So what Gaba said was that this is a technique, not a technology. All of us always equate simulation with technology. It's much more important to remember that it is an educational technique. Technology is part of it, just as much as technology is part of surgery, but technology is not surgery. Similarly, simulation is, the technology is not simulation. Technology is only part of simulation. Okay. So you are replacing real experiences with guided experiences, and there's a purpose to this. The purpose is for you to learn. This slide changing is not happening. Okay.
Click here, that's right.
Okay. Sorry, just 1 second. No? I think they opened the wrong. Can you just close this? You opened the wrong this one. Side to display. No, close this. Just close the PowerPoint presentation. Show me my. Shares. Close. Is share? Yes. Yeah. Just lose. Thank you. Sorry about that. Again, the same problem with slide changing. Okay. So basically, as I said, simulation can be training or sorry, give me 1 second. Third time lucky. Okay, so we are aware. Thing is, I tailor my presentations to the audience. So, surgical training, I think it's important to understand that there are a lot of components to surgical training, which all of us will agree with. So it needs to be multimodal. We need to have different modalities through which we learn surgery. It is not just about the classroom or not just about the lab or not just about the operation theater, but it's multimodal. And more importantly, it needs to encompass both technical and non-technical skills. This is something that we don't understand very often because traditionally we have always ignored the role of non-technical skills in all postgraduate training, let alone surgical training. And it is well known in literature now that the majority of medical errors happen as a result of issues with non-technical skills, not with issues of technical skills, which means that a patient will not die because a surgeon doesn't know how to suture or stop a bleed. A patient will die because of lack of proper communication, lack of proper decision-making, lack of proper leadership, lack of situational awareness. And we see this time and time again. If you do a root cause analysis of any medical error, you will find that more than 90% of the time, it is a non-technical skill that is the basis for that error. Okay. So surgical training should include deliberate practice. How many of us get that opportunity? When we are relying upon patients for training, we can't guarantee that each and every postgraduate will to surgical skills, because patients are varied in their presentation, they are varied in their, whether, you may not get the same patient in your entire 3 years. So deliberate practice becomes difficult. And of course, I already told you that surgical training should use training and surgical planning as well. So right now, traditional training is serendipitous, right? If you get patients, you're lucky enough to get patients, it happens to be your OT day. When a particular patient comes, you get exposed to that patient. Otherwise, you don't. So the training is therefore not uniform. So how is the traditional surgical training that is happening now? So we have supervised practice on patients. That means when first year you start doing some minor surgeries, you're supervised for those minor surgeries. As you get more experience, then you start, doing again under supervision, more complex operations. Eventually, maybe when you're a senior resident, you start doing independent practice for less major surgery. And eventually, you have increasing responsibilities. And in your more senior years, you start managing the patients unsupervised. Now, the problem is in each of these steps, there is a chance for error. When I say error, I'm talking about patient safety, errors in patient management. All right. And we have seen examples of these errors throughout. All of us who are experienced know that these errors happen. So in contrast to that, if you look at simulation-based training, this is a model that I'm proposing. So you have supervised practice on simulators first, following which, so you reach a particular competency. So unless you reach that competency, you don't move on to a real patient. Then you go and supervise practice to patients for that skill or that surgery. Then as you move further, you again go on supervised practice for simulators and achieve a competency level, and then again go to supervised practice on patients. And this cycle continues for each and every surgical procedure that you're doing, so that you do simulator followed by patient. And then, so the cycle is more like a spiral where you go on to more and more complex surgeries, each time with the simulator practice and then going on to real patient. Now, I'd like to highlight over here, when I talk of simulation, I'm not talking only about machines or mannequins or, virtual reality. Cadaveric is also a simulation. So cadaveric surgery, which is a common way of learning surgery, is also classified under simulation. Eventually, once you have reached a certain level of competency, you can break out of this cycle and then you go into the increased responsibilities. So the advantage of this training system is A, it is systematic, and B, it ensures competency for that particular skill before you are allowed to use it on a real patient. Okay, there is enough evidence for the use of simulation in surgery. I'm not going to go through the various articles, but if you just look for transfer of skills from simulation to the actual clinical environment, there's enough evidence to show that training in a simulated environment A, helps you to do the real surgery faster. B, it helps you to reduce the complication rate for real surgery. 3, it improves your decision making during real surgery and shortens your learning curve essentially. Okay. So there are many articles, as I said. I'm not going to go into all these articles. What about assessment? Can we use simulation for assessment? Now, this is a tricky situation. Surgery assessment, a lot of places in the world are now using simulation for assessment as far as surgery is concerned, especially for surgical procedures. And some of the MCH programs, I know that part of the assessment includes operating on a real patient. To my mind, that's not ideal because the candidate is already stressed. He's being observed by the examiners, and that is not an ideal frame of mind to be in when you're doing surgery on an actual patient. So simulation can be used in these situations. But at the moment, I don't believe that we are fully ready for it, and it needs to have reliability and validity testing before we can say that simulation is ready for assessment. Okay. So in a nutshell, basically, simulation training, I feel, should be an integral component as far as your surgical training is concerned. It has got many advantages. It removes that element of chance for the type of surgeries that you're going to face. It gives you a more systematic progression system where you are progressing only when you when you reach an adequate competency. We all know the problems with the existing surgical training today, where we have increasing number of trainees and we have reduced number of patients. OT time is precious. Consultants are, many of the institutions face consultant shortages. The advantage of surgical training using simulation is also that the system can give you the feedback. You do not need a facilitator or a consultant standing by your side when you're doing the surgery. So that is another advantage. Why don't we use surgery as use simulation more universally in surgery? I think the answer is maybe there are several reasons for this. I was just talking to Dr. Parsati, who was, our student here, and he was saying, we don't know that simulation can be used, especially for non-technical skills for team training. So we don't know that we don't know. So that's a very basic first step where we are at right now. So unless we have knowledge of simulation, we can't think beyond to say, okay, we should use simulation. The second is even those who have the knowledge of simulation, because they have not experienced simulation when they have been in training, they don't know the power of simulation and they are always looking at simulation skeptically. Okay, I think those days are gone because now, as I already told you, we have enough evidence. But the encouraging side of the story is that I travel a lot for simulation education, and I'm seeing more and more uptake of simulation by the premier institutes in the country. And when that happens, automatically the other institutes will follow suit as well. Thank you very much.
It was very nice and brief information regarding the simulation in surgery. Thank you, sir. The only thing I would like to ask you, sir, what are the challenges to implement this simulation-based training? Will you elaborate on this? Because this is actually the traditional teaching is over the patient, and that is the scenario most of the time it's going on. And second thing, the simulation, what we think that mannequins, and it involves lots of money and it needs a training of a trainers. That is another most important part of it. So how will you see towards this?
So thank you for bringing up that question. I think it's a very important aspect that we have to understand the challenges of using simulation for training. I think the primary challenge is what you highlighted. It is more the training of trainers. There is a feeling that simulation is an expensive modality to use. And if you go for some of the top range simulators out there, what you say is perfectly true. It is expensive. I will counter that with two arguments. One is we are saving an immeasurable amount of money in terms of patient safety. When we are training, even if one patient has an adverse event, which because of an improperly trained surgeon, and that event costs the hospital or the doctor or the organization a huge amount of money, and that happens on a recurrent basis, you will find if you do a cost-effective analysis, probably it's cheaper to get simulators to train these people. And there is now evidence to show that simulation helps. That is why we are now on a stronger footing, number one. Number two, we have a lot of low-cost alternatives to simulation. It need not be that simulation is always high cost. In fact, in India, now I'm working with several people initiatives to produce low-cost solutions for simulation rather than going with the traditional high cost. Surprisingly, one of the very important areas where this is developing is in virtual reality. The biggest, we may argue that virtual reality is expensive, but if you look at it, it's only a one-time expense and is not as expensive as getting physical simulators because you don't have consumables. You get a very, reproducible experience, and you don't have to each time, and the problem with surgical simulators is once you cut, you have to discard it. Whereas in virtual reality, that is not the case. You can do it as many number of times as possible. You can replicate it as much as possible, and it is upgradable. That is the other advantage of the virtual reality simulation. So there are a lot of low-cost simulators out there. You can also make your own. And so that will take care of a lot of the objection relating to cost of simulation. I think the faculty resistance is one of the important challenges, overcoming faculty resistance to use simulation for training. And that is by exposing them and training them more, probably we can overcome that.
Thank you, sir, for the brief presentation. As I said, increasing number of intake of postgraduate with limited resources and on patient safety aspects also. So simulation, I think, should be there, and NMC has made mandatory that skills lab. So possibly having a central skills lab and simulation with multidisciplinary will reduce the cost. So, thank you, sir.
Thank you, sir. Thank you very much.
Thank you.
Thank you, sir. I request the chairpersons to felicitate Dr. Tilpit Pai. Thank you, sirs. Coming up is a guest lecture on surgical management of GE junction tumors by Dr. Inian Samarasam. We welcome you to the stage, sir. Let me invite the chairpersons, Dr. Ananthakrishnan N. and Dr. Vishnu Prasad NR, to the dais. We welcome you, sirs.
So this is scroll down. Okay.
So, good afternoon. Let me introduce Professor Inian Samarasam. He is head of the Upper GI Surgical Unit at Christian Medical College, Vellore, which is close by. So he has been coming to our JIPMER surgery update for the last, I think, yes,
six times.
6 times. Yes. So
no, I think I missed one. 5.
Yes, come. So coming to his CV, has authored more than 80 journal publication, participated as invited faculty in various national and international surgical conferences, and he has got a basic and clinical research project related to upper GI surgery and received multiple grants from the ICMR, examiner for National Board Examination, the Royal College of Surgeons. His special area of interest is in benign and malignant diseases of the esophagus and stomach, and advanced laparoscopy dealing with them. Over to you, sir. And he is giving the lecture on one of the important topic close to his heart. It is the G-junction tumor management.
Thank you for the introduction and also for inviting, sir. And very good afternoon to everyone here. So my brief is to talk on G-junction tumors. So what I will do in the next 15 or so minutes is to give you the basic principles of the surgical management and how we make a decision on what operation to do in G junction tumors. And I bring along with me greetings from our hospital in Vellore. We have had a really close association with the Department of Surgery here over many decades, and I'm happy to continue this. We know G junction tumors is common in the West, and a similar trend we are seeing in the East as well, including in our country. And this could be possibly due to diet, obesity, reflux disease, etc. Now, junctional tumors have unique challenges because, firstly, of the anatomical location. So, difficult location, and therefore the surgery becomes difficult. And also, the lymphatic pathways can traverse abdominal, chest, and even the neck. So, essentially, all these make this tumor, management of these tumors, and decision making regarding these tumors difficult. And controversies in the management of these tumors, firstly, starting from the classification of these tumors itself, the different multimodal approaches that are available, how do we choose it? And also, which is what I'm going to concentrate, the surgical issues, what approach, how do we get adequate margins, what type of lymphadenectomy that we do. So all these are some of the controversies in the management of junctional tumors, which I will touch upon. And also another thing that is complicating the issue is that most of the trials that have been done in esophageal cancers and junctional cancers, they club together squamous cell carcinomas and adenocarcinomas. And esophageal gastric junctional tumors are often clubbed together. So you really don't get isolated view of the junctional tumors. So when we talk about gastroesophageal junction tumors, are they gastric or are they esophageal? So the AJCC guidelines, the latest guidelines, say you can classify them as esophageal if the epicenter lies within 2 centimeters of the junction and it involves the junction. However, if it is more than 2 centimeters away from the junction, or if the tumor does not reach the gastroesophageal junction, then they are gastric. So this is the broad classification. So when you say TNM classification of junctional tumors, based on this, you can treat them as either gastric or esophageal. And I'm sure you all are aware of this classification of gastroesophageal junction tumors. Does any volunteers? What is this called? Sievert's classification. So Sievert's classification basically on the location of the epicenter of the tumor. So suppose you have a tumor like this, the epicenter of the tumor, can I have a pointer, please? The epicenter of the tumor is, say, about 3 centimeters above the G junction. So it's type 1. And this would be a type 2 with the epicenter being about, say, at the G junction, and type 3, where the epicenter is more on the gastric side. So this classification talks about the center of the tumor and where the center of the tumor is located. And this is a Japanese classification. Does anybody know the name of this, where it's almost similar to Sievert's? Any volunteers? So this is called the Nishi's classification. So this classifies it into 5 types, and there is a corresponding Sievert's type at the top. The Nishi's classification is predominantly for squamous cell carcinomas, whereas Sievert's is for adenocarcinomas. Now coming to some of the controversies in management, PET CT scan, normally we do a CT scan for staging. The role of PET CT scan, now it is shown that for esophageal and junctional tumors, it upstages in about 20%. So if possible, particularly in advanced tumors, it is better to do a PET CT for staging. What about a staging laparoscopy? The current guidelines say that for a Sievert's 1, it is optional, but for a Sievert's 2 or 3, it is probably essential to do a staging laparoscopy. And also the timing of the staging laparoscopy, it should always be done prior to starting neoadjuvant therapy, so that you get so it's a staging investigation and it has to be done before you start any form of treatment. If you do the staging laparoscopy here, then you may not get a clear picture of the staging. That is after your neoadjuvant therapy. All these tumors have to be discussed in a multidisciplinary team. And as with any gastroesophageal tumors, when you have a locally advanced tumor, that is, if it is more than T2 or if it is node positive, then it is an indication to give neoadjuvant therapy. What type of neoadjuvant therapy? We've got both chemoradiotherapy, which is the cross trial, which I'm sure you would all know about. So this neoadjuvant therapy is paclitaxel with 41.6 grays of radiation. So this is given, and this is a landmark trial which you should all know about. And there was a significant increase in the survival, particularly in squamous cell carcinoma. So NACRT is good for squamous cell carcinomas. And the other neoadjuvant therapy is giving chemotherapy alone, and this is the FLOT regime, which again, you will be familiar. So these two regimes you should know. For chemoradiotherapy, it's cross, and for chemotherapy, it is FLOT, which are the current standard of care. And again, for adenocarcinomas, it showed significant increase in outcomes. So neoadjuvant therapy, for all practical purposes, if it's a squamous cell carcinoma, it is NACRT. And if it is adenocarcinoma, it is FLOT. And the new kid on the block is the immunotherapy. So immunotherapy, after you give the traditional either NACRT or NACT, you do the surgery. If there is residual tumor in the specimen, then this study has shown advantage of giving immunotherapy. Of course, there is the toxicity of cost, because this is quite expensive. And in this study, they gave nivolumab for nearly a year, and this could be very costly. But adding any form of immunotherapy has shown to be of benefit, even if it is for a smaller duration of time. And I'm sure we are going to see more of this immunotherapy in this picture. Now, coming to the surgical resection, which is what I want to really concentrate upon. So how do we decide the extent? How do we decide the whether we do an adequate lymphadenectomy? And how do we decide on whether the margins are adequate? Because these are the crucial things when you do when you're dealing with this junctional tumors. So basically, if you have a squamous cell carcinomas versus adenocarcinomas, there is a difference in the management policy or principle. We know squamous cell carcinomas, there is something called field cancerization. So basically, the entire mucosa of the esophagus is at risk. Okay. And of course, you have there is quite extensive nodal spread, both proximally and also distally. So essentially, if you're dealing with a squamous cell carcinoma, the operation of choice would be to do something called a near total esophagectomy. You remove as much esophagus as possible, and then do a neck anastomosis. So essentially, it's a McEwen's esophagectomy or a transhiatal esophagectomy. So for SCCs, it's very clear. So this is the treatment of choice. What's more complicated is in the decision making is when you have a adenocarcinoma. So if you have a gastroesophageal junction adenocarcinoma, how do you decide? So one is the margin. So what you aim to achieve is a 2 centimeter proximal margin. And when we say 2 centimeters, we try to get at least 2 centimeters, if not more. And this is when you do the surgery. Of course, after you remove the specimen, the tumor shrinks, the specimen shrinks, and it may not be 2 centimeters, but at least intraoperatively, you aim to achieve a 2 centimeter margin. And you have to do adequate lymphadenectomy. And the decision here would be to know which lymph nodes to remove. So if you have a Sievert's 1 type of tumor, which is basically involving on the esophageal side, you have to do a complete mediastinal dissection. So essentially, even the supracarinaal nodes, which is, the recurrent laryngeal nodes, need to be need to be taken out. And of course, the abdominal side as well. So that will involve a transthoracic approach. Now, if you have a Sievert's 2 tumor, which is straddling the gastroesophageal junction, the lower mediastinal lymph nodes are involved. So you don't really have to go and remove the recurrent laryngeal nerves or the supracarinaal lymph nodes. And of course, the abdominal nodes. And if it's Sievert's 3, which is on the stomach side, then the nodes are mainly around the hiatus and around the celiac axis. So if you have a junctional tumor, type 1 will involve, as we have seen, you need to give an adequate margin and you need to remove lymph nodes in the mediastinum, and therefore you need to do a transthoracic esophagectomy. So type 1 is clear. And for type 3, which is predominantly on the stomach side, there is no problem because you can perhaps do a total gastrectomy or an extended total gastrectomy. You will still get a margin. So these two are not so difficult. The real problem in decision making is the type 2. Type 2 is when they are located in the cardia, they are located around the gastroesophageal junction per se. And do you have to do an esophagectomy, or can you get away with just doing a total gastrectomy? So the type 2 are the difficult decision making in the decision making process. So this Japanese guidelines somewhat help in deciding the extent of lymphadenectomy that you have to do if you have a tumor involving the lower esophagus. So if the esophageal involvement is less than 2 centimeters, so if you have a tumor and it extends only up to 2 centimeters into the esophagus, then you do not need to do any major mediastinal lymphadenectomy. Maybe 5 more minutes. If you have a tumor that is more than 4 centimeters into the esophagus, then you have to do a complete mediastinal lymphadenectomy. And between 2 and 4 is, again, you may have to decide on whether you can do it either transabdominally or transthoracic. So these involvement of how much length of the esophagus is crucial. And again, there are still practice. So even if you know all this, there are still practical difficulties because, see, we talk about gastroesophageal junction, 2 centimeters, 4 centimeters, etc. But how do you actually know where the gastroesophageal junction is? Because if you have a tumor sitting there, it is anatomically difficult, both if you do an endoscopy, if you do a CT scan, even if you do a laparoscopy, to actually locate where the Z line is. So that itself is difficult, and there can be inter-observer variation. And the other problem is both these classifications, Sievert's, Nishi, etc., they talk about the epicenter of the tumor, where the center of the tumor is located. And they do not talk about the proximal or the distal extent. So you don't know where the proximal or the distal extent is. For example, if you have a tumor like this on the left side, this is a Sievert's type 2. The center is located around the G junction. Whereas this is also a Sievert's type 2 on the right-hand side, because the center is also located at around the G junction. And you cannot treat both these tumors identically, right? So that is one of the fallacies of the Sievert's classification. So Sievert's, although both are Sievert's 2, you cannot treat them identically. So I'll probably finish with this. So one thing that will help, or this is probably will help in the decision making of this. So one is to decide where the proximal margin is, whether you can achieve the proximal margin thoracic or through the abdominal route. What type of lymphadenectomy will it require? And can I use the stomach as a cause? So if you have a G junction tumors, these are the 3 questions that you have to ask yourself before you decide on what surgery to do. So suppose if the tumor extends up to 3 centimeters into the lower esophagus, remember you have to give a 2 centimeter margin, right? So 3 plus, so you can mobilize up to 5 centimeters through the abdomen by for the proximal margin. So if you have a 3 centimeter involvement of the lower esophagus, then perhaps you can get away with a total gastrectomy or an extended total gastrectomy. If it's more than 3 centimeters, your margin is going to be at risk. So you will have to go into the chest. So one is the upper extent of the tumor. Then based on the upper extent of the tumor, we've just seen the Japanese classification. So which says that if it is less than 2 centimeters, 2 to 4 and more than 4. So that again will help you decide, can you remove the lymph nodes adequately through the abdominal approach or through the, or do you have to go into the chest for it? And lastly, if you look below the distal extent of the tumor, can you use the stomach as a conduit? So this again will depend on the longitudinal extent. So if it is more than 5 centimeters into the stomach, or if the epicenter is away from, more than 2 centimeters away from the G junction, or if there is involvement of the body or the fundus of the stomach, definitely you cannot use the stomach as a conduit and you have to think of something else. So these are the 3 questions that you have to ask. Proximal margin, the lymphadenectomy based on the Japanese, guidelines, and can I use the stomach as a conduit? So if you can answer these 3 questions, then you can then decide, I can either do a total gastrectomy, I can either do an extended total gastrectomy, or I need to do an Ivor Lewis procedure for this. So I think the rest I will probably skip. And there can be instances where you have to use the colon as a conduit, because sometimes if the lower esophagus and the stomach is not usable, jejunum may not reach, and you may have to use the colon. And lastly, is there a role of proximal gastrectomy? Suppose you have a tumor in the G junction, can you remove the proximal half of the stomach alone? Now, this is possible if you're dealing with early gastric cancer, this less than T2. Now, if it is advanced gastric cancer, and if you do a proximal gastrectomy, you'll be leaving the nodes behind in the distal stomach, which is not oncologically sound. So proximal gastrectomy cannot be done in advanced gastric cancers. So I'll probably finish there. So not only all this, so in addition to all this, you have to look at what type of neoadjuvant therapy, how is the patient fit for a operation of such a big size, etc., the surgical expertise, and the local practice guidelines and logistics. So all this will determine what type of management that you do for these tumors. Thank you.
Thank you, Indian. Excellent as always. Can we have a few questions?
Yeah, of course.
Yeah. Anybody? Please ask questions. How do we know that you're all awake? No questions? Everything very clear?
I can take it as a compliment.
Yes, Dinkar.
Yes.
The line of management, in case you have distant metastasis subsequent to your primary resection, say either cerebral or liver or something.
Okay. So, sir, you're talking about after surgery?
Yeah.
Okay. So, obviously, these patients need to be on follow-up, and basically they will go on sort of palliative chemotherapy, I guess, once they have distant metastasis. And many instances, they may or may not be suitable for it, and it may be just palliation alone without chemotherapy. So it really depends on the duration. If it is a tumor that comes just after the operation, it's bad biology disease, and whatever you do, the results are not going to be great. But if it is, maybe 5 years down the line, there is some scope for giving some form of systemic therapy. So that is one. And if for local recurrence, obviously, we'll have to deal with endoscopic methods, stenting, etc.
Indian, excellent presentation as usual. So this is not a question, a recent incident that happened.
I wrote to Sivata recently in January 21st to have a talk in our Serathapin Education Foundation. Unfortunately, found that he died on January 16th of this year.
Oh, okay.
Sivat.
He's from Germany, right? Germany.
For those with hepatic or distant metastasis, what would be a recommendation on the feeding access? Because dysphagia is there and
Sure. So basically, now with the endoscopic techniques, trying to get a channel endoscopically or stenting, sir. I think endoscopic stenting is probably a better way of palliation rather than, putting tubes in the abdomen. And obviously, when we reach one other thing now, what we are finding is with the advent of immunotherapy, many of these actually patients with these tumors carry on for 2 years, 3 years, etc. So if we're able to palliate for a short term and let the sort of systemic therapy act, then it is at least some quality of life we are able to give. So I think with systemic presentation, I guess it will be probably a combination of, the traditional chemo plus or minus immunotherapy, and stenting is probably if feasible, I think a better way to go.
problem with stenting sometimes is free reflux, particularly at night, the great risk of aspiration. Unless you use a non-refluxing stent, which is very expensive.
Mhm.
So that is a risk which many people are not willing to take. So,
Sure.
Yeah. Sir, how do you evaluate and manage patients who have fully responded to chemo therapy?
Okay. So basically, the decision for treatment is taken before any systemic therapy or neoadjuvant therapy. So suppose you've decided to do, let's say, an esophagectomy, and then you find that the tumor completely disappears after the neoadjuvant. That's your question. Okay. So if you can sort of look at it in two ways. One is if you're dealing with a squamous cell carcinoma, complete response is almost 50% with cross protocol. And the problem is that it is very difficult to actually know that there is complete pathological response. Complete clinical response, yes. Clinical response means endoscopically, radiologically, PET scan, everything will be negative. But there is no real test now, as of now, to find out whether there's any residual microscopic tumor, either in the primary or in the lymph nodes. So therefore, in the, in the rectum, there is, this thing. There is also the Sano trial, which has looked at wait and watch policy, where you wait and then do surgery as indicated. So that is still not standard of care. We may see that come up. That is the wait and watch thing for squamous cell carcinomas. But right now we operate on everybody. And only when we get the pathology report, the final resected specimen, we know that there is a complete pathological response. That is for squamous cell carcinoma. Adenocarcinomas, whether there is a complete response or not, you have to operate. So there is no wait and watch policy for adenocarcinomas, and you cannot treat them equally. So as of now, both are, you have to operate, but there is a questionable role of wait and watch for squamous cell carcinomas.
And are there any subsets of patients where you still
Consider?
case of squamous cell carcinoma, are there any subsets?
Yeah, see, if you have an elderly patient who is not fit for surgery, so those are subgroups of patients where you can afford to wait. Where surgery is at very high risk, you've given neoadjuvant therapy or even radical chemoradiation, complete response. There, we've already made a decision not to operate. So there is those subgroup of patients who are not fit for surgery, etc. And if there is a response, that's excellent, actually. But we are talking about a patient who is otherwise fit for surgery. Can we avoid surgery? That, as of now, it is not standard practice.
And your comments on salvage is big.
Salvage esophagectomy after radical chemoradiation up to about 50 grays of radiation is still possible. The more you wait, the longer you wait, the more difficult it gets. So if you're talking about 60 grays, etc., it's very morbid operation. But up to 50 grays, you can still do a salvage esophagectomy. But again, the longer, like, you wait, it becomes more riskier. But if it is subcarinal, if it is below the carina, then you can, I'm talking about, at the carina, above the carina, it becomes quite risky, mainly because of the airway injury.
Is there any role, Inian, of routine ER or HER2 new studies in these tumors and appropriate measures if they are positive?
Sure, sir. Basically, HER2 new, yes, it is now. If you get metastatic tumor, not operable tumor, but metastatic tumor, we do HER2-1, MSI, and PDL1. So these are the three immunotherapy markers that we do, IHC markers, sorry, that we do. And if they are HER2 positive, trastuzumab, they respond. And if they are MSI high, or if they are PDL1 positive, immunotherapy acts well. So I guess these are some of the recent things that have come up.
The last question is, what's the time interval between neoadjuvant and ideal?
Ideal is about 4 to 6 weeks. So less than that, it's too less. More than that, it becomes fibrosis. Both, yes, same for both. Well, sorry, I'm talking about chemoradiation. For chemotherapy, 4 weeks is enough. Basically, you have to recover from the last cycle of chemotherapy, which is about 3 weeks. So after that, any time is fine.
So there was some video which you had put it into. What was that? I thought you skipped that slide.
Which one, sir? The video?
What was that? Just
No, that was not a video. You mean this one? I was going to ask the students some questions to see whether they were actually listening, but no video.
So,
I had a video, but this is.
so suppose I think one question which is was asked previously in another session. So when you do extended total gastrectomy, what will be your method of reconstruction if the jejunum is very difficultly? It's very difficult to pull the jejunum in for reconstruction.
Yes, sir. Basically, one thing is to do a left thoracoabdominal approach where you can go a little bit higher and use the jejunum. If jejunum cannot be used, then we have used colon, sir. Colon as the conduit. So we prepare the colon. No, we've done colon. We have not done laparoscopically. Jejunum we have done, but colon we have not done laparoscopically. Sure. Thank you.
Chairpersons to participate, Dr. Inian Samaras. Thank you, sirs. We now break for lunch. We shall reconvene in half an hour in the hall. I would also like to announce that after lunch, the session will be starting in first floor. All the presenters for original article and case reports to proceed to first floor hall after lunch at 2 o'clock. Thank you. Dr. Shankar and Dr. Rafiqullah from MGMC to report to the desk. You will have the session after this. There'll be 1 20-minute talk, no? Then session. Okay, so your PPT is to be given.
இப்போ ஆர்டர் என்னதுன்னா பைஜு சார் வெல்கம்
and Rajit. Okay. Uday sir and VP sir.
Where is it?
VP sir and Uday sir here.
And also Dr. Ranjit.
Okay.
Written here, no?
Yes.
All of them are here. Yeah.
Where is Uday sir?
He will just announce if they are there, they will come.
Okay.
They don't worry about all those things. I tell you, say good afternoon, welcome back.
Okay.
Okay.
Good afternoon, everyone. Welcome back for the afternoon session of JSU. Next on, we have Dr. Baiju Senadipati speaking on laparoscopic colorectal surgery. We welcome you, sir, onto the stage. I welcome the chairpersons for the session, Dr. Vishnu Prasad NR, Dr. Uday Kumar Shamrao, and Dr. Ranjit Hari to the dais.
Was written.
No, you can. That
So means parties are alone, we have to call extra now. And Sudarshan, actually it's going down. I think, okay, parties are there and Rajan sir is there. That's all I think. Rajan sir is not there.
So good afternoon, welcome back. So for this session, we have Dr. Baiju Senadipan. So some of you may be knowing him already. It's a well-known name in minimally invasive surgery. So he is currently the senior consultant in Senadipan Institute of Medical Sciences, and he has successfully performed more than 2,500 complex gastrointestinal surgery laparoscopically, and is one of the most experienced and prominent leaders in the world. So he is the first Indian to perform the laparoscopic coloplasty for benign esophageal stricture, first Indian to perform laparoscopic redo hepaticogenoscopy for edge stricture, has won the best video presentation award for laparoscopic ripples, and his area of interest is surgical gastroenterology, advanced laparoscopy, laparoscopic cancer surgery, bariatric and metabolic surgery, colorectal surgery, hepatopancreaticobiliary surgery, ERCP and endoscopy.
Manual operator.
So today he's giving us the talk on laparoscopic colorectal surgery. So nowadays on the colorectal surgery for colorectal malignancy is done expertly using laparoscopic surgery.
Thank you, Dr. Vishnu, for the wonderful words. And thank you for inviting me for this wonderful meeting. When you called me for this laparoscopic colorectal surgery talk, actually, you had told me that it will be a basic audience. So I didn't prepare much regarding, because the way Dr. Inian Samarajan and other people gave the talk, it's highly scientific. So I have not prepared that in the scientific way, thinking that it's students only. But I see that Anandakrishna Sara and all Abhitang Venkate Sara are in the audience. I'm a bit nervous to present this talk. If you look into the history of colorectal surgery, you know that it was Ernst Miles who first did the APR. Until 1973, when Park did the open colorectal anti-recession, it was APR only for clear rectum. So till 73, it was APR only. And after 73 only, we started doing anti-recessions. And in 1982, Healed standardized by demonstrating total mesorectal excision. Then it became popular after Healed demonstrated from back in stock. Then there was an era of neoadjuvant and downstaging of the disease. Then you started doing anti-recession for lower rectal cancers, and people started doing laparoscopic anti-recessions and APRs in the late 90s. And we started in early 2000s laparoscopically. Intrasphincter recession recently, 1994, it was demonstrated, recently started laparoscopically. TATME or transanal total mesorectal excision was started in 2010, and it was popularized by Dr. Leroy, who is my friend. When we started laparoscopic colorectal surgery 20 years ago, many eyebrows raised their eyebrows. There was criticism regarding port site metastasis and dissemination. And in the early 2000s, there was a large meta-analysis including thousands of people telling that the port site metastases are equivalent to open incisional site metastasis. So it was equivalent or less than that of incisional metastasis. And the criticism again was therefore time taken for laparoscopic colorectal surgery. Yes, in the initial times we took time for 3-4 hours or 4-5 hours for a colorectal surgery. Now the time has come down with the experience. Now it is being completed with less than an hour. And the steep learning curve could be managed. Actually, initially there was a lot of people who are not ventured into laparoscopic surgery because of steep learning curve. Now, because it is standardized, the techniques are standardized, now the steep learning curve has come down. And people are talking about the complications which are made intraoperatively. That has also come down drastically. And they were raising the concerns of long-term benefits. And there were data coming in. So short-term benefits, you all know the advantages of laparoscopic surgery, short-term benefits. Now coming to the oncological benefits, because of more visibility, you can have a more radicality in colorectal surgery. Lesser need of transfusion because of blood loss. More retrieval nodes, I will show on slide, having the nodes retrieval. Quality of specimen is, especially in rectal cancer surgery, quality of specimen is you are not breaching the fascia at all, which you'll have to look into when you are looking into a pathological specimen. And another advantage which always to the patients or to the colleagues is that if you are going for open surgery, the adjuvant therapy, if at all the patient needed, will be postponed for 2 months or 3 months because the wound has not healed. Here, that is the most advantage which I see, that you can start the postoperative adjuvant therapy very early. And the avoidance of stoma, probably some of the giant figures in this audience may not be agreeing to the fact that we can avoid stoma in many cases if you are doing laparoscopy. So see, this is an anti-recession floor which has done laparoscopically. You can see that the pelvic floor muscles, you can see the divided rectum there, and you can go up to this level or even lower than that. This is another picture of me doing laparoscopic anterosurgery in a male patient, you can see the prostate and the stump, you can see it has gone beyond the prostatic level, lower border of the prostate. This
the red training muscles are because so deep. And if you look at these donuts, this donut is just to show you that you can so achieve and so close to the end of the world. Now you can see that the skin is dead in this donut, and you can see the pathology report that this donut is free of everything. So that distance we can go and the concept is the same reason. The concept is we usually monitor that situation maybe having informative now. Because we have recorded, we can see the size at the work. Now, considering the number of lymph nodes recently done and recently done, you can see that the number of lymph nodes is 54. We are not imagining open surgery. 54 and 2 of the so that is the number of lymph nodes we can receive, and that is the answer we can achieve. So, we follow evidence. Actually, the colorectal surgery, about colon cancer, rectal cancer. And he was saying that the open surgery. Then the color time, classic time is one looking blocking aspects of rectal cancer. Then color 2 and color 3 by so they try to one who equate to the advanced families in rectal cancer. They also told that you can do laparoscopic surgery on rectal cancer. So I think this is the model of safety. There are a lot of complications regarding this model of safety. One second rule. Is that standing? Yes. Systematic review shows that one second rule is standing. And in this same study, they say that one of two studies against ours. Margin as 5 millimeter. It is negative, maybe covered. Now I will be showing some videos which we do in our department. This is the important question. Is not important question. The question we are about. And this is based on the whole side. So here we can see very well the reports. Very well the anatomy more than the view of surgery. Now we can see our aorta here, and we can see the bifurcation aorta like a man. Now we can see the inferior graphic, we are holding the artery, and lifting of the mesomery just over which expose you the so safety fascia, visual controlling all the aorta, all in the mesomery, all that is the lateral marginal digit fracture, and but you will the inferior mesotic vein. So calculate the inferior mesotic artery. If you are going for a high angle session, you go just above the left artery. Your medication just go below the left artery. As you can see that here you are going for a highlightation. And you can see the hypermedia very clearly here. That is visualized from the next part. Now the information is taken plus the aorta. And it is divided. And now going to the inferior vein, just start with the details of with harmonic circle dividing, and you can see those examples, you can see the whole vein there, which is little higher than the appearance of the cell. So that is exactly the vein is also divided now going immediately to lateral. You are there, we can see the lot of patients, and lot of patients the mesopoic actually is a fusion of brain, where we can search the mesopoic and the very following one. Now we are seeing is a white yellow color structure which is done here. You like both the right, you divide the pressure there so that you can mobilize the entire very pressure from middle to that itself. So now what I have introduced the capsular steel. Now leave there, go laterally, take down the pressure from lateral to middle. Because in some cases remaining it comes from the. So once the steel pressure mobilization is done, you come down to the critical, which you already divided. Now we can see the vein here, artery here, then show you the artery. And like I told you, now this is the results enter to the holy plane of field. So holy plane of field is a used area of tissue within the lymphorectum and the principal tissue. And you can say anterior to the uterus, so these hypertrophic myself. So you can see these hypertrophic here going deep into the pelvis. So you can see how the thermostasis you can achieve while doing so this is actually done almost 20 years back. So this method so now coming to the last aspect of the portfolio, they already divided the so just to have the recent the you can see that is pale blue, that means that now connecting that to the researcher. Now going lateral to Microfacia, you can see when you see and divide the model particle or the apple units going anteriorly. That is the pelvic muscles. You can actually when you reach the pelvic muscle, you do not stop there. There will be a space almost 3 centimeters between the appearance of the pelvic muscle and to the fracture margin on the board for the. So on this side also, same is done. After particular that skin and divided, protecting the part of the now a digital examination is carried out to see the margin of the tumor. So that is the space between the pelvic muscles and the so in between the pelvic muscles and the rectum, and divided with the endogenous paper. Here we can do the examination to see the muscle is free when you are the paper. Here we are using purple. You can use one or two depending on the rectum. Blue. Now the factors like the sun there, like the performance there, like the reflexes there, ureter, everything. And that is the intermediate vein, then with the artery. And you can check out the structure to a small incision. When I try to fast forward, it was sorry. So the structure is taken out with small incision and they check all kinds of then this 15 April, and it is taken down to the 27th January. Going to the next slide. So this is actually the TPG, total of the cost means the video culture and so probably that will cover the entire spectrum of articles. Certainly, the situation is manufacturing dorsal position. At down, you can see the video point artery, allowing from the base of the inflammation difference, you can see the margin of the G3, just above the vertical. So you can see the original G3 going to G1, and again you are identifying the before the pedicles right at the bottom of the origin from the pedicles. So you can see the people for the original pancreas. You usually don't go so deep when you do open surgery. So the radical is maintained in laparoscopic surgery. Now do the discussion from the lateral side, and the anatomic part is finished. Now you are going to the kind of to take the branch of helicoid to the right, sorry, to the left. That is the nodal sampling. And now we can see the come to the left side. You can see the left column of these lesions. Like we are seeing the angular part. So going medial to lateral to the spring factor, and then taking the spring factor for lateral aspect. Now coming to the anterosation part of expression. So we recently there are a lot of discussion regarding whether to go for complete mesopolic excision or not. Whether Japanese D3 is equivalent to classification. So it's all the same, provided that you are taking the vessel from the root and taking the fascia. Now this person is taken to a small incision, the DG is taken to converted into a conduit, that is U-shaped conduit with the staples. And the staple is taken back into the conduit is taken back into the chronic cavity. Follow anal anastomosis is being performed with staples. I have a couple of videos of rectopexy, but I'm not going to show that because people are thinking about rectopexy because of time limitation and protection also. Because of time limitation, I'm not going to detail. So with a high definition camera or a 4K camera, you can have a sense of magnification and do the surgery for anatomy. With better understanding of the anatomy, which is better total health. Time taken is less than half the time of
Thank you, sir, for the presentation. Very clearly, you have presented all the landmarks and steps following this. Now the question, you actually told one point that question of trauma actually isn't different between the open and the what I'm trying to say is that I go so deep that I so close to the universe
about the surveillance. Even numbers come on being very reinforcing the surveillance. So most of the cases, 99% of the cases, we will be able to reinforce the surveillance so we can avoid someone low and and what is the policy regarding someone for laparoscopy completed areas? Means what should you do or someone we should you avoid this one? So actually when there is a tension, which cannot be taken down for the better or technically demanding context only. And any kinds of blood supply doubt is there for us. Does DOJ not see better results in time? Yes, but I take it to see if everything is okay that it's a theory proving on the tissue by dissecting then I go for trauma. But if it is not that of things are there or not for us, but reinforce this. Would you think the advent of robotics is going to make a difference in practice? Probably, we might get the for next techniques probably for say, probably no, but I don't know. One problem which we face during this, most often the rectum goes are affected and there will be not equal sensation whatever we have done. We haven't known okay. So I think all these are also not yet because of the preparation. So we will usually for like 4 days preparation and if you do can is there, right? So we give epidural anesthesia in all cases where the bowels will come down. So the bowels will obey. So mostly what is happening with the lower is the lower but it should be difficult to manage. So give epidural just before the anesthesia. That will contact with small bowel that is obey. So that is one way. And use the daily minutes of environment. Actually, the second case of the developing criteria so even two treated tumors with 32 35 million on the animal without external fingers. Go by earlier method of you take either in the slide it will be considered on the wall and then marking then in the upper margin then the partly go between the three then the complete laparoscopy. Regarding some male patients, 20 rows in the tumor, very difficult to reach. And there will be too much of whatever it is possible. Yeah. Anyway, it will be actually probably about helping you better than aging with disability, but in that case, basically, if you have given a radiography for 20 years, they might have even then if it is not treated, still the like because the law by so and sometimes you may have to respect to the level it is visible. Then complete the surgery below. Understand what I said? Means suppose lesion is 10 centimeters here. You go 5 centimeters below and then the set is do the process of the set without the tumor there. Understand?
questions? Okay, thank you very much, sir.
Thank you, sir, for your informative question. Request the chairperson to facilitate Dr. Baiju's scenario.
Presenting a case on lower abdominal mass. I invite the examiners for the session onto the dais, Dr. Vikram Kate, Dr. Baiju Senadipan, Dr. Rajan KV, and Dr. Sudarshana Ness. We welcome you, sirs.
Good afternoon, sirs. I'm Dr. Shankar, and this is Dr. Rafiqullah, final year postgraduate from MGMCRI. A 36-year-old gentleman from Kallakurichi, working as a constructing manager in Singapore, came to the hospital with complaints of swelling over the umbilicus since 8 months, complaints of swelling in the lower abdomen since 5 months. History of presenting illness. Patient noticed the swelling 8 months back, initially smaller in size, later grew to the current size. History of swelling increases in size on straining and walking, and spontaneously reduces on lying down. Patient also complains of another swelling in the lower abdomen, which he noticed 5 months back, initially smaller in size, later grew to the current size. It's not associated with the pain. Patient complains of upper abdominal pain since 5 months. It's burning type, intermittent, aggravated on eating spicy food, and relieved with medications, non-radiating type. There's no history of gastrointestinal symptoms such as regurgitation, nausea, vomiting, hematemesis, melena, constipation, loose stools, or hematochezia. There's no history of jaundice, no urological symptoms such as burning maturation, hematuria, or dysuria. No history of loss of weight or loss of appetite. Patient initially visited a clinic in Singapore where he was diagnosed with umbilical hernia and advised for surgical reference. Further, he consulted MGMCI for further management. Patient doesn't have any comorbidities like diabetes mellitus, hypertension, asthma, epilepsy, and tuberculosis. There's no significant past history. No significant family history. In personal history, patient consumes a normal diet. Patient consumes mixed veg and non-veg. There's no loss of appetite. There's no altered bowel bladder habits. Patient not a smoker, consumes alcohol 180 ml per week. There's no significant family history. In summary, a 36-year-old gentleman with complaints of swelling of the umbilicus in 8 months and which reduces spontaneously on lying down, and another swelling in the lower abdomen, which is since 5 months. There's no other significant history.
You presented a history. Any idea what is the likely origin of it? Got two complaints on the
Yes, sir.
swelling, like like
Yes, sir. Yes, sir.
another one is noticed not in the forehead.
Yes, sir.
But apart from that, there are no major symptoms. So what are the
So it looks like mostly like any pelvic tumors, anything arising from there's no colonic pathology. No, sir. No history of no GA symptoms. It could be small bowel mass. Yes.
Not be right.
Yes, it could be gist or it can be quite gist. Okay.
It's got a lump in the lower abdomen.
Um,
Caused in lung.
Yes.
No GA symptoms.
Yes, sir.
Just well away from the GIT or
So, any pelvic tumors from sigmoid colon?
weight loss is got
No, sir.
No, the question is that if a person is complaining of a lump in the abdomen on history, there is a possibility that the lump is large enough for the patient to appreciate it and then complain about the lump in the lower abdomen.
Yes.
And you yourself have mentioned that there are no significant symptoms related to the lump the patient is having.
Yes.
So what are the pathologies that can lead to a large lump in the lower abdomen, which do not produce much of
Sarcomas.
symptoms?
Sarcomas.
So when you talk of lower abdomen, one of the things what you can ask the patient is that much the patient should be able to tell. When we ask in history, we divide the abdomen in 4 quadrants. When we examine the patient, we divide it into 9 quadrants. So here, if you divide it into 4 quadrants, which quadrant the patient is complaining the lump is primarily present?
Sir, primarily he's saying just below the umbilicus.
You have to use the mind. There are so many people already, they are little partly drowsy, so you have to activate them. Na? Speak loudly.
So below the umbilicus.
Your voice should be more than mine.
So just below the umbilicus, he's saying, sir, like hypogastric.
That patient cannot tell like that. Na? Hypogastric mass.
Involves both lower quadrants, lower right and left.
See, when we talk of quadrant, it means left lower, right lower, like that I'm talking.
Yes, involves both the quadrants, right and left lower quadrants.
Oh, so the patient is feeling that it is more of in the center in the lower abdomen. That's
Yes,
what you're trying.
Yes, sir.
So with that sort of background, what are the possibilities which can lead to a large lump, which essentially is symptomatic?
Any soft tissue sarcomas.
Soft tissue sarcoma arising from where?
Sir, retroperitoneum.
Okay, so abdominal sarcoma.
Abdominal sarcoma.
Possible. Okay, then what else?
So any parietal wall.
Parietal wall swelling. What parietal wall swelling can give rise to a large lump?
So desmoid.
Which is situated in that area what you mentioned.
Desmoid tumors.
Desmoid tumor. Desmoid tumor by description commonly where does it happen in the quadrant? It is more often in the right leg, is it?
Yes, yes.
Desmoid is not a common presentation. Anything else you can think of? Sarcoma is also not common, but it can be there.
So leiomyosarcomas.
Sarcoma covers everything. What else?
Carcinomas from the colonic carcinoma, sigmoid colon.
Sigmoid colon. Okay, if it is a sigmoid colon malignancy, and the patient is malignancy I'm talking about, not carcinoma of the sigmoid colon. and the patient is relatively asymptomatic, as this patient has. Patient only has one symptom in the form of a mass, is it not?
Yes, sir.
So what are the possibilities?
There would have been any history of blood and stools.
Question is, when the patient has relatively asymptomatic large bowel mass arising from the sigmoid, what are the pathological possibilities? I am being very specific in the question. What pathological lead to that? That's the question. One of the things what you mentioned is GIST. Is it? GIST can produce a large lump and may be relatively asymptomatic. GIST produces what symptom commonly?
Mostly due to compression, pain.
No, if the patient has got abdominal mass, what other symptom if the patient has got, you can suspect there is a possibility of GIST.
Hematemesis or GI bleed will be melena.
GI bleed, you say. Hematemesis is not likely to happen with the sigmoid GIST, is it not?
Yes.
This is not very often seen in the sigmoid, but okay, it is acceptable. Anything else? Can you get any other malignancy in the gut, which may not be producing any obstructive symptoms? That's why the patient is not having any symptoms.
I think from the mesentery cyst.
So what are the positive symptoms or what are the negative symptoms here?
So positive patient only the abdominal mass. Sir. That's since 5 months. Sir. Negative history, no history of nausea, vomiting, or hematemesis, melena, or hematochezia.
There is no GA symptoms particularly.
Yes, sir.
Is there any history of weight loss?
No history of weight loss.
Yeah.
Yes, sir.
Then what are the other positive and negative?
So there's no loss of appetite, yes. And urinary complaints, yes. There's no history of hematuria, no history of dysuria. Sir, yes.
On general physical examination, after obtaining consent and examined a patient examined in a well-lit room, the vitals examination, pulse rate was 76 beats per minute with a regular rhythm and normal volume measured in the right radial artery. Blood pressure was 130 by 80 millimeters of mercury measured in the right arm. Temperature was afebrile and respiratory rate was 16 breaths per minute. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Patient was well nourished with a weight of 68 kgs and height 160 centimeters, BMI of 26.56, and his ECOG score was 0. On abdominal examination, on inspection, abdominal contour fullness noted on the umbilical and the hypogastric region. 3 into 2 centimeter swelling present over the umbilicus, where cough impulse was present and the swelling was reducible. A 2 into 2 centimeter scar present over the epigastric region and healthy. No sinuses, no dilated veins, no visible intestinal peristalsis or no visible gastric peristalsis. On a leg raising test and head raising test, fullness over the lower abdomen was obliterated. Hernial orifice, there was no swelling and no cough impulse noted. Spine was in the midline and renal angle, no fullness noted. External genitalia appears to be normal and no fullness noted in the left supraclavicular region. On palpation, the abdomen was soft, non-tender, a 3 into 2 centimeter swelling present over the umbilicus.
Excuse me. Inspection, you mentioned about the swelling in the umbilicus. So with the picture, can you describe it more? Because the swelling, we see it's in the inferior margin of the umbilicus, protruding into the center of the umbilicus, but the superior margin of umbilicus, the shape is mine. You didn't mention all this.
Yes.
So whether it is a fully umbilical hernia or a paraumbilical hernia, we need to know with the inspection itself.
On inspection, cough impulse is noted over the swelling and the swelling occupying the lower border of the umbilicus, and the superior margin of the umbilicus is maintained.
What was the position of the patient when you elicited that finding? Was the patient?
So
The next photograph shows that the patient was supine, is it not?
yes, sir. The first
Supine
photograph.
and the patient is erect. The
Yes,
next
sir.
one, is it not?
Yes, sir.
Okay, but what you have drawn with that marker pen?
That is the second mass that was palpable, sir. Second mass that
Okay,
the patient
continue your
complained.
palpation, because I didn't see any description of that. That's why I'm asking.
So palpation have yet to come to inspection.
Okay, continue.
Yes, sir. On palpation, abdomen is soft, non-tender, 3 to 2 centimeter swelling present over the umbilicus. Expansal cough impulse is present, and the consistency being doughy and reducible swelling. A mass of size 16 centimeter transversely and 12 centimeter from the superior border of the swelling to the pubic symphysis, palpable predominantly over the umbilical and hypogastric region and also extending to the right iliac fossa, with no local rise of temperature over the mass. Well-defined borders all around, but the inferior border is not palpable. Superior border is 9 centimeter below the Ziphi sternum. Lateral border 4 centimeter from the umbilicus on either side. Inferior border is not palpable and extending beyond the pubic symphysis. So the mass is firm in consistency. Surface is nodular, and the mass is transversely mobile and vertically non-mobile. Head raising and leg raising test, swelling becomes less prominent and transversely mobile and vertically it's not mobile. And plane of the swelling is intra-abdominal. There is no hepatomegaly or splenomegaly. Hernial orifices, there is no cough impulse noted. Spine is in the midline and non-tender. No renal angle tenderness. External genitalia is normal. Bilateral testis is palpable and left supraclavicular region, no palpable lymph nodes. On percussion, over the umbilical swelling is a dull note. Over the lump is also a dull note. Renal angle, there is no dullness and no evidence of free fluid. Auscultation, normal bowel sounds heard. For rectal examination, there was no mass palpable in the rectovesical fold. And systemic examination, respiratory system, bilateral air entry is present and equal with no added sounds. Cardiovascular system, S1, S2 heard and no murmurs. Central nervous system, no focal neurological deficit. To summarize, 36-year-old gentleman complains of swelling over the umbilicus since 8 months back, reducing spontaneously on lying down, and another swelling in the lower abdomen since 5 months with no other significant history. On examination, an intra-abdominal mass of size 16 centimeter transversely and 12 centimeter from the superior border and 12 centimeter from the superior border of the swelling to the pubic symphysis, palpable predominantly over the umbilical and hypogastric region and also extending to the right iliac fossa. Pause.
So, lower body not well. The and how here it is regular examination more good. What I'm missing.
Sir, lower border is not palpable, so we can infer that the swelling is originating from the pelvis and rectovesical fold. There is no mass palpable in the PR, so mass from the rectum can be ruled out.
Can you just go back few slides where you have described the physical examination of the mass? Yeah, here. That the last line, what does it indicate?
So
Why you have done it and what did you want to find there?
So head raising test and leg raising test, we wanted to check the mobility of the swelling while contracting the anterior
Head
abdomen.
raising and leg raising when you do, is it for that? If you find that there is a mass which is appearing on inspection, you would like to know whether the mass is parietal, whether the mass is behind the anterior apparatus that is inside the abdomen. So when it is just to indicate whether it is a parietal mass or not a parietal mass, is it not? So it is not something what you have written transversely mobile, vertically not mobile. So how will you do this palpation once you have contracted the muscles, overlying muscles? When you do this head raising, leg raising, that will happen.
Sir,
You understood the question?
yes, sir.
See, this is a large mass, is it not? 16 by 12 you written.
Yes, sir.
So when you have a large mass and you want to assess the mobility of the mass, sometimes it is very difficult to hold the mass in the hand. Is it not? 16 centimeters, how will you hold? So you have to do a palpation with the help of two hands trying to push it. Is there any other way to know whether the mass is mobile? A better way?
Elbow knee position and we can,
Hmm?
in elbow knee position, we can check for
The elbow position is very difficult for the patient, is it?
left
Anything
lateral,
less than that.
left lateral position.
Yes, lateral position. It's not necessarily left lateral or right
Left or
lateral.
right.
What will decide the position, which lateral side you should take? You are correct. You go closer to the mic and answer.
So the region where the mass is less prominent.
Very good. Yes. So if the mass is more on the right side, you will put the patient on the left side, is it not? So space is there to know whether the mass moves on that side. If it is mobile on the left lateral position, if it moves, it falls on that side, then that indicates that the mass has got, it indicates two things. One is that it has got a pedicle. And number two, it is not fixed to the posterior parietis. It's very important to know this sort of big mass is fixed to the posterior parietis or not.
Yes.
You'll be doing cross-sectional imaging to find that out. But still on clinical examination, if you can document that the mass is not having any mobility, it becomes important. Because you have written that it is transverse mobility. How did you assess that in this patient? Definitely you should not do with head raising and leg raising. Abdominal muscles have to be soft for that.
Yes, sir.
After that, how you did it here in this patient?
So the patient supine position, initially we check the mobility of the mass transversely and
You
vertically.
have put hand like this, indicating you have held the mass 16 centimeters, quite a lot, no? Is it
Yes,
not?
sir.
So you may not be able to get, if you don't hold the mass properly, you may not be able to assess the mobility. That's what I'm trying to assess. Okay.
Yes, sir.
You understood the point?
Yes.
Yes, sir.
So that's why I wanted to emphasize that in large mass, it's always better that you change the position. And I don't know now, this is your finding. So was it mobile or not mobile?
It was mobile, sir. Transversely mobile, sir.
And vertically?
Non-mobile.
Why it was not mobile vertically?
Sir.
Tell me the reason in this patient. Just
You-
now, Dr. Rajan asked you a question. It's related to that.
Might be from the pelvic origin, sir. Because of the pelvic origin, the vertical mobility is restricted or attachment
Not
to the
related to pelvic.
Yes.
The extra
Ask you a
peritoneal.
very particular question. See, for assessing that vertical mobility, you should be able to palpate the mass up and down. Agree or not?
Yes.
Is it not? So I thought what you mentioned, you are not able to see the palpate the lower limit of the mass. Is it not?
Yes, sir.
So it is difficult to assess that mobility. You understand? You may be able to push the mass in the pelvis, but that is not like when you have both the borders palpable, the assessment becomes better. All right?
Yes, sir.
So now you tell your, summarize your findings.
To summarize, 36-year-old gentleman with complaints of swelling over the umbilicus since 8 months back, which reduces spontaneously on lying down, and with another swelling in the lower abdomen since 5 months with no other significant history. On examination, intra-abdominal mass of size 16 centimeter transversely and 12 centimeter from the superior border of the swelling to the pubic symphysis, palpable predominantly over the umbilical and hypogastric region and also extending to the right iliac fossa. Our possible differential diagnosis, pelvic sarcoma, gastrointestinal stromal tumor, sigmoid colonic mass, and bladder tumor.
You cannot just enumerate the diagnosis, is it not?
Yes.
So you have to also keep in mind, this patient does not have any symptoms.
Yes, sir.
Yes.
Such a huge mass arising from the bladder, will it be totally asymptomatic? Sigmoid colon, gist arising from what?
From colon pathology, sigmoid colon thinking.
But you already written sigmoid colon mass. If you are meaning just arising from that, that becomes inclusive of that.
Yes.
So can you have a gist from something else there? That's why I'm asking you.
Lower abdomen, what would be the lower abdomen? Which part is cut floating there?
Small bowel, sir. Small bowel.
Small bowel, yes. So you can have a gist from the small bowel. You can have a sigmoid colon mass. you have only considered these diagnoses. I asked you a question earlier also. Which other malignancy can happen in the bowel, in the gut, which is not carcinoma, which is not GIST, and which can present with a large mass? What are the other malignancies of the gut? Usually there are 4. What are the 4 malignancies arising from the gut? Carcinoma of that portion of the gut, GIST. Anything else? Lymphoid related malignancy.
Lymphomas.
Lymphoma. Anything else? More often happens in the appendix.
Mucins.
Carcinoid, you've heard of that?
Carcinoid.
May not produce a large mass, but a lymphoma can produce a large mass, is it not?
It's not a parietal wall swelling, so it's an intra-abdominal swelling. So in the intra-abdominal region, is it an intraperitoneal swelling or a retroperitoneal swelling? This pelvic sarcoma I mentioned. So is it what is the site of the sarcoma? Which structure you think it's arising from? Is it a retroperitoneal swelling or an intraperitoneal swelling? So as per your examination.
Clinically, it is a intraperitoneal swelling, sir, because the mass is
The mobility.
mobility.
So it's moving, so you want to consider intraperitoneal swelling. So sarcoma, from which structure you want to consider now? An intraperitoneal swelling. What did you think of when writing that sarcoma? Was it retroperitoneal sarcoma?
Retroperitoneal.
Should not be mobile usually. Like you were describing very good mobility.
Yes.
So what's your final diagnosis?
So, final diagnosis.
At this stage, it might be difficult. So, what is the gender? I missed on that point.
Male, sir.
Where did I ask that?
So any ovarian mass, like if it is female.
Yeah, the female patient, you have to strongly suspect that it could be a case of ovarian mass.
Ovarian
It's not any mass which is in the region where you mentioned hypogastric region, you cannot rule that out. So it's not sure, and there is a large mass. Temporarily, we'll ignore that umbilical hernia part of it. So how will you proceed?
So, proceed initially with the radiological investigations. Initially would be ultrasound abdomen.
Why do you want to do that as the first investigation? When you classify investigations, how do you do them? In what chronological order?
Confirmatory, then followed by
Yeah, to establish the diagnosis. Investigations to establish the diagnosis.
And staging.
Simple to more complex.
Yes.
Okay. Then if you're suspecting malignancy,
for staging.
Stage the disease. And third,
if it is preoperative investigation.
yes, investigations, general investigations for the fitness, is it not? With these things in mind now to tell the investigations.
Ultrasound abdomen showed a large multilobulated mixed solid cystic lesion measuring 12 into 11.6 into 8 centimeter, noted in the abdominal pelvic region. The mass is seen occupying the RIF and LIF, extending into the supra and infraumbilical region.
Better to avoid the abbreviations, okay?
Yes.
Continue.
Into the
Right
supra.
leg fossa, the left leg fossa, extending into the
supra and infraumbilical region, and mass is seen abutting the superior aspect of the urinary bladder with the suspicious loss of fat plane. The lesion shows mild internal vascularity on color Doppler. And a defect measuring 1.3 centimeter.
Okay, that we can ignore. So on the basis of this first part of the ultrasound finding, what information you get from this as far as the diagnosis is concerned?
So this internal vascularity.
Because in the previous slide you have mentioned, no, those 3 or 4 diagnoses.
Yes, sir.
So, the consistent solid cystic lesions with that variable consistency and the internal vascularity is present.
No, see, when you are answering a question to what I've asked, there's no point repeating. No? Everybody can see what is written there, is it not? You're practically repeating
Sir,
the same.
internal vascularity, which we can go with malignant tumors, malignant conditions.
No, what diagnosis now? So the investigations are done to suggest a diagnosis. Now let's talk. Tumor is a very general term, no? Whatever diagnosis you have put, all are classified into tumors only.
Yes.
So based on that, now you tell.
So, we can sarcomas sir, from abdominal pelvic region, soft tissue sarcoma arising from abdominal pelvic region.
Possibility of a sarcoma.
Yes.
Okay. Then?
Based on the USG, the suspicious loss of fat plane with the urinary bladder, sir.
So you feel it is a tumor arising from the urinary bladder?
To be ruled out with further investigations.
That is very unlikely. It's not. To make a diagnosis because it is little bit in contact averting the bladder, I don't think that should be one of the diagnoses you should suspect. More likely means almost certainly it looks like something which is adherent to the bladder. Any other possibility? You have said soft tissue sarcoma? Possible. Anything else?
Still, the distal lymphoma can. Just lymphoma still.
Just from which part can go down and then infiltrate the bladder?
Small bowel. Still bowel. We have to rule out cysts from bowel, small bowel.
Just can produce this sort of thing. Is it not pattern? No? You can have solid cystic pattern in a gist. So the question Dr. Rajan asking, what should be the site of the gut from which the gist should be arising, which is likely to infiltrate the male patient? No? Bladder will be there very close to that.
So from colon, sigmoid colon.
Sigmoid colon, is it not?
Yes.
Fine. So possible. What is the next thing you would like to do?
Next, contrast enhanced CT will.
Why?
So to know the.
See, you already got the case, you're prepared, is it not? So be confident and answer. Go close to the mic and speak.
So to look for the extension and the site of origin. Sir.
Yeah, it's still not clear no, from the ultrasound. What is more likely the diagnosis?
Yes.
Ultrasound finding of the CT scan findings will suggest more about the diagnosis. So can you show that? You have the picture or you have the finding?
The video.
Yeah, show it.
You want me to play it again, sir?
No, you have to demonstrate. No? If you just run the video, then you'll not be able to see. You have facility to pause it?
On axial cuts, this is where the lesion starts. And this is the bladder surface. Looks the anterior wall of the bladder, the tumor abutting on the anterior wall of the bladder.
There's a fat plane there. Can you see that? It's not the full wall. Maybe a slight contact is there. Have you got a sagittal or coronal view?
No, sir.
That will give you an idea, no?
Yes,
What level the mass is there in the abdomen. Now, what are those two structures by the side of the vertebra?
This, the kidneys, sir.
You run it down so that you know. Run it up. Take it up or down, something like that. I just want to know where the mass starts. See, this is the area of the kidney, is it not?
Yes, sir.
So now the pelvis is seen there. Go up a little bit. Okay, now come down. So the mass starts quite high up, no? Yes or no?
Yes, sir.
Okay, just pause it a little bit. Now, how will you describe this mass?
So, variable consistency.
Density wise.
Yes, sir.
CT will use the term density, no?
Yes.
Yes.
Hypo and hyper heterogeneous. Okay.
We just got both, is it not?
Yes,
Yes,
both.
sir.
Hyperdense and hypodense
Hypodense.
areas. Come down. How will you know that the mass has got some fluid on CT? See the lower part of this. What you can see, now those areas, homogeneous areas.
Yes.
See this one.
Yes, sir.
So is this solid or is it fluid? How will you know?
So, it will be hypodense, like
Hmm?
hypodense. It will compare with the muscle, like it will be intensity will be less.
What?
Compared with the muscles, the intensity will be less. Like
Any
hypodense.
other ways then? More specific. What is Hounsfield value?
So the to
Who's
intensity is
Hounsfield? Why we use the term Hounsfield?
so one who found CT.
Hmm? Yes.
Intensity is named in Hounsfield's units.
Why?
Like, invented.
Yes, he's the person who invented used to be called CAT scan, computerized axial tomography, is it not? You know when? Early 80s, he invented the CT scan. So yeah, how much is a solid component? How much is cystic component? Easier to dissect, is it not? Cystic component is easier to dissect or solid component?
Cystic is
okay. So what's your impression from this? What does it look like? From the shape and the size, everything.
soft tissue sarcomas.
Possible. Okay. So if you are suspecting soft tissue sarcoma on CT scan, what are the other findings you like to look for?
The margins that's abutting any of the structures.
That is already
and,
there, you already told. Then
and any
what else?
possibility for metastasis. Metastasis things like
Sarcomas. Okay. Sarcomas, where do they metastasize?
mainly for the lungs.
Lungs. Okay. So this, have you got the lungs cut?
No.
Lung
Like,
cuts are not there, no? Is there or not there?
not this. Like it's
Not much. Okay.
only the base.
So anything else you'd like to see in what is available there in the axial thing? When you're operating a sarcoma in the lower abdomen, what are the most important things you'd like to see?
So the vascularity.
That is always visible. Does it look very vascular? Not much.
Lymph nodes.
Sarcoma, does it spread by lymph nodes?
No.
Local.
See, one of the things which is
In
very
ureter,
important, that will
retro-
decide. Yes,
ureters.
ureter. So if you want to see the relationship of the sarcoma, or sarcoma means the mass to the ureters, what sort of CT scan you should order? Then only you'll be able to see it. Otherwise, you'll not be able to see it. Request, not order.
So venous face.
Hmm?
Venous face is better.
What sort of thing? You have to have delayed films, is it not? So otherwise, what will happen is they'll finish off the CT and you'll not find the ureter. Okay, ureter, the thing has to be excreted to the kidneys into the ureter. Then only you'll see. If the ureters are very close by, in those circumstances, you will have to. If you suspecting a sarcoma and the ureters are very close by, what further investigation you'd like to do? Further procedure you'd like to do? The other investigation.
Sir, MRI to be done to involve symptoms.
Okay.
What about the bladder involvement? Which part of the bladder can you make inference? Which part of the bladder is infiltrated?
Anterior wall of the bladder.
And what about the small bowel? Because that's also one of your diagnosis, no?
Yes, sir.
Just go to the uppercuts. Is it close? Is anywhere closely related to the small bowel? That's all bladder. You have to come up. It was one of the sigmoid or a small bowel. Just anyway, I can see the bowel loop there.
Yes, sir. Bowel loop in close proximity to the tumor.
The time is limited, so quickly you tell. Next 1 or 2 minutes to finish.
Yes, sir.
Yeah. What other procedure investigation you will do? Hepatic, it's a large mass.
Cystoscopy can be. Cystoscopy.
Cystoscopy. Okay. Has it been done?
Yes, sir.
Tell the report.
Sir,
Show the report, or you tell orally.
on cystoscopy, there was increased vascularity over the anterior wall of the bladder with no infiltration into the mucosa.
Okay. So it might be just abutment.
Yes.
Okay. If the ureters are very close, then when you do cystoscopy, you would like to do an additional procedure in the form of double jet stenting.
Yes, sir.
Okay. Double jet stent means the stent on the side of the ureter, what is involved. So that when you are doing intraoperative dissection, you know where is the ureter and you safeguard. That's the aim of it. So any further investigations you've got here in this patient?
No, sir. We actually proceeded with cystoscopy and diagnostic laparoscopy.
Okay. What did it show?
Any tissue diagnosis if you attempt or?
Yes, sir. Biopsy was attempted. Two-cut biopsy was attempted, but it showed inadequate sample. So we went ahead with diagnostic
That's
laparoscopy.
where the cystic component comes, you know? So
Yes,
that,
sir.
you have guided true cut so you can avoid all the cystic areas. So that you don't get negative pathology.
Common sarcomas that you get here?
So leiomyosarcomas.
And?
Liposarcoma.
Liposarcoma. So do you have any diagnosis? Or you don't have?
Sorry, sir.
No. Have you received, have you got any final report or you don't
Yes,
have? That's the question.
Yes, sir.
Biopsy showed
Sir, biopsy showed inflammatory gave us 2 DDs of inflammatory myofibroblastic tumor with an intermediate grade and dedifferentiated liposarcoma, which is low grade, and all resected margins were free of tumor.
So this is what biopsy? Excision biopsy?
Excision biopsies.
Oh. So it's some sort of soft tissue sarcoma, is it not?
Yes, sir.
Two reports are there. Huh?
Yes, sir. They gave us 2 DDs and they asked us to proceed with immunohistochemistry for.
So what is the final diagnosis?
Final diagnosis was ALK negative inflammatory myofibroblastic tumor, sir. We've done all these immunohistochemistries.
Okay. So any role of any adjuvant therapy in this?
Sir, when it comes to myofibroblastic tumor, there is not protocol is not clear based and the data, not much data is available. So currently, surgical excision is the treatment of choice with the follow-up, sir.
So when you're doing surgery,
Yeah. So there's bladder infiltration, no? So what's to be done for that?
So a partial cystectomy could be done with free margins.
No, was it done here?
Yes, sir.
Okay. It was the dome of the bladder.
The anterior wall of the bladder was.
Okay. So it was that portion of the bladder was just excised. That's all.
Yes.
So what are the important take-home messages from this case? What you presented? Tell 5 points. Okay.
Sure.
Alternately.
The mobility.
Quickly before you finish.
On palpation, the mobility.
No, go from history itself.
Uh,
1 point at least you tell in history. That patients with large abdominal masses, which the patient can complain of, can be asymptomatic. Is it not? This patient had asymptomatic large mass.
Yes, sir.
In palpation, you tell me one important message.
Mobility on lateral, on large tumors is better to check mobility with lateral position.
Okay. Again, the same thing, that large masses, okay, in these patients, they can have variable consistency. And what you said, yes, if mobility is, we can establish, that's a good point because that is more favorable towards a excisional type of surgery. Otherwise, you might have to do subtotal sort of excision. Isn't it?
Yes, sir.
Then number 3, investigations. At least tell 2 points.
Sir, we should different CCD mainly to differentiate.
CCT, not mainly, CCT is one of the important investigation of choice in this particular suspected soft tissue sarcoma. Number 2, CCT will also show you whether it is likely to be operable or inoperable. So tell me at least 2 points which are not there in this patient, which would have made it inoperable. Inoperable means you can't do R0 resection.
If it was involving a supramesenteric artery, ureter.
Large vessels.
Large
That's the term you use. If it is infiltrating the large vessels. Okay, that is number 1. Number 2, if it is infiltrating the posterior parietis, if it goes into the vertebra, can you actually excise it?
No, sir.
No.
Can't excise. Okay, so those are the things. Bladder and all, bladder, gut, anywhere else, if it is a direct, it is excisable, is it not?
Yes.
And last point, final 5th point. You had it in this patient. You can have sometimes very odd sort of histological finding. You said, no?
Yes, sir.
You mentioned only 2 leiomyosarcoma and liposarcoma. See what does the diagnosis here, is it not?
Yes.
On IHC, they have given you a more subset of the conventional sarcomas that you get. And the role of adjuvant therapy is based on the type of sarcoma
Sarcomas.
that you get. And the best possible treatment for the sarcoma is what you mentioned, that excision is the best possible sarcoma. And what sort of excision? R0 resection, so that you don't leave behind. R1 is possible because then you might not know, but definitely you should not do, you should avoid an R2 resection. Okay, sometimes what happens is you are forced to do R2 resection because when you excise 90-95% of tumor, then you actually find out that some part of the tumor you just cannot excise. So in those circumstances, you'll have to leave. But if there is a R1 resection, which has happened, which is very not very uncommon in abdominal sarcomas, what is the follow-up of that? What is the problem that happens with that? You cannot rule out in this patient also. It leads to recurrence. Abdominal sarcoma recurrence is not very uncommon. You will find after a few years, patient comes back with another lump and will tell that 2-3 years back, I had undergone a surgery for a tumor in the abdomen.
Yes.
Before we close, any questions you want to ask us? Any clarification? Any points?
No.
Okay, fine. Well done.
Thank you, sir.
Thank you, sir. I now request the examiners to award the certificate of presentation to Dr. Shankar. And Dr. Rafiqullah. May I request Professor Dr. Jagdish to come to the dais and honor the examiners? Professor Dr. Vikram Kate. Dr. Rajan KV. and Dr. Sudarshanan S. Thank you, sirs. Thank you, Dr. Shankar and Dr. Rafiqullah. Next is a video lecture by Dr. Rajkumar N. on thoracoloscopic esophagectomy for esophageal cancer. Sir, we welcome you. I welcome the chairpersons for this session, Dr. Shanmugam D. and Dr. Sahive.
This is a marker, huh? Okay, sir. It doesn't work on the
There will be no commentary break. If anybody needs a caffeine kick, kindly go and help yourself for 5 minutes.
Yeah,
Thank you.
Interesting video, I think better not to leave. By Dr. Rajkumar. Dr. Rajkumar is our additional professor in our department. So he is one of the person who is trying to improve in the field of minimal access surgery, especially the laparoscopic surgery. Okay. So he has a lot of, I think he is one of the first faculty to do laparoscopic pancreatic duodenectomy in our department. In addition, he has done other minimal access surgery. He has presented his work on 3D lymphadenectomy, laparoscopic right hemicolectomy abroad. He was in US, one of the conference, I think, Association of Surgeons of America, right? He has published 30 research articles in national, international journals, right? And a member of Network for Oncology Clinical Trials in India for pancreas and biliary system for JIPMER. So his area of interest is advanced minimally invasive surgery in upper gastrointestinal, colorectal, and with special interest in hepatopancreatic biliary surgery. So today is speaking on thoracolaparoscopic esophagectomy for carcinoma esophagus. Over to you, Rajkumar.
Thank you, sir. Thank you for the introduction. So I'll be presenting on McKeown's esophagotomy. It'll be the McKeown's esophagotomy will be done in the following steps: the thoracoscopic part, the abdominal part, laparoscopic part, the neck, cervical esophageal mobilization, specimen retrieval, and cervical anastomosis. The video. The video. So this is the thoracoscopic part where the patient is placed in prone position. 3 ports are placed. One is 1 and 5, 7 and 9 in the prone position. The camera port is at 5th intercostal space in the posterior axillary line. The right hand and the left hand working port in the 5th and the 9th intercostal space in midway between the posterior axillary line and the posterior scapular line. And this is the thoracoscopic view in the prone position where the azygous vein is seen, and beneath is a thoracic duct. The mediastinal pleura is incised both anteriorly and posteriorly in the infra-azygously. And the azygous vein is mobilized by incising the supraazygous part as well of the mediastinal pleura. The azygous vein is isolated and clipped using hemolock. First in the posterior aspect, because the direction of flow is from posterior to anterior, and it's cut using ligature. Then the mobilization is continued anterior to the esophagus near the carina. So that's the main bronchus with the esophagus and the bronchial artery and the right main bronchus. The dissection is continued posteriorly to the esophagus onto the left-hand side, dissecting all the paraesophageal tissues. This is a posterior dissection of the esophagus being carried out. And this is the dissection carried between the pericardium and the anterior surface of the esophagus, wherein umbilical tape is placed. Using the umbilical tape as a guide, posterior esophageal dissection is carried out, and the esophagus is hooked with the umbilical tape, and the dissection is carried out in the same plane. There's one of the lymphatic in the lower esophagus which is going to be clipped. And further mobilization is being done towards the diaphragmatic part of the esophagus. That's the inferior pulmonary ligament which is being released. This is on the posterior aspect towards the diaphragm. On the left side, the paraesophageal tissues along with the supradiaphragmatic lymph node is being dissected off. This is the crura. And now you'll be seeing the edematous crura because of the neoadjuvant therapy received by the patient. That's the crura there. And still some additions were present onto the left side, which is being released off. It's a lower esophageal tumor. That's why there's a lot of additions and edema around that area. So now the distal esophageal mobilization is complete. Now we are proceeding on to the supraazygous part of the esophageal mobilization. Since this patient is a lower esophageal tumor, I didn't carry out a rectal laryngeal lymph node dissection. This is the bronchial artery on the right side, which is going to be clipped. And the dissection is being continued posterior to the esophagus. That's the membranous part of the trachea below. And the esophagus is carefully dissected between the membranous part of the trachea and the anterior surface of the esophagus. The upper extent of the dissection is up to the inferior thyroid artery. And now I'm proceeding with the infracarinal lymphadenectomy part, where the inferior pulmonary ligament is being dissected from the lung. Using a harmonic is one of the best instruments for sharp dissection. The infracarinal lymphadenectomy is being carried out now. The bluish black lymph nodes around the right bronchus, the inferior surface of the right bronchus is being released from its attachments. And most of the time, the infracarinal part bleeds a little bit. So with compression, it stops. And the dissection is being proceeded. In the same infracanal, you can see the carina there. The dissection is proceeded onto the left side on the inferior border of the carina. Once that is done, the fatty tissues of the lymph node is being taken off from the infracarinal region. So this is the last part of the infracarinal lymph node dissection. That's done. And that's the pericardium below. The entire esophagus is mobilized up to the hiatus. And here I'm showing the left recurrent laryngeal nerve, which is hooking around the arch of aorta. That's the arch of aorta with the left main bronchus and the left recurrent nerve. Even though I have not dissected it, I'm just showing for the. And that's a right vagus nerve. To trace that, that's the right subclavian on which the right recurrent nerve takes the turn. So that's the pericardium with the inferior pulmonary vein. So all the fatty tissue in the infracarinal area has been removed. And the infracarinal area with the left main bronchus there. So the esophageal mobilization part is almost done. Again showing the right recurrent laryngeal nerve hooking on the right subclavian. That's a right recurrent nerve hooking around the arch of aorta. This dissection is especially carried out in mid-thorax tumors. Since it's a lower thorax and G junction involved, I didn't carry out the lymph node dissection. Moving on to the laparoscopic part where the gastric. The port positions are usual. Umbilicus, left and right mid-clavicular line with two retraction ports, one in the epigastrium and one in the left flank. The gastrocolic momentum is incised and the lysosac is entered Stomach mobilization is started along the greater curvature, carefully preserving the gastroeploic arcades and clipping some of the short gastric vessels. That's a spleen. Clipping the short gastrics. And the right side mobilization is complete towards it. Now it is towards the pylorus side. And again here we have to preserve the right gastroeploic artery. The extent of dissection on this side is seeing the infrapyloric vein. So the additions between the duodenum and the pancreas has been released. Now on the lesser curvature side, the lymph node dissection is being carried out now, starting at the superior part of the pancreas. In a moment, you'll see the common hepatic artery and the lymph node tissue anterior to the common hepatic artery is being dissected off carefully. That's a common hepatic artery. All the fatty tissues on anterior to it is being removed with sharp dissection and proceeded till you see the right gastric origination. That's a small twig which takes out from the proper hepatic, the right gastric artery. That's being clipped now. Then the lymph node dissection will be carried out towards the medial side, towards the origin of left gastric and splenic. That's a portal vein there, seen. Here I dissected the posterior 8P also, posterior nodes, which is not usually required for the demo purpose. Common hepatic artery being stripped of all its lymphatic tissues. And the dissection is continued along the superior surface of the pancreas, which reveals the left gastric vein, the splenic artery. The left gastric vein is being clipped and cut. Then the section is proceeded along the celiac trunk. All the lymphatic tissue along the celiac trunk is being released off. That's a celiac trunk there. After dissecting the celiac trunk, the left gastric artery is being isolated here. And clipped. Then 11P nodes, the proximal splenic artery nodes will be dissected now till the origin of the posterior gastric. Now the phrenicoesophageal membrane is being, and the thoracic dissected area has been entered through abdomen. This is the last portion of the abdominal part where that's the posterior gastric artery, which is being clipped. So for esophageal tumors, this is the extent of D2 lymphadenectomy you will do here. 11P, this is 11 proximal splenic artery. On the right side now, on the left crura, we have entered into the thoracic part, the dissected area. All the additions of phrenicoesophageal membrane around the crura is being isolated here. So now the esophagus and the stomach is mobile. That's the tumor part in the lower esophagus. Now the cervical esophageal mobilization. A J-shaped hockey stick incision is made along the anterior border of the sternocleidomastoid up to the sternal notch. Incision is deepened. And after laterally retracting the sternocleidomastoid, sometimes I do cut the staph muscles, sometimes I don't. But the omoid will be cut. The esophageal here is hooked, and periesophageal dissection is done. And the esophagus is cut at the level of this thoracic inlet. The distal esophagus is sutured to a Riles tube, and the specimen is pulled through the abdomen. So there you can see the specimen being pulled through the esophageal hiatus. The next step would be specimen retrieval and condo preparation. A small incision is made in the epigastrium for a length of 5 centimeters. And a wound protector is put. The stomach, mobilized stomach, along with the esophageal specimen is taken out. And the greater curvature, some of it be trimmed because it has to pass through the hiatus, carefully again maintaining the arterial arcade. Then staplers on the fired from the lesser curvature to prepare the stomach for a condo for a length for the width of 4 centimeters, 4 to 6 centimeters, starting just 4 centimeters above the pylorus. Earlier I used to oversew the staple area, now I don't. And the stomach is pulled through the esophageal hiatus in the posterior mediastinum carefully with gentle traction onto the next side. A cervical anastomosis is being fashioned here. Here I did the modified Collard's technique for the anastomosis, the posterior wall of the esophagus with the posterior wall of the condo using a 60 mm blue stapler. And another stapler applied transversely. That completes the procedure. Thank you.
Hi, Rajkumar. It's
Yes,
a
sir.
very nice presentation. It has
Thank you.
demonstrated all the major steps in thoracolaparoscopic aspiration. The only thing is that how do you safeguard the thoracic duct, or do you use any fluorescent imaging?
No, I don't. Until now, I have not used any fluoroscopic guided. It's just to stay away from the lower aspect of the esophagus.
Do you use ICG?
No, I have not used it till now.
Have you got any incidents?
No, sir.
of
No, sir.
thoracic
Not yet.
duct injury?
Not yet.
Yeah, like.
A very nice demonstration.
Thank you.
My question is, how do you decide to do a thoracic first or abdomen first?
If the patient has undergone an FJ already, then the diagnostic laparoscopy is done. And in patients where it's an adenocarcinoma, then a diagnostic laparoscopy is must upfront before putting the patient in prone position. Or if you're planning for an IV Lewis, then abdomen first approach is done.
So what is your practice in doing a lymphadenectomy?
I've done both standard and total lymphadenectomy as well. In this case, that didn't require a recurrent laryngeal nerve lymph node dissection, so I stopped with infracarinal. For mid-thoracic tumors, yes, I did bilateral recurrent laryngeal nerve lymph node dissection.
Actually, you have demonstrated the advantage of prone position for
Yes,
laparoscopy.
yes.
We can do either in a lateral position or
Semi-prone.
position.
Yeah, in semi-prone.
Semi-prone or prone position. The advantage of prone is that one, we need not have a double lumen
Yes.
theoretically.
Yes. Yes.
We can collapse the lung with just the pneumo, which you put either 6 or 7 of CO2
Yes.
percent. The disadvantage is that if any catastrophe happens, the
Thoracotomy
possibility
becomes.
of opening is
Yes.
difficult. But with practice and with expertise, the conversion rate is much less.
Yes. The only place where there will be a lot of bleeding is esophagus vein. If you can take care of that, I think
Yes.
the rest of it is fine.
You have demonstrated excellently.
Thank you,
Very
sir.
good video.
Thank you, sir.
Did you do pyloroplasty or pylorodilatation?
Earlier, I didn't do pyloroplasty regularly, sir. But off in the last 2-3 cases, I've opened the stomach on the lesser curvature, introduced a sponge holding forceps, and did a manual dilatation of the pylorus.
Excellent video.
Thank you, sir.
Thank you very much.
Thank you.
Any questions from the floor? Anybody wants to ask? Okay, we'll move
Thank you,
because it's already running.
Thank you, sir, for that very interesting session. I request the chairpersons to felicitate Dr. Rajkumar N.
Thank you, sirs. I request Dr. Deepak Verma to kindly remain on stage for the next session. Next up, we have a case presentation on obstructive jaundice by final year postgraduates from Arupade Vidu Medical College, Dr. Soundarya and Dr. Pavitra. The examiners for the session would be Professor Dr. Vikram Kate, Professor Rajan KV, and Dr. Deepak Verma. I welcome the examiners onto the dais.
So this is a case of obstructive jaundice. Please carry on.
Good evening to one and all present here. I'm Dr. Pavitra and this is Dr. Soundarya, junior residents from Arupade Vidu Medical College. We are here to present a case on obstructive jaundice. Case history: a 63-year-old female hailing from Kadalur, homemaker belonging to lower socio-economic class, came to OPD with chief complaints of yellowish discoloration of urine and eyes for the past 2 months, complaints of passage of clay-colored stool for the past 1 month, complaints of generalized body itching for the past 1 month. History of presenting illness: patient was apparently normal 2 months back, after which she noticed yellowish discoloration of urine, which was insidious in onset, gradually progressed in 2 months. History of yellowish discoloration of eyes, which was noticed by a family member, and it gradually deepened in last 2 months. History of generalized body itching present for the last 1 month. History of clay-colored stools for the past 1 month. History of loss of appetite present. History of loss of weight present. No history of hematemesis or melena. No history of nausea or vomiting. No history of abdominal distension. No history of fever, chills, or rigor. No history of cough, hemoptysis, or breathlessness. No history of headache or seizure episodes. Coming to the past history, patient is not a known case of diabetes mellitus, systemic hypertension, tuberculosis, bronchial asthma, coronary artery disease, thyroid or seizure disorders. No history of any previous abdominal surgeries. No history of any previous blood transfusions. Personal history: patient consumes a mixed diet. History of loss of appetite present. Sleep pattern disturbed. History of passage of clay-colored stools present. No changes in the bladder habits. No history of addiction or any substance abuse. Menstrual history: Patient attained menarche at 13 years of age, regular 3/28 cycles, normal flow, obstetric history, para 1, live 1, normal vaginal delivery, attained menopause 10 years back. Family history, no history of any malignancy in the family. Summary, a 62-year-old female with no known comorbidities presented with painless progressive jaundice for the past 2 months, associated with generalized body itching for the past 1 month, and passage of clay-colored stools for the past 1 month. History of loss of appetite and unintentional loss of weight present for the past 1 month.
Coming to the general examination, after getting consent from the patient, examined in the
Just a
daylight.
minute, before you go on to the examination, okay, from the history, what do you think?
Sir, from the history, I would, since there is a painless progressive jaundice, I would think of progressional diagnosis of obstructive jaundice with malignant etiology. Since there is loss of weight.
That's more of textbook description, but we don't normally see in practice, no? They'll have some sort of pain. So it's the textbook we mentioned many years back. It's no painless breast lump is painless, but it doesn't happen like this. Most often you do get significant number of patients with pain. What's the reason for pain in obstructive jaundice? Any reasons?
Retroperitoneal neural invasion.
So in case of carcinoma head of pancreas, we are suspecting the retropancreatic nerve infiltration will be the cause of pain. And
Locally advanced. Any other reason?
and stretching of liver capsule, Glissen's capsule, in case of obstructive jaundice with hepatomegaly.
Yes, that is one of the common causes of pain because many patients with obstructive jaundice will have cholestatic hepatomegaly. So that is one cause. Any other cause? Which is common?
Pancreatic duct dilatation in case of periampullary carcinoma.
Yes, that is the other cause of pain. So these are
Cholelithiasis.
What type of pain will this lead to?
Intermittent.
What these two things, what you're told? It may be a dull aching type
Dull
of
aching.
pain, is it not? When you have distension of pancreatic duct or when you have stretching of the Glissen's capsule. What you mentioned that when there is infiltration into the posterior apparatus leading to pain, that will be moderate to severe type of pain, boring pain, radiating to the back. Okay, so that has to be elaborated.
Can this be a gallstone disease? Cholelithiasis.
Yes, sir. Patient does not present with any fever, sir. Pain, it's a progressive jaundice. And there
In
is
case
loss.
of cholelithiasis, patient will have intermittent type of jaundice. Here, the patient doesn't give a history of any waxing and waning or intermittent jaundice.
And also there is a history of loss of weight and
Waxing and
appetite.
waning is different. Intermittent jaundice is different. You cannot mix up the two things. No? Is it?
The typical history of a gallstone disease would be the patient usually will have recurrent episodes of pain. What is the typical pain of biliary pain?
Colicky
Can
pain.
you describe a typical biliary pain?
Colicky pain radiating to shoulder, left shoulder. Right shoulder.
You can decide left or right.
Right shoulder.
Right. Okay. So it's not colicky actually. What is typical colicky is it should come and
So you have to approach on history in an algorithmic manner. So first you said it is jaundice. Patient has come with jaundice. Number two, you said it is obstructive jaundice. You said that, is it
Yes,
not?
sir.
Why did you say this is obstructive jaundice?
This patient is having
Use the
yellowish,
mic, please.
patient's having yellowish discoloration of urine and patient's having itching and clay-colored stool, passage of clay-colored stools.
High color urine, clay color stool, and
Presence of itching all over the body.
history suggestive of pleuritis. So if these
Pleuritis.
things are there, suggestive of obstructive jaundice.
Yes, sir.
The next question is whether it is benign or malignant. That was already asked. So malignant cause, one of the commonest, the benign causes, one of the common causes is ciliary stone obstruction. Is it not? Choledocholithiasis. So you have answered that the patient usually has intermittent jaundice. Here the duration is continuous for 1 month. So that is what it is unlikely to be a case of
Benign.
Cholelithiasis.
cholelithiasis. But can you have any other benign cause of jaundice which can be progressive and the cause is benign.
Biliary strictures.
Due to what?
Previous ERCP, any intervention.
Then that.
Lab cholecystectomy.
Good. So did you ask the history, something like that?
Yes,
If there
happened
is
in
no
this
history.
patient?
No, patient does not underwent any
Any
lab cholecystectomy, abdominal surgeries.
It's a very common and very unlikely. Any other benign condition you know which can lead to obstructive jaundice? As has been told, ERCP it is extremely rare, but more often than that. Chronic pancreatitis, can it lead to lowered biliary stricture and jaundice? Okay, so there are some other causes also, benign conditions, but we'll not go into that. So you said malignant obstructive jaundice. That's what you said in history. So because the patient has progressive jaundice, 1 month jaundice, continuous jaundice, what's the age of the patient?
62, sir.
62, elderly patient. So combining all these things, possibility is there of malignancy. But you stopped at that. When you are diagnosing malignancy, you also have to go a little bit more in depth to find out what could be the cause based on history. So can you tell some pointers in malignancy or in history that will suggest that this could be this malignancy, which is leading to obstructive jaundice?
The
Can you
patient
tell
does not.
4 or 5 symptoms which can help you in making a diagnosis, provisional diagnosis of the cause of that obstructive jaundice?
It's a progressive jaundice, which is not waxing or
Close to the mic.
It is a progressive jaundice, not waxing or waning, sir. And there is no history of melena.
That is suggestive of malignant jaundice. I'm asking the conditions. To give you an example, if the patient has moderate to severe pain radiating to the back, there is a possibility of carcinoma head of pancreas, like that.
Yes. Patient does not give a history of melena, sir. So we can rule out periampullary carcinoma.
No, that's not correct. Okay, first of all, melena is not very often seen in periampullary carcinoma. So that's not correct. Anything else? This patient does not have this. So it does not having does not rule it out. But can you tell if what symptoms, if present, can help you in making a diagnosis? That's the question. I'll give you another example. If the patient has vomiting and is suspecting the patient to
Yes.
have gastric outlet
Yes.
obstruction, what will you suspect?
So, in a CA head of pancreas, it will sometimes in advanced stage, it will present as a gastric outlet obstruction
Due to?
due to duodenal
Excellent.
growth.
That's what I'm asking you. Any other things are there which can help you in making a diagnosis?
Patient will have bilious vomiting.
No. Now go to the next. Any other symptom which can be there? Suppose patient presents with a mass in the right hypochondriac region. What is the commonest cause for the mass in a patient with obstructive jaundice?
So, hepatomegaly.
Anything else?
So, cholecystitis also.
You're talking of malignancy. Now don't switch over to something else.
CA gallbladder, sir.
See a gallbladder.
Gallbladder.
Okay, although it is spelled as Gall, it is pronounced as Goll. Gallbladder. Okay, yes. CAGB is one of the things not common here in the south. But if the patient presents with a mass in the right hypochondriac region and some pain associated with that, you have to suspect this could be a case of, when the patient is a female patient, suspect it to be a case of carcinoma of the gallbladder. So if all these pointers are there, it can suggest the patient has got bleeding PR. Okay, elderly man. When the patient has got a mass in the right hypochondriac region and jaundice, what will you suspect? Obstructive jaundice. I've already given you all the
Sir,
findings.
it could be due to hemophilia.
Not hemophilia. Multiple secondaries can happen, can lead to obstruction of major ducts, can lead to jaundice, is it not?
Okay.
So all those things you have to keep in mind, which can be present. If they are present, they can be suggestive of some conditions. If they are absent, they do not rule out anything. If they are absent, they do not rule out anything. If there is no waxing and waning of jaundice, it does not rule out periampullary carcinoma. That's the point which you should remember. If waxing and waning is present, it may suggest periampullary carcinoma. What type of jaundice that is called as? One you told intermittent jaundice. When there is waxing and waning of jaundice, what is it called as? Waxing and waning means the jaundice is still present. The jaundice does not go away. So what is the term used for that? Have you heard of remittent jaundice?
Remittent.
What do you mean by that?
Jaundice is not completely
Resolved. Okay.
resolved.
Yeah.
Malignant obstructive jaundice, which condition produces? You already said, discussed. Just one more aspect of that. Which condition can produce waxing, waning under malignant obstructive jaundice?
So, distal cholangiocarcinoma and periampullary carcinoma will.
The thing is said.
Distal cholangiocarcinoma.
Which type of cholangiocarcinoma?
Uh,
Normally it occupies the whole limb, so it's usually progressive. But there's a variant of cholangiocarcinoma can produce, can have intermittent jaundice.
Papillary, intraductal papillary, polypoidal. Coming to the general examination, after getting consent from the patient, examined in the daylight with adequate exposure. Patient is conscious, oriented to time, place, and person. Patient is moderately built and nourished. Afebrile and hydration is adequate. Icterus present. Pallor could not be assessed. No cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Scratch marks present all over the extremities, and ECOG score is 1. Coming to the vitals, pulse rate of the patient is 66 beats per minute. Blood pressure is 112 per 78 millimeter mercury. Temperature is 97.8 degree Fahrenheit. SpO2 99% in room air, and respiratory rate is 16 per minute. Per abdomen examination, inspection.
Point of view, the exam will say 66 per minute. I know it's borderline, but the question will be that patients can have
Bradycardia, sir. Yes, sir.
What's the reason for that?
So deposition of the bile salts in the SA node. Deposition of the accumulation of the bile salts in the SA node, and it will cause the reduced myocardial contractility, and patient will have
The rate. That's the rate.
Okay.
But this is the SA node. That's the possible explanation. No.
abdomen is normal in shape and contour. Umbilicus midline inverted. All quadrants moves with respiration. Scratch marks present over the abdomen. No dilated veins or scars. No visible gastric or intestinal peristalsis. No visible pulsations. No visible lump or mass. Hernial orifice is free. Flanks free. No renal angle fullness. External genitalia is normal. No left supraclavicular fullness noted. Coming to the palpation, no local warmth. No non-tender, and abdomen is soft. A palpable globular mass of size 8 × 8 centimeter present in the right hypochondrium, 4 centimeter below the right costal margin. Medial border is from 5 centimeter lateral to the midline. Lateral border 3 centimeter medial to the anterior axillary line, and the lower border is 8 centimeter from the costal margin. Surface is smooth, firm in consistency, well-defined border, and it moves with respiration, and side-to-side mobility is noted. Plane of the swelling is intra-abdominal, and on knee elbow position, mass falls forward, and it confirms it is intraperitoneal.
Pause for a minute. There are so many findings, which doesn't add, or it's too many findings which you don't need to do, or you don't have to mention. We're not sure whether you've done all this. Because once you say it moves respiration, then all becomes superfluous, all your other findings. Why knee elbow position for a swelling which moves respiration? Doesn't add.
Okay.
So probably you've done everything for this patient. You tried all maneuvers for this patient. So which we may not need to do.
Okay.
Once you said that the mass moves respiration, then there is no other information you're going to gain by putting the patient in knee. Very uncomfortable. You really put the patient in knee elbow position. It's not a very comfortable position. So don't try to subject the patient to the awkward position. If you're the last case, don't differentiate intraperitoneal, retroperitoneal masses. You put them in lateral, depending on where the mass is. Okay.
Finger cannot be insinuated under the right costal margin. Liver palpable 4 centimeter.
The postgraduate level. Okay, I don't think that para should be mentioned. The undergraduate level, I can understand. You're presenting in a postgraduate examination, the findings should be mentioned very quickly and fast. What you have put for the second bullet, obviously you are trying to tell that this is the
Distended gallbladder.
gallbladder which is
Distended.
palpable. So I think in a PG exam, if I ask you why do you think it's a gallbladder, it's a different thing. Then you can mention 2-3 points.
Okay, sir.
Otherwise, that is not necessary. Okay. If you have a doubt that it could be a gallbladder or it could be something else, like it is not, what is the consistency form? Instead of that, if it is hard in consistency and the liver surface is also nodular, so you do not, you're not sure whether it's a nodule from the liver or it's a gallbladder, then you're fully justified in mentioning like this, what you're told. 3-4 lines you can tell. When you don't have a doubt, globular swelling, okay, there is hepatomegaly, smooth surface, is it not? You mentioned surface and all the liver, you not mentioned that. So all those things, if it is there, better to be straightforward, okay? So that you don't spend too much time in explanation. Go ahead.
Liver palpable 4 centimeter below the right costal margin. No splenomegaly. No other palpable mass in the abdomen. No palpable left supraclavicular node. Percussion, liver dullness noted from 4th intercostal space in right midclavicular line till 4 centimeter below the right costal margin. Liver span is 14 centimeter. Dull note over the mass, which was continuous with the liver dullness. Tympanic note over the rest of the abdomen, and no shifting dullness. Auscultation, normal bowel sounds heard. Per rectal examination, no growth or deposits. Glove stained with clay-colored stools. An examination of the other system, respiratory system, bilateral normal vesicular breath sounds, and no adventitious sounds heard. CVS, S1, S2 heard, no murmur or added sounds. Central nervous system, no focal neurological deficit. Summary, from the clinical history and the examination, a 63-year-old female with no known comorbidities presented as painless progressive jaundice and with a history of generalized body itching for 1 month, and patient has history of clay-colored stools and history of loss of appetite and unintentional loss of weight for 1 month. And general examination, scratch marks all over the body present, and the patient has icterus. Per abdomen examination shows distended gallbladder with hepatomegaly. From the history and the clinical examination, I would like to give my provisional diagnosis as it is a case of obstructive jaundice, malignant etiology, probably due to carcinoma head of pancreas.
Why do you specifically take the diagnosis of carcinoma head of pancreas as the first one? Why can't it be periambulary?
Sir, as the typical history, like history of waxing waning and history of melena is not there, I would like to, and more obstructive jaundice with malignant etiology is more common towards CA head of pancreas than ampullary carcinomas, periampullary.
Like Katesa told, waxing and waning, if it is not there, it will not rule out periambulary.
Okay.
But, that is an additional finding in the history.
Okay.
So what other features are pointing towards carcinoma head of pancreas in the history, in the this patient?
The patient doesn't.
In this patient, what other points are pointing more towards carcinoma head of pancreas rather than periambulary or ampullary cancer?
The patient has distended gallbladder and hepatomegaly.
Yeah, that means it is obstructing somewhere below the cystic duct, somewhere in the distal bile duct.
Yes.
Bile, this complete obstruction. Yes. From the history, what is the most prominent symptom of head of pancreas malignancy? It is one of the silent killers of abdominal malignancies, where loss of weight and loss of appetite are more prominent probably before the jaundice comes. If it is in the lower part of the head of pancreas, it might not obstruct the bile duct initially. So these two will point towards carcinoma head of pancreas. Cholangiocarcinoma CBD, why do you consider that?
Sir, distal part of cholangiocarcinoma is also a component of periampullary carcinoma. That's why it will cause obstructive jaundice. Okay.
GB carcinoma, no? How to explain liver and distal gallbladder? Consistency.
No.
And then lymph node mass photohepatitis, that will be automatically ruled out.
Yes.
Double test also, no pain. Like
Once you have lymph node mass photo, no, you'll have distal gallbladder.
Yes, a patient has distended gallbladder. No, sir. It is above the level of gallbladder. It won't.
So why, my question is why the diagnosis, why number 1 and number 2 you are put at the top? If you ask that question, how will you justify it?
Sir, cholangiocarcinoma, it is very rare to present with.
No. Why those 3? That's the question.
Sir, the patient has short duration of
It is
history.
correct to put the 3, but why those 3? Yeah.
Sir, considering the age of the patient and the short duration of the history, sir, more towards malignant.
Can be for 4 and 5 also. See, the answer for that should be that in this patient on physical examination, the gallbladder is palpable. Since the gallbladder is palpable, the likely obstruction is at the lower end of the common bile duct. And at the lower end of the common bile duct, there are 3 common disorders which can lead to obstructive jaundice. They are periampullary carcinoma, carcinoma head of pancreas, and lower end cholangiocarcinoma. We don't use the word CVD cholangiocarcinoma, lower end cholangiocarcinoma. Because theoretically, you can have a CVD cholangiocarcinoma in the middle also, is it not?
Yes.
That also can produce a dilatation of the gallbladder if it is beyond the level of cystic. That doesn't happen there. Cholangiocarcinoma happens commonest in the confluence, then it happens at the bottom. In between, it is very rare. So that is why you should justify your put. Only thing is, it can, number 1 diagnosis can still be periampullary carcinoma in this patient. And the DD can be carcinoma head of pancreas because at least in history, there is no evidence of any obstruction. Repeatedly, you're telling about melena. If melena is there and obstructive jaundice is there, you have to suspect carcinoma head of pancreas and not periampullary carcinoma. Periampullary carcinoma is a very tiny tumor. So if you have bleeding, it is very minimal. So when you have minimal bleeding, it will not produce melena in the stool, but it will produce something else. What is that?
Silver paint stools. Silver colored stools.
Yes, silver color stool. Do you know the sign for that? What is it?
Thomas signs.
Thomas sign. So everything you know, then why you are telling repeatedly? 2-3 times you told melena. So if at all there is bleeding and if at all it discolors the stool, it will be in the form of a silver color stool. Silver color stool is something like that clay color stool, little bit darker version of the silver. If you have seen oxidized silver, that sort of thing, it will look like that. But melena is due to when you have carcinoma head of pancreas infiltrating the duodenum and from that bleeding occurs, then you can have melena. Or if a patient has got carcinoma stomach with porta-hepatis nodes, what you have put number 5.
Yes, sir.
Okay, CS stomach can always lead to some bleeding and melena. So those things are not common. So that's the why you have put this as a list. And it is acceptable provided you remove number 3, number 4, because it doesn't look like that on palpation, and number 5. So you should have put number 1, 2, 3 only in this patient.
Okay.
Okay, proceed. Now you have to, this is the diagnosis which is acceptable. Okay, and then you are now going to investigate. So we already discussed in the last presentation, how do you chronologically arrange ask for the request for the investigations. Continue.
So, to confirm the diagnosis, I would like to do a basic investigation like liver function test and USG abdomen to look for intrahepatic biliary radical dilatation.
Don't club the investigations. Right now you have in front of you, is there ultrasound there? This is not ultrasound. I'm not asking that. I'm saying what you are projecting is not ultrasound.
Yes.
Talk about what you are projecting.
I would like to do liver function test and complete blood count, coagulation profile, In a liver function test, total bilirubin and direct bilirubin was elevated.
Don't read out everything, only interpret.
Sir, as this patient has elevated bilirubin more than 10, more towards the obstructive jaundice of a malignant etiology, and the direct bilirubin, conjugated bilirubin was elevated. It is more towards the obstructive jaundice post-hepatic cause, and ALP is elevated, and most of the biliary carcinoma, ALP will be elevated. And
Don't use the SGO.
AST and ALTs. Both are
Normal.
It is normal. Sir, some sort of liver involvement is there. Sir, in hepatocellular dysfunction setting. Cholangitis. Coagulation profile and CBC was normal. Hemoglobin level 10.1. Patient is anemic, and total leukocyte count was normal. Platelet was normal, and coagulation profile also normal. RFT, LFT is normal.
Here in this, when you look at the liver function test, hemogram and the renal function test, what are the important things you should look for when you are that means when you're planning to treat this patient?
So, if the patient has anemia, we have to correct it before surgery. And
just particularly to this patient with obstructive jaundice, that is our subject.
So coagulation profile and cholangitis, we should rule out.
That's what I told. That's so. If the transaminases are elevated, that means there is some inflammation going on in the liver. Then what will be the other sign of cholangitis? Other investigation, what will you find? In other blood parameter.
WBC counts will be elevated.
What is the third one we should look for in the renal function test? Look for the creatinine. So if there is a renal failure, these are the three things which will alter the management. Even if you are planning for surgery, whether to plan for something to reduce jaundice or something like that. These are the three key things we need to look for in the liver function test, CBC, and the renal function. And of course, coagulation profile, because if it is deranged, we should correct it.
Any reason why you have done amylase lipase in this patient?
Sir, in case of chronic pancreatitis, it will lead to.
Is there anything to say from the history or examination? Then most often we will not find. History is very reliable for chronic. Is there anything to suggest we should do amylase lipase in this patient? It's not needed. This patient given acute abdomen, he thought that the tumor is producing acute pancreatitis. Sometimes it can produce. Exhausts the duct. It's all rare presentation. We don't know the other reason for abdominal pain in carcinoma pancreas, nor periampullary carcinoma. Those tests. Lipid profile, that may be routine, I think.
Yes, sir. Lipid profile, total cholesterol, triglycerides, LDL.
One of the other things which is important is you should always look for the albumin level.
Albumin.
Okay. In this patient, I think the total protein I saw was 6.9.
6.9,
That
normal.
must be fine.
Yes.
But that's very important because that is one of the very important determinants of management.
Okay.
On examination, if you find edema feet, and on investigations, you find the albumin is less than 3 or less than 2.5, then it becomes a problem in the management. Continue. Why the cholesterol is so much high here?
Sir, as the patient has obstructive jaundice, bile salts could not reach the gut, which is important for the fat absorption.
So will
Cholesterol.
Will it rise or it will come down then?
It will rise.
Correct. I need to check it out because if fats are not absorbed, how the cholesterol is LDL is some 300 plus, 350 plus. Is it not? So if you find something like that, as a clinician, what's the first thing you'll do? Should repeat it, is it not?
Yes.
If it does not fit in the clinical scenario, because this is very, very abnormal what you have showed there. So you have to repeat and find out. You see, sometimes patient could be having a coexisting disease.
Okay.
What is the explanation you told? I don't. Why should cholesterol increase?
Sir, actually, as the patient has obstructive jaundice, bile salts will not, which is responsible for the cholesterol fat absorption in the gut. So, hyperlipidemia will be there in the patient.
No, cholesterol is not absorbed, it should not increase.
And-
I don't know why, I don't know that why it increases or decreases. But this explanation doesn't, I'm not sure. Anyway, we'll go for the next.
Ultrasound abdomen.
Don't read it. What you would like, what is the information you are seeking from the ultrasound in your patient?
Sir, I would like to see the intrahepatic biliary tree and extrahepatic biliary tree, liver for any hepatomegaly and liver secondaries, and gallbladder distended or not.
That's not the way to tell in the post-grad exam. How do you say, I would like to see this tree, that tree? Not like that. What is your aim? That's what I'm asking.
Level of obstruction.
Yes, that's how you should start. The level of obstruction, which you will determine on the basis of dilatation of the intra and extrahepatic biliary radical dilatation. That's how the complete answer should be.
Okay.
So, if you're suspecting obstruction at the lower end, what will be the picture like?
Sir, distal CBD obstruction.
You're answering well, so just be a little confident to answer. Yeah.
So in distal CBD obstruction, the patient will have dilatation of the intrahepatic radicals, distended GB and mid CBD. The end upstream.
Radical dilatation also up to the lower end. That's how you tell, is it?
Okay.
This is what you'll find. So this is your first aim. What is the next aim on ultrasound?
Sir, I look for pancreas head.
You'd like to look for whether any primary is visualized. Okay. Most likely in ultrasound, you may not be able to see in a situation like this when there is a lower end obstruction. Most likely. So indirect way, can you determine something there? Indirectly, that means there is a lower end obstruction, which is leading to obstruction to the pancreatic duct. CBD, you already told it will be dilated.
Yes.
Apart from that, can you have dilatation of the pancreatic duct? Both that does dilated, what it is called as
Double duct sign.
So will you not look for that
Yes.
if it is there? Number 3, what will you look for? You like to look for the liver.
Liver.
Suspecting malignancy
Yes, sir.
can produce secondaries. These are
Secondaries.
things which are picked up on ultrasound very well. That's what I'm saying. Not number 2. Double duct may or may not be there, but ultrasound, the dilatation will be picked up. Gallbladder dilatation will be picked up. Ultrasound, the secondaries in the liver will be picked up well. What else will be picked up very well on ultrasound?
Free fluid.
Free fluid. Excellent. Then in addition to that, you look for any lymph nodes or any other intraperitoneal deposits which may or may not be picked up on ultrasound examination. So with these things in mind, see, your mind should be prepped up what I am looking for in the ultrasound. So when the report comes, you focus on those points and pick up those points on the ultrasound examination. So with this background, now you see what is mentioned in the ultrasound. All right.
Intrahepatic biliary radical dilated, cystic duct is dilated, proximal CBD dilated with narrowing noted at the mid CBD. Rest of the CBD is not visualized, obscured by the bubble gas. GBD is distended, minimal free floating sludge noted. Hepatomegaly with grade 2 fatty liver is there. Pancreas normal, no free fluid in the abdomen or pelvis.
What we discuss, is it not everything is mentioned there? Is it not?
Yes.
So how do you interpret this ultrasound?
The patient has hepatomegaly and distal CBD obstruction could be there. And the CA head of, pancreas is normal, so most likely to be the distal cholangiocarcinoma. Pathology in the distal CBD.
It's written narrowing noted at mid CBD. Rest of the CBD distal to that is not seen.
Yes.
So are we changing the diagnosis now?
Mid CBD.
Mid CBD.
So from the ultrasound.
Yes, sir.
So is it still see a head of pancreas or is it something else?
Pancreas is normal as as given in the ultrasound. So mid
Consider cholangiocarcinoma.
cholangiocarcinoma of mid CBD.
Mid CBD, it
Yes.
can be mid CBD, what is wrong?
Okay.
That's very unusual diagnosis. Whenever you make a very unusual diagnosis, see, they have written very clearly that due to the bowel gas, they could not visualize it very clearly. Okay. Possibility is there, but it's a very rare diagnosis. When you make a rare diagnosis, you are rarely correct. So that's the point which is not very clear from the ultrasound. Otherwise, the liver looks all right, except for little enlargement and there is no free flow. So what next?
Sir, I would like to stage the disease.
When it is written pancreas normal, remember in ultrasound does not mean that pancreas is normal. I told you that ultrasound cannot image the head of the pancreas area very well. Okay. So you can always have a false negative finding. So it appears normal on ultrasound. That's not an investigation which has got a high efficacy to assess the head of the pancreas. Okay. So it can be normal. It might be abnormal. All right.
Why pancreas cannot be assessed with ultrasound?
What's the reason? Particularly the head area.
Sir, C loop of the duodenum is
Can have
So,
gas.
Yes.
Ultrasound cannot penetrate two things. What are they? One is gas. What is the other thing? If it would be penetrating, Hounsfield would not be known. What is it?
fluid.
collection.
The bone.
Oh.
Ultrasound cannot go through these two things. Otherwise, you'll not require a CT scan, is it not? So, carry on. Proceed.
So what will you do next? So we have a suspicion of a CBD obstruction, malignant obstruction. What is the next after ultrasound? What is the next investigation?
To confirm the diagnosis, MRCP, I'd like to do.
Not MRCP. You already shown one investigation. How you jump to MRCP? In chronological order, you have to go.
CECT abdomen was done in this patient, and the findings are bilobar communicating intrahepatic biliary radical dilatation with CBD dilated 16 mm, and ill-defined soft tissue density lesion measuring 2 × 1 centimeter noted in the distal CBD. A main pancreatic duct appears normal. Liver appears mildly enlarged, approximately 18 centimeter. Gallbladder was distended. No calculi focal lesion. Pancreas BC aorta portal vein are a normal position and caliber. Impression, distal CBD mass lesion causing upstream dilated CBD, CHD and bilobar communicating intrahepatic biliary radical dilatation. Possible could be cholangiocarcinoma or pseudotumor. And no significant regional lymphadenopathy was noted.
So this is the radiologist report.
Yes, sir.
So what would you think independently? Here, usually radiologists will give even a pathological diagnosis, even the cells they can tell. But what will you think first? They have written pseudotumor. They might give 3-4 differential diagnoses when you send with one diagnosis. So what is your diagnosis with this CT scan?
Distal cholangiocarcinoma.
Okay. Why?
Sir, the level of obstruction noted here is distal CBD, sir. Before that, everything is dilated till intrahepatic biliary radical.
What is the what do you expect the characteristic in CT scan in a distal cholangiocarcinoma mass? What will be the typical appearance? What kind of CT do you do? It's contrast enhanced means what are the
CT pancreatic protocol. Triple phase CT.
Okay, that's mean you need an arterial phase. to see if it is a
Portal venous
vascular
phase.
tumor, it will enhance.
Yes.
Then you need a portal phase.
Portal phase.
Which will usually wash out if it is a arterial enhancing lesion.
Yes.
And you need a late venous phase.
Late arterial.
Especially to look for liver lesions. And so if it is a hypervascular or if it is a tumor with a high vascularity, it will enhance well in the arterial phase. So what is a typical cholangiocarcinoma in the bile duct? What kind of tumor is it? Is it a very vascular tumor or is it not a vascular tumor? So what do you expect in the CT scan?
Vascularity will be there.
Vascularity will be there.
Hypervascular tumor.
No, cholangiocarcinomas are usually not very vascular. So it will not brighten up in the arterial phase. So it probably you don't have the images.
How do you know this is not a stone at the lower end of the conveyor duct? Impacted stone.
So in impacted stone, CT enhancement, I mean, in arterial phase, the enhancement will not be there.
Just now you were told it not be there for a cholangiocarcinoma also. Is it not? Sometimes there can be confusion whether it's a stone or not. But here the duration of jaundice is 1 month.
1 month.
That's little long. When you have about 8 or 10 days or 15 days, a doubt could be there whether it could be this or that. See, when the pancreas is normal on CT, okay, here, see now, CT is a good investigation to assess the pancreas. Ultrasound may not be. So there are two possibilities. What are the two possibilities in this patient?
So
One is
cholangiocarcinoma.
What is the other possibility?
Periampullary carcinoma.
So here it is more suggestive of cholangiocarcinoma. That's why you have done the next investigation in the form of MRC. Is it not?
Yes, sir.
If it is in this CT, it is not very much indicative of cholangiocarcinoma. What should be the next investigation?
Endoscopic ultrasound.
Not endoscopic ultrasound. You like to do a side wing scope.
Side
Okay.
wing.
Because that will make a diagnosis of first end wing followed by side wing for cholangiocarcinoma or for periampullary carcinoma. That's more common compared to a cholangiocarcinoma. But here the findings are more suggestive. So it might be appropriate to straightway go with the MRCP so that you can have a endoluminal assessment of the distal end of the common bile duct. So what is the finding MRCP?
In MRCP, an ill-defined polypoidal mass lesion, which is heterogeneously hypointense on T1 and hypertense on T2, showing mild diffusion restriction on ADC and DW1, is seen involving distal CBD, distal third of the CBD, causing abrupt narrowing of the CBD with moderate to severe upstream dilatation of proximal CBD and common hepatic duct, intrahepatic biliary radicals, cystic duct, and gallbladder. Pancreatic duct normal and normal in caliber, normal ampullary or periampullary region.
Fine.
Gallbladder.
You can stop here. So what's the impression now here?
So it confirms
What
it's
does it confirm?
distal CBD,
Distal
CBD cholangiocarcinoma.
This is the investigation which will also rule out, a CBD stone.
CBD stones.
This is the investigation of choice to differentiate between the two. So once you have made this diagnosis, so after this, I don't think there is any need to do what you said. What is the need for doing an endoscopic ultrasound here?
In case of periampullary carcinoma, to visualize
Periampullary carcinoma, you should do
small
endoscopic
tumor.
ultrasound. Okay, you will do a side wing scopy and take a biopsy if there's a lesion there.
Yes, sir.
So here now you have literally a final diagnosis with MRCP, isn't it?
Yes, sir.
So what next?
So, pre-operative evaluation, I would
That
like
you
to.
need a biopsy of this to confirm the diagnosis. That's my question. That's a postgraduate question, so answer like a postgraduate before you plan any surgical intervention.
So since there is no local invasion.
Go to the mic and speak.
Since there is no local invasion, biopsy is not indicated here, sir.
No, that's not the answer. Local invasion means what?
Involvement of SMA and portal vein.
SMA and portal vein
SMV.
by a cholangiocarcinoma.
No, sir, not. Sir.
That is usually the
Head of pancreas.
End of pancreas. No? Anything else? What should be the answer to the question I asked? Answer a very straightforward question. Do you need a cytological diagnosis or a histopathological diagnosis in this patient now to go ahead with the surgical intervention?
As the patient has a clear-cut diagnosis like short duration of history, malignant obstructive jaundice, we don't need to wait for the biopsy.
Not need to wait for, not necessary.
Necessary, okay.
Okay. When the clinical and the cross-sectional image findings, okay, they point towards the malignancy. It's not necessary to have a cytological or histopathological confirmation of the malignancy. You can go ahead with the surgical. This is the point. All the postgraduates should remember. When you have a doubt in those circumstances, then certainly you can go ahead and do a biopsy. Okay. The biopsy is done with the help of endoscopic ultrasound. Any other indication for biopsy? Not in this patient. If there is a lower end obstruction and you need to do a biopsy, what you mentioned. If you have a borderline resectable pancreatic cancer, why you should do biopsy there? Because CT will show you it's pancreatic cancer when you do pancreatic protocol CT. It will confirm the diagnosis. What is the need for that?
Operability.
FNSC? Not operability. Go to the mic and answer.
Palliative therapies.
Not palliative therapy. You have borderline resectable means you give neoadjuvant chemotherapy for that. Before you give chemotherapy without biopsy, they'll not give, isn't it? That's why you need. So that's the reason for it.
You need the indication for doing a biopsy to confirm. Another neoadjuvant, because you need a tissue diagnosis, no, before subjecting a patient to chemotherapy or radiotherapy, any form of treatment. So you need a tissue diagnosis you have to do. Any other situation you already said, but you have to think and tell.
So inoperability, we have to look for any SMV portal wing, palliative.
Resectable patient got that.
Yes.
Not resectable, only palliative treatment is only option. Then you need a tissue diagnosis. You can't give a palliative chemotherapy for a benign disease.
Yes, sir.
Then such situation also again need a tissue diagnosis before starting them on radiotherapy or chemotherapy.
This tumor is involving the distal third of bile duct.
Yes, sir, distal.
How can you take a biopsy?
Sir,
Not in the lumen, you will not reach by endoscopy.
Sir, endoscopic ERCP.
How will you take using ERCP?
Side with the side viewing endoscope.
Is there anything you can, with any method, you can go into the bile duct?
Sir, a PT bead, PTC, a percutaneous transhepatic cholangiography.
Just taking a tube, or you can put a stent relieve them. Can you do scopy into the bile duct? Endoscopy into the bile? Have you heard about it? I think you can find it. Yeah, it's a cholangioscopy, endoscopic cholangioscopy. It's called spyglass. So you can directly view the bile duct. You can relieve the obstruction. You can take small spy bites from this. But probably if the discussion goes that further, you can answer. Just you should know that there's a possibility.
The last question, what surgery would you like to contemplate in this patient? Everything is fine.
So we'll do staging laparotomy, and if it is operable, and we'll do Whipple's pancreatic duodenectomy.
Fine.
Thank you, sir.
Thank you, sir.
Thank you so much.
Thank you, sirs. I now request the examiners to award the certificate of presentation to Dr. Soundarya. And Dr. Pavitra.
Yes.
I kindly request Professor Dr. Rajan KV to kindly remain on the dais for the next session. Next, we have a lecture on Hirschsprung's disease by Dr. Krishna Kumarji. We welcome you, sir. The session will be chaired by Professor Dr. Vishnu Prasad, Professor Dr. Rajan KV,
Good evening. So Dr. Krishna Kumar is professor of pediatric surgery. He did his MS from our department. He's also done from JIPMER. He's also a fellow of ACS, ICS, ASI, IAPS, so many associations. A member of SAGES, Association of Many He has got 50 plus publications and 5 chapters in books. So his area of interest is pediatric, oncology, and neurology. So today is giving a talk on Hirschsprung disease, where we find some of the concept difficult to understand. Hope we will make it.
I remember those days, I think both of us worked in. So Krishna Kumar fondly called us KK. Both of us worked in pediatric surgery under Professor Jagdish. Few months, I think, some overlap of few months before I good old days.
Yeah. Thank you for the nostalgia. Thank you for the introduction. So it's a pleasure to be here as part of the JSU update. This will be the overview of the talk. I'll try and to keep it as short as possible. We are at the fag end of the day. I understand that. So Hirschsprung's disease, well, to say how to define will be a very simple way of putting it across. Something like a motility disorder where the problem lies with the ganglion cells. As a result, the varying segments of colon do not work as they are supposed to be. So what is the importance for an adult surgeon to know about Hirschsprung's disease? So the transitional care is one important thing, which means a child who's undergone some kind of a treatment for a Hirschsprung's, some surgical procedure, coming to the adult with a complication or with a this thing. So the adult surgeon needs to know about Hirschsprung's disease. Then sometimes the presentation itself can be in the adult. We know that about 2% of them spill over into the adult population. And even atypical presentations like sigmoid volvulus enterocolitis in the adult are known. Then presentation with constipation, which can mimic Hirschsprung's disease. So what are the typical ways in which it can present in a child? It's usually common in a male child. We'll come to the types later on. If the segment which is involved with the aganglionosis is longer, then this male predominance comes down. Otherwise, most of the times, the typical presentation, almost 80% of them is in the first few months of life. And about 15% of them would spill over to the later age group at about 5 years. The history would be about meconium passage, which is delayed beyond 2 days. Sometimes it can be even prolonged passage of meconium. The other atypical presentation is idiopathic cecal perforation. Sometimes what happens is the classical Hirschsprung's disease in which the rectosigmoid is involved, we have another block at the IC valve. So the cecum bears the brunt of it and you have a cecal perforation. So that is one of the ways in which Hirschsprung's can present. Abdominal distension, which is evident on examination, can be accompanied when you do a perical examination. You have explosive passage of feces and flatus. Something about embryology, the normal migration of neural crest cells is the center stage of the problem in Hirschsprung's disease. So it is expected that these neural crest cells migrate from the developing area down to the colon by about 16 weeks, 12 to 16 weeks. And the neural crest cells, once they reach their final destination, start maturing into ganglion cells, and then they go from the myenteric plexus to the submucosal plexus. Several factors are involved in the regulation of that: neurotropic factors, extracellular matrix proteins, as well as other molecules as well. So anything can go wrong in that, so which can result in the arrest in the migration. And the other important thing is the microenvironment, because when the microenvironment is something which I said before, it can be the proteins, it can be the factors, neurotropic factors, whichever. So if there is some problem with that, the ganglion cells wouldn't mature, as well as would result in a loss as well. It's also proposed that some autoimmune thing can also be involved. Ischemia is also one more hypothesis proposed for this aganglionosis. As I said before, the common type that we come across would be the rectosigmoid area, which is about 80% classical, we call it. So little beyond into the sigmoid spillage, that is about 20%. Sometimes when the entire colon is involved, that is called as TCA, total colonic aganglionosis. So that's only about 5%. Very rarely, this extension can go in even into the small bowel. That's called as TIA, total intestinal aganglionosis. Plain X-ray usually may not reveal the dilated and the collapsed bowel in a proper delineated manner, but sometimes we can be lucky in even the plain X-ray showing a nice dilated bowel and a collapsed bowel. So it is noteworthy that the dilated bowel, which you see on the X-ray, is actually the normal ganglionic bowel, and the collapsed bowel, which is seen, is actually the aganglionic bowel, or otherwise the abnormal part of the colon, which does not have the ganglion cells. So the next thing to go for would be the contrast enema. So in children, we prefer to use water-soluble contrast. So we don't prefer a barium for fear of spillage and causing barium peritonitis. So contrast enema is what is typically used, which delineates the dilated and the transition and the collapsed zones. The gold standard for diagnosis would be taking a biopsy and proving the absence of ganglion cells. So we can do what is called as a suction biopsy, in which a portion of the mucosa and part of submucosa can be taken. Unfortunately, these suction biopsy guns are not widely available, and again, they cannot be used in older children. So this is typically used in an infant or less than 3 months, 4 months, and all that. So beyond that, it's difficult to get a good piece of suction biopsy. So it is not useful in an older child. Anal manometry, I would come to it later. So when we do a contrast, so normally the rectum would be the one which would be more dilated than the sigmoid. In a classical or the short segment Hirschsprungs, there will be a reversal of the rectosigmoid ratio. So that is one of the hallmark findings of the contrast enema. So when we do a histology subjecting the biopsy to analysis, it is not only the loss of ganglion cells, but also presence of hypertrophic nerve bundles. So it should be both of this which should be present to make a diagnosis of Hirschsprung's disease. And again, these biopsies can be obtained as a HND, that is a paraffin section, or it can be taken as a fresh frozen this thing. So the advantage of a fresh frozen would be like when we do a primary procedure, we would like to get a diagnosis because the diagnosis wouldn't have been done before. So this can be done by using a rapid acetylcholinesterase test, which would be available within 30 to 40 minutes. So, but again, the support has to be from the histology department, the pathology department. So the other, which is the HND stain, is what is routinely done. But the problem here is that the report would be available only after 2 to 3 days. The calcitonin stain is another, which can be used when the staining is doubtful and we need further confirmation. Just would like to highlight, as I said before, the migration of the ganglion cells may not happen equally on all the 4 quadrants. So sometimes bringing in a bowel which is supposedly ganglionic may not be ganglionic in all the four quadrants. That's why when we take a biopsy on table or when we assume it's a ganglionic bowel, we ask the pathologist to look at all the four quadrants of the colon. We call that as a downnet. So to ensure that we pull down a normal ganglionic bowel so that it works well after the surgery. This is just to illustrate which is a normal segment, which is an abnormal segment, on what is a transition zone. This transition zone, there's just 1 minute to explain what is it. In a transition zone, the aganglionic bowel gradually turns on to being a normal ganglionic bowel. So in which the ganglion cells will be still a little less compared to the normal bowel. So in case we pull the transition zone and do the definitive surgery, there still can be some problems. That is why to avoid the transition zone pull through, we do on-table frozens, or at least from the expected aganglionic zone, we go at least about 5 to 6 centimeters to avoid the transition zone during the definitive surgery. To say why the segment of bowel is collapsed, the aganglionic zone is collapsed, the explanations are several. Couple of things are, there is more adrenergic nerve fiber activity, and also loss of nitric oxide function, which does not allow the bowel to relax, so it remains tonically contracted. In case we have to take an open biopsy, as I said, we need to do an open biopsy in an older child, because in a younger child, the suction biopsy will be there, but in an older child, we will not be able to do that. So in case we have to go for an open biopsy, there is something called as a physiological aganglionic zone, which is normally present near the dentate line. So we have to avoid that when we take a biopsy. So consciously, when we take a biopsy, it should be at least 1 to 1.5 centimeters above the dentate line to avoid this confusion. Anal manometry, when we distend the rectum, the sphincter should relax. That is a normal thing that we call it as rectoanal inhibitory reflex. So this is sometimes useful. Only problem is availability of manometry to do this. So this can be useful in a segment of Hirschsprung's disease. I will come to that later as well. So this is not routinely done, and it may not be available in all centers as well. So used only for a specific this thing. I'll come to it again later. We have a long list of differentials, so not go into details. Just to remember, the ileal atresia, meconium ileus, and meconium plug almost appear similar, except that when we do a contrast study on an ileal atresia, the distal colon will appear like what is called as a microcolon. In a meconium ileus, you have pellets of meconium, which will be opacified on the contrast. In a meconium plug, generally after the study is finished, you have a nice plug of meconium which gets passed by the rectum. So that's why it's called as meconium plug. So these three are typical close differentials for a Hirschsprung's disease. Just a word about idiopathic constipation. So when a child presents with constipation, the features which favor idiopathic rather than Hirschsprung's are: one, if we have feculomas, soiling being present, and the rectum being dilated. So these are all some of the features. These cannot be taken as 100% positive for idiopathic constipation, but these are some of the features which can differentiate the idiopathic constipation from Hirschsprung's disease. Associations are known with Hirschsprung's disease. Generally, if you take the Hirschsprung's disease, most of it is because of a sporadic reason, but we can have associations, for example, like Down syndrome, neural crystopathies. As we saw before, the neural crest cells appear to be the cornerstone in the formation of the ganglion cells. So anything related to that, we call them as neural crystopathies. So almost about 20% of them can have an association in the form of hypoventilation syndrome, Waardenburg-Shaw syndrome, etc. We have come a long way with regard to the surgical management since its first description in 1880s. So the current procedure, which is initially So when a child presents with sepsis, when the child presents late with significant bowel dilatation, and when we are not able to effectively decompress with the rectal washes, these are all some of the indications for diversion. Also, in a total colonic aganglionosis, sometimes we cannot achieve effective decompression. So these are all some of the indications for diversion. So otherwise, we plan or try and do a single stage or a primary procedure. Classical procedures which are described are Swenson's, Soyave, and Duhamel. In a Swenson, it is similar to the low anterior resection which is performed for general surgical procedures. The ganglionic bowel is pulled down after taking off the aganglionic bowel as low as possible, almost up to the dentate line, and the ganglionic bowel is pulled down and anastomosed. In Soyave's procedure, it is called as an endomucosal pull-through. Here, either from the abdominal route or from the rectal route, we do what is called as a submucosal dissection, leaving behind a small cuff of the muscle around, and then pull down the ganglionic bowel through, and then anastomose through the muscular cuff. So that is called as Soyave's procedure. Duhamel's procedure is when we retain the aganglionic bowel, which means the rectal stump will be retained. The rest of the aganglionic bowel is resected, and the ganglionic bowel is brought as a retrorectal route. Through the retrorectal route from the posterior wall of the aganglionic bowel, it is brought. So in essence, we will have the normal as well as aganglionic bowel having two layers which we can staple and take them off. So in Duhamel, we have a stapler which is essential. So some of the surgeons have gone away from Duhamel because of a requirement of staplers, whereas in Swenson or Soyave, we don't require. And of late, Swenson's has become more popular because of use of minimal access. If we have a the total colonic aganglionosis variety, some of the surgeons prefer to use the right or the left colon as a patch to the ileal segment, which comes down for the anastomosis. It's called a Kimura's procedure. Depending on which right colon or the left colon that is used, it's called as a Martin's or a Kimura's procedure. This is how transanal endorectal pull-through is done. Here, there is no incision on the abdomen, typically performed for a short segment Hirschsprung's disease. So we start the dissection, let's say about 1 to 1.5 centimeters from the dentate line, go into the submucosal plane, reach the transition zone, cut it across, then we get the ganglionic bowel, pull it through and anastomose down to the dentate line area. And then we make sure the frozen sections are compatible with the diagnosis, as well as the normal ganglionic bowel is pulled through. Two special types I would just like to highlight. There is something called as an ultra short segment Hirschsprung's disease. Here, the segment that is involved is even lesser than a classical rectosigmoid. So it can be so small that it can be missed on a contrast study. Even a biopsy can miss that. So the way to diagnose would be to do a anal manometry, so which I mentioned earlier. So absence of the rectoanal inhibitory reflex, which would be very typical, would be the way to diagnose ultra short segment Hirschsprung's disease. So the problem with the total colonic aganglionosis or TCA is the use of a diversion. Sometimes ileostomy is very difficult to manage because of the fluid electrolyte imbalance. And when the definitive procedure is done, we take off the colon and use the ileum for the reconstruction down. Even with a colonic pouch, sometimes it is still difficult to manage in the postoperative period. Child will have a lot of stools and excoriation, perineal excoriation. It takes a long time to adapt, so it's a little difficult to manage in the postoperative period. So these are the various postoperative complications. Some are specific for the procedures which I mentioned before, like for example, a leak which can occur in a Duhamel's. In a Swenson's, we expect a stricture because we have an anastomosis done at the lower rectal level. Then cuff abscess or a cuff stenosis or the bowel retraction, this can happen in a Soares procedure. Prognosis, I will just skip this slide. We just know that the incontinence is something which can happen, but sometimes it is transient because during the procedure we can retract and the sphincters can get damage or whatever within quotes, and the normal tone takes some time to recover. So there may be a transient period of incontinence which gets improved over a period of time. So okay, so that's almost the Hirschsprung's disease. So to summarize, we just need to keep in mind a child who presents with constipation, abdominal distension, and alteration in the meconium history as the presenting features of Hirschsprung's disease. The way to diagnose would be to perform a contrast enema. Of course, the gold standard would be the biopsy. And we always aim to do a primary surgery so that we avoid a diversion. But as I said before, there are certain specific indications where diversion is we cannot avoid. And enterocolitis is one thing which can happen even in a planned procedure where the ganglionic bowel is down. Sometimes it can be troublesome. So it's one of the Achilles heel in a management of Hirschsprung's disease. So overall, the prognosis is all right. And as I mentioned before, the transitional care is something the adult surgeon needs to know. So to conclude, we try to aim for normalcy of the colonic function in the management of Hirschsprung's disease. Thank you.
Thank you, Dr. Top. Very nice, good slide with the pictorial representation. I think very useful for the postgrad residents for the exam. It's a very common question with theory papers and specialty papers. I'm sure this talk is going to help you a lot. Probably once you doesn't remember, I don't think you have to go back and read again. Thank you again, Dr. Krishnan.
Thank you.
Two questions.
Yeah, please.
What is your choice of surgery when you see such babies with such? That's one. Next, when we do in adult patients, in NL, they tend to have the diarrhea post-op complications. There is one group which says that you can create a pouch, but it doesn't serve much. When the children, how does it post-op?
I'll take the first question as in the same order. So I prefer to do, my personal choice of surgery is Duhamel's because I've been doing Duhamel's for a long time. And Soares, I've done a few. Only problem with the Soares is the dissection has to be meticulous. And the other important problem is the cuff stenosis. So if the muscular cuff is a little longer, it can have an effect on the postoperative this thing. So I have seen several cuff stenosis. Of course, that is my opinion. There are several people who can do much better than me in terms of doing a Soares procedure, but my personal choice would be a Duhamel's procedure. And to answer the second question, coloanal anastomosis, that's what you're... Actually, the absence of, if we take a classical Hirschsprung's wherein we take off the rectosigmoid and bring the colon, it is not much of a problem. Of course, in the immediate postoperative period, the number of stools are a little more than usual, but that settles over a period of few months itself. Initial 2 visits when the child comes, the second, third visit itself, we know that the stools become, frequency becomes much lesser and they tend to improve. Even when the ileum is used in a TCA, we had 3 cases where we had used only the ileum without a colonic patch in a TCA. So even those children, we saw that over a period of about 1 to 1.5 years, slowly the ileum got adapted. Initially, there was quite a frequent number of stools which the child experienced. But then we saw the stools becoming more solid, becoming quite manageable. And now the child is about 2.5, 3 years old. The child who is coming for regular follow-up after a TCA is doing well. Yes, ma'am. Thank you, madam.
Thank you, Achilles here.
Thank you for the question, madam. There is a way of going about it, which means we can do what is called as extended biopsy. That is one of the ways in which it is said. but some of the people go about doing definitive procedure itself because they are not sure how much to remove. And when the bowel becomes a little dilated, more than dilated. But of course, as you said, there are people who just do a little bit of this thing, like an extended biopsy, and then do away with. I mean, it does well. Thank you, madam.
Thank you, sir.
So thank you very much, Krishna Kumar. That was an excellent lecture.
Thank you, sir. I take this, sir.
Thank you, sir, for the amazing session. I request the chairpersons to felicitate Dr. Krishna Kumar ji.
I take this. Thanks.
Next presentation is on lower GI case by Dr. Gopi Krishna and Dr. Jnaneshwar.
So
Finally,
since we have less time, we want to wrap up by 6:30. What happens during your final examination when there is short of time, we make it quick by taking some just few 10 minutes like that. So since we have 3 presentation, those who want to present, we will ask say a few questions, like 3 or 4 questions, and then finish it up. Because it's taking too much of time. So each one will take 40 minutes instead of that. So it happens in the examination. We have practically faced this problem. And we cut short by asking short number of questions. I think people will also be really are also trying to go home. So we'll try to wrap up before 6:30. So we'll take only 10 minutes for each case presentation. There are 3 lined up, I think. 3 case presentation pending. So each one 10 minutes. We finish it up. Yeah. No, there. Okay. Okay, 2, 10 or 12 minutes. Where is Shaktivel? First one is where is Shanmugam?
I invite the examiners for the session, Dr. Suresh Kumar S., Dr. Venkatesh P., and Dr. Shanmugam D. onto the dais.
Only 10 minutes. They present and few questions and finish it up. So we want to finish by 6 before 6:30.
One of you can start presenting. You know the cases, right? Brief your history.
belonging to lower socioeconomic status, according to the modified classification, presented with chief complaints of bleeding PR for 3 months and pain in the perineal region for 2 months. A patient complained of bleeding PR 3 months back, which was insidious in onset, 3 to 5 drops of and 4 to 5 times per day, just prior to the passage of stools, which was not mixed with stools, and it was stopped 1 month after taking, which by going by the patient was seen to be Ayurvedic medicine. Patient also complained of pain in the perianal region for the past 2 months, which was insidious in onset, intermittent pricking type of pain, localized to the perianal region and non-radiating, and it was relieved by defecation. Patients also had complaints of discharge per rectum for the past 2 months, which was watery, blood tinged at times, multiple episodes per day, approximately 10 to 12 times with 2 to 3 drops per episode. And it was foul smelling. Patient also complained of constant urge to defecate and feeling of incomplete evacuation for the past 2 months. And also he complained of passage of narrowed caliber stools. Patients also had complaints of reduced food intake, but no loss of appetite. But however, he had significant loss of weight with approximately 10 kilograms in the past 6 months. Patient had no complaints of loose stools, constipation, obstipation, mass protruding through from anus, fecal incontinence. He had no complaints of increased frequency or burning micturition. He had no complaints of abdominal pain or distension. He had no complaints of fever, jaundice, cough, breathlessness, or hemoptysis. He had no redness of eye, increased or decreased lacrimation, oral ulcers, skin nodules, joint pain, myalgia, or easy fatigability. Going to the past history, patient had no history of any similar complaints in the past. He is not a known case of any medical or surgical comorbidities. He had a past history of left inguinal hernia surgery done at Pondicherry 17 years back, for which records were not available. And patient also had undergone umbilical hernia repair at a private hospital in 2021. Treatment history, the patient went to a private hospital in Viluppuram with the above mentioned complaints, where he was admitted and evaluated. Multiple scans were done and colonoscopy was also done. Later, he was told that he could have cancer. Then the patient self-referred to JIPMER for further management. Going to the personal history, patient had no alteration in bladder habits. He is habituated to smoking for the past 20 years, approximately 4 pack years, last smoked 6 months back. Patient is also habituated to alcohol consumption for the past 20 years, once or twice a month, and last binge of alcohol was 6 months back. Patient consumes a diet mixed with meat once a week. Patient is married for 25 years and has 2 children, no history suggestive of promiscuity. Patient is not on any chronic medications or has no known drug or food allergies. There is no family history of any cancer or cancer-related deaths in the family. To summarize, a 53-year-old farmer with no known comorbidities, occasional smoker and alcoholic, presented with complaints of insidious onless, painless bleeding PR for the past 3 months, which later progressed to painful bleeding PR for the past 2 months, associated with foul-smelling, blood-tinged mucoid discharge per rectum, and tenesmus with significant weight loss. There is no history suggestive of any metastasis. Patient has no significant family history. Based on this, I like to keep my provisional diagnosis as a rectal pathology, possibly of malignant etiology, sir.
Hemorrhoids, you said like before passing stools, there is a drops of blood.
Going by the history, patient had no.
It's not mixed with stool, right? It is
blood is not mixed with stool, sir.
Before passing the
before
stools.
passage of stool, sir.
So why can't it be a hemorrhoids?
Long duration, one is long duration, and he had no similar complaints in the past. And also patient
Similar complaints not necessary.
Had no prior history of any constipation. So history suggestive of constipation prior to that. And also there is significant weight loss associated with it. And also stool caliber is normal. History-wise, there are we had multiple differential.
To make a diagnosis or some differentials. What do you mean by here the diagnosis, provisional diagnosis? Is there anything you are describing a condition where the history what you have taken is fitting in? What do you mean by rectal pathology? So many are there. What do you mean by malignant etiology? But make some diagnosis. Or if you put some differentials, why you put the differentials in the order of your priority. So why you suspect malignancy in the presentation based on the symptomatology?
One is short history of both his chief complaints, bleeding PR and mucoid discharge, which was initially painless, later progressed to painful, which was associated with tenesmus, mucoid discharge per rectum, and there is also history.
Don't repeat the same. So why you suspect malignancy with this history? Does no other condition fits into that symptomatology?
We are suspecting inflammatory bowel disease also, sir. That's why I had asked.
So why you have not kept any differential as inflammatory bowel disease?
Patient, this is the first complaint, first presentation of the patient. He had no prior similar complaints, or also no systemic features suggestive of inflammatory bowel disease was there. So even though we have a differential, I like to confirm it by examination.
Any strong evidence to say it is malignancy, and you are ruling out other possible differentials from the history what you have taken. So if you are sure with that diagnosis, then you can make it as a rectal malignancy or whatever you are trying to say with this. So if you are can't, just because there was no past history of similar episodes, does it rule out inflammatory bowel disease? Or it is the only differential you have got to with this presentation?
One is his age is against inflammatory bowel disease. First presentation at around 53 years.
The age factor. Does malignancy alone fits into this diagnosis, or no other condition comes into this?
We were thinking about anal canal malignancy, carcinoma anal canal, sir. That is one of a differential diagnosis, and solitary rectal ulcer syndrome.
The condition where you are not having any classical features to say only malignancy, and you are not having any features to rule out other differentials. So you always have to put it in a differentials where, based on the priority what you are suspecting it is to be more malignant, you give the priority for that. Second option could be an inflammatory bowel disease, and third can be some other conditions which still you have to find. There are differentials, not the only malignancy as the differential. And when you put that rectal malignancy as a different diagnosis, what is the cause for pain? Is pain is a factor of presentation in rectal malignancy?
No, sir, it is not the presenting complaints of the
so
rectal
how do
malignancy.
you explain for that?
One thing could be due to the sphincter involvement, sir. Initially, patient had painless bleeding PR, later converted to painful, sir. Probably the drone might have progressed to involve the sphincters during the later course of the
So do you think this 3 months is sufficient enough for the tumor, whatever it is there, to present with the pain and involvement of the sphincter? And what is the tenesmus that you are trying? For malignancy, none of this symptomatology what you have presented is suggestive of malignancy. So you have to be very clear when you make a single diagnosis of malignancy as a cause.
What is spurious diarrhea?
Spurious diarrhea is seen in long-standing obstructions. A patient will have intestinal obstruction due to there'll be profuse secretion of mucoid content, and which is fecal enteritis, which typically patient describes as passage of loose stools in early mornings post waking up.
Go ahead with the examination.
Proceeding with examination. On general examination, patient was conscious. Patient was examined in the well-lit room. Patient was conscious, oriented, and comfortable at rest, and he was afebrile and was well hydrated. Height 170 centimeter, weight was 45 kg, and BMI was 15.6, and ECOG status 2. There was no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, and pale edema. There was no palpable supraclavicular lymphadenopathy. And vitally, patient was stable. Pulse rate was 88 per minute. It was regular rhythm and normal volume. BP 116 divided by 68 millimeter mercury, and respiratory rate 14 per minute, and SpO2 99% in the room air. Proceeding with the abdominal examination, after explaining the procedure to the patient and getting the consent from the patient was examined. On inspection, abdomen appears to be flat, and umbilicus was in central position and inverted, with a scar noted in the inferior aspect of the umbilicus. And all quadrants of the abdomen equally moves with the respiration. there was
Please go to the positive findings, sir. If anything significant, you say. If not,
on a abdominal examination inspection wise, there was no significant finding. And palpation wise, there was no palpable lump or mass. And percussion wise, there was no shifting dullness, and the liver span appears to be normal. On auscultation wise, there was no significant abnormality. There was no palpable lymph node in the inguinal area and supraclavicular area. After explaining the procedure, patient was examined in the left lateral position. On parting the buttocks, perianal area was examined. There was no scar, sinus, fissure, fistula, and skin tag was noted. Anal tone was appears to be normal, and on digital rectal examination, after applying the adequate lubrication, the finger was gloved finger was inserted. The eccentric growth felt 3 cm from the anal verge. It was located posteriorly between the 2 o'clock to 9 o'clock position. It was occupying more than half of the circumference of the bulbar. It was firm in consistency, tender on touch, and irregular surface. And it had a restricted mobility in the posterior aspect. And finger, we can able to negotiate this finger with the difficulties. And the upper margin of that irregular growth, we couldn't able to reach. And grade 1 prostatomegaly was noted, and gloved finger soiled with the blood and mucus. And after explaining the procedure, proctoscopy examination was performed in the left lateral positions. And a proctoscopy examination wise, there was ulceroproliferative with a friable, irregular surface, everted edge. The growth was noted 3 cm from the anal wedge. It was located posteriorly between the 3 o'clock to 9 o'clock position. It was occupying more than half of the circumference. Blood tinged mucus discharge was noted, and scope we able to pass with some difficulties. The upper margin we couldn't able to visualize. There was no hemorrhoids, polyp, or any other ulcer noted on proctoscopy examination. And systemic examinations, no significant abnormality, and no spinal tenderness also. On summary, after the history and the systemic examination, abdominal examination revealed no
diagnosis.
I like to give the provisional diagnosis of there was ulceroproliferative growth in the lower rectum extending into the anal canal, likely carcinoma of rectum with no feature suggestive of metastasis. My differential diagnosis, carcinoma anal canal.
In digital examination also and proctoscopy also, you mentioned the growth from 3 to 9 cm. What is the significance of knowing that?
We can on the clinical examination wise, we able to predict that any surrounding organ.
Significance, why we want to know, you said no, from what clock position to what clock position. What if it is 9 o'clock to 3 o'clock in anterior or posterior or 11 to 1?
If it's anterior growth.
Knowing it, and you said half of the circumference, more than half of the circumference. What is the significance of that?
Yes, sir. In the clock position, we can able to predict what are the structure, adjacent structure involvement or infiltration. If it's anteriorly located, the prostate involvement are high. We can able to predict that. And regarding the circumference, if the patient is able to pass the stools, or whether the patient is going for obstruction or subacute intestinal obstruction, whether he's in like that. Impending obstruction, we can able to rule out, sir.
Did you mention the supraclavicular no?
Yes, sir, we mentioned, sir.
Diagnosis.
Why did you include anal canal carcinoma as a differential diagnosis here?
Actually, during digital rectal examination also, and the proctoscopy examination also, the growth was starting from the 3 centimeters. And we thought our primary diagnosis here rectum, lower rectum, it was encroaching the anal canal. Other differential diagnosis, since the patient having perianal pain and all presenting, we would like to give the differential diagnosis, anal canal growth extending into lower rectum, sir.
The length of the anal canal?
So 3.8 centimeters. Sir.
You expect the growth starting from 3 centimeters above the anal verge and go to the level where you cannot palpate? Unlikely. So
unlikely.
You can stick on to one diagnosis, that's fine. It is not mandated that you should give one more diagnosis. Okay, that is one. And were you really able to see that grade 1 BPH in such a huge, though even the tumor is posterior, almost more than half of the circumference the growth is there. Were you really able to, did you palpate that BPH?
The prostatic gland we could able to palpate. But not significant.
Unlikely.
Okay, sir. Proceed, Pandra.
Again, the same. that it's a carcinoma rectum or the anal canal, or it's a rectum involving the anal canal, or the anal canal it's extending into the rectum. So that you have to differentiate in your presentation from the presentation and also the rectal examination that you did. So what is it trying to, what do you appreciate? So the growth is not reachable, the upper limit. So the predominant growth is in the rectum. And it is coming up to the 3 centimeters. 3 centimeters obviously into the anal canal. But how do you say it is anal canal or in the lower rectum? That how you appreciate that on PR examination. So PR you will be looking for the anal sphincter, so the anorectal ring. So that is the point which you should be able to appreciate if the tumor is not involving circumferentially.
Okay,
if it's involving part of the circumference, then definitely you should be able to appreciate the location of the sphincter, and in relation to that sphincter, then you can assess the growth where it is exactly located, whether proximal or distal. That is an important landmark for rectal assessment. It will help you in deciding the management as such, the plan, what you want to do surgically, whether you want to go ahead with intersphincter resection or a patient end up with APL. So that observation is important when you do PR, and that will help you in making a clear diagnosis.
I feel this growth would have bled like anything. It would have bleeded more like what, unless what you told us, it was just tinged, the gloved finger was tinged. No, the bleeding on touch would have been very evident, very obvious in this growth. I feel so. See?
We just want to confirm the diagnosis, sir. Since the growth is visible in the proctoscopy, we would like to take proctoscopic biopsy, sir. Shall we? And then according to that, our further management will differ.
Okay.
Biopsy suggestive of well-differentiated adenocarcinoma. It's mostly suggestive of like rectal malignancy encroaching in the anal canal.
Okay, so what do you do further? You have a biopsy now?
Yes, sir. We would like to do colonoscopy, sir.
Okay, so why?
Actually, colorectal malignancy can synchronous lesion. They can present with synchronous lesion. Rectal malignancy can present.
See how far it is extending in the first place. The upper level is not accessible.
Yes, sir. Yes, sir.
That's okay. Synchronous lesion also you'll see, but first you want to know how far it is extending.
Tumor extent and then synchronous lesion we want to rule out. We want to for that we need to do colonoscopy examination.
Okay, finding.
On colonoscopy wise, ulceroproliferative growth noted 2 centimeters from the anal wedge, and then scope past cecum, rest of the colon appears normal, sir.
So, what percentage will present with synchronous lesions?
30% of the patients will have synchronous lesions, sir, whereas just 3% of which will be malignant.
Okay, good. Next, what you want to do?
Since patient presenting with the bleeding PR, we just
characterize the lesion when you do a colonoscopy, where you should be able to appreciate precisely what is the starting point, what is the circumference involvement, what is the proximal extent, any adjacent changes in the mucosal, any polyps adjacent or any other polyps. All those things have to be given. So you should be explaining whether this report is adequate or not.
You could have put a picture also if it was possible.
Okay, sir.
Next, what you want to do?
Since patient was presenting with bleeding PR, we just want to know that hemoglobin level, like since patient clinically not having any pallor, we just want to confirm this. And then we want to take, since it's malignant case, we just want to take tumor marker, CA level, sir.
No, before that, what you have to do is, so once you confirm it's a malignancy, next step is to do what? You have to stage
the disease. For that, for taking CCT before, we need urea create value, sir. With this normal value, we can proceed with the CCT to rule out distant mets and then
thorax, abdomen, pelvis.
So do you do this serum marker? What you said, CEA you will be doing?
Yes, sir. CEA you want to do.
Is there any difference in doing it before and after of this planned imaging to stage the disease? What staging investigation will do?
CT to look for metastasis.
Okay, does CEA have any effect on deciding CT or any other imaging? Okay.
No, sir.
So high CEA
values are associated with
malignancy, locally advanced disease or chance of being metastatic. So you should also anticipate that, and you can that put together with the CT imaging. Initially, the CT imaging is the first thing,
And if required, you may need to go ahead with PET-CT. PET-CT is not a routine investigation, but indication for PET is these things: bulky disease, high CEA.
Sir, how you stage the malignancy, colorectal malignancy?
No, sorry. After loco-regional spread, loco-regional extent, we have to see, sir. For that, MRI pelvis is needed. For ruling out the distant meds, we have to take.
That's what the carrying out message is. Yeah, I would rather do a MRI in this case rather than SCT, because the circumference, the layer which is involving by the tumor, that is what is more important in staging. Okay.
Also, MRI wise, I'd like to look for sphincter involvement, pelvic floor muscle involvement, the mesorectal fascia status announced.
Do you have the CT report?
Images.
Video we have, sir.
Video we have, sir.
Image videos of CT.
Okay, quickly play.
It's a CT thorax image, sir, to look for any lung meds.
Patient has a green eye.
Okay, there was no suspicious nodules or like.
Normally, go to the
go ahead.
primary lesion.
Either some finding you're going to show.
Go to the primary.
If it is
lesion.
normal,
Leave
just
this.
skip it
Leave
and
this.
show any findings.
He had a suspicious nodule on the left lung,
sir,
which they had reported it to be healed granuloma. We had to get a PET-CT, sir, which was not.
What the CEA level?
Yeah.
CA level.
There is a nodule there.
What is CEA level?
72, sir.
CA rectum.
Basically, CT thorax is to look for metastasis, sir, lung metastasis, which is common in lung and liver metastasis in CA rectum. These are the two most common sites for metastasis. MRI is predominantly for soft tissue deniliations and also decide on neoadjuvant.
MRI is for local staging.
Local staging and decide on neoadjuvant therapies.
Findings
You
on
have the
CT.
primary imaging, primary lesion imaging.
There's a CCT abdomen, sir, to look for any liver lesion or any free fluid level, and to look for any nodal enlargement, and the location of the tumor in the pelvis, the rectum extent. Liver seems to be normal only, sir, after the CT wise, and then no free fluid also.
If you find a free fluid. Would you do ultrasound before this, or you'll straight away proceed with the CT?
For CA rectum, I'd like to go ahead with CT directly, sir.
Okay, fine. So ultrasound as such not necessarily be done beforehand. If it is logistics are restricted and you can't get a CT in a resource limited setting, maybe you can consider doing ultrasound, etc. But it is obviously CT.
As for the CT wise, the growth likely to be starting from the mid-rectal area, sir, encroaching up to anal canal. For the local extent, I just want to see the MRI pelvis.
So after seeing the CT, I have a question, but you are not specified about that in the examination as a part of a routine examination. So looking at this patient's CT, there are significant nodes in the groin region. Did you look for any groin nodes clinically?
Inguinal nodes.
Does it have any role in this patient?
There were clinically no palpable nodes, sir. Actually, CT wise, we can able to see any loss of fatty elements, and then any suspicious node is there or not, we can able to see, sir.
I remember you mentioned no.
No, clinically no significant, no palpable nodes, sir. Here nodes are there. Inguinal area nodes are present, sir. But
based on the biopsy came as adenocarcinoma, it was rectal anal canal carcinoma. Predominantly, they'll go for inguinal lymph nodes, sir. Since it has come as a rectal malignancy, I like to get an FNA, USG guided FNAC first. USG to characterize
the FNAC shows adenocarcinoma. What will do?
anyway, that lower rectal cancer, like proceeding to anal canal, we can treat like lower rectal carcinoma itself.
since there's an involvement of anal canal also. So far.
No, what you have to think is whether it's a regional or non-regional, it's metastatic or not. So based on that, your management will be decided. So you treat that as regional or non-metastatic.
For rectum, it is non-regional lymph nodes.
So here is this tumor is confined to the rectum or what?
It is extending into the anal
I've seen
canal.
the images, and even after that, you keep telling rectum is not correct. So it is involving the anal canal,
Anal canal.
obviously, and colonoscopy showed 2 centimeters from the anal verge. So it's involving the anal canal. So the chance of spreading to the inguinal nodes is high. Still, it will be treated as a regional node. And then, did you see any nodes in the paraaortic region in this patient? Did you look for any nodes? See, when you see a nodule in the lung, you should also see for any distant disease in the abdomen. So is there any regional nodes or non-regional nodes and any signs of any peritoneal disease other than this ascites what you described? So you have to look for all those things when you, so that is how you completely stage the disease on CT. And the MRI is done for local staging of the disease to assess the tumor local T staging and N staging.
Yeah, it's usually CT followed by MR.
Mhm.
Okay. And tumor markers obviously would have done before.
So what is your final diagnosis? Staging.
Sir, for local extent, we'll just want to see the MRI pelvis.
What is your diagnosis now?
No,
Staging.
you tell me the finding. You would have had MR findings, right? You must be having MR finding.
Yes, sir.
Okay, so tell me the finding and then quickly tell the plan.
Actually, MRI pelvis like is looking like T3D, sir. T3D is there, and then multiple mesorectal nodes also was present, and N2, and sphincter involvement also is there, sir. Yeah, internal sphincter involvement is there. Intersphincter space was like free.
Okay, so what stage of this disease?
T3D N2 like locally advanced stage, sir.
So what are you going to do? It's
We-
locally advanced disease.
Yes,
So
sir.
what is the treatment plan? How you?
Sir, neoadjuvant we would like to give, sir. Neoadjuvant, total neoadjuvant will be better for the patient.
Okay, how you assess the response? You're going for neoadjuvant therapy. So how you assess the response?
4 weeks later, we have to get a response assessment MRI, sir. Based on that, we'll have to decide. Since already pre-operative, neoadjuvant only, it was just 2 centimeter colonoscopy wise. So mostly we can't plan for a sphincter preserving procedure, sir. So most likely we'll have to go ahead with the abdominal perineal resection for this patient.
So how much centimeters you can try for the ultra low anterior section?
Ideally, anything less than 4 centimeter, the traditional is to go for an APR, sir. But current concept is negative margins on negative incut margins, sir. So if it's just 2 centimeter margin also, if possible, we can go ahead with ultra low ARs.
2 centimeter, even 1 centimeter
110
is enough. Okay. So the current concept is even 0.5 centimeter to 1 centimeter is more than enough if you can get the clearance. But you have to realize one thing. This centimeter is not equivalent to the surgical resection centimeter. During surgery, you get mobilization another 2 centimeter. Okay. So extra 2 centimeter you will still get. Okay. So anything more than 2 to 3 centimeters, clinically, you will get it as 5 centimeter while doing the surgery. So still you can go for a ultra low resection with a stapler.
Thank you.
Thank you, sir.
Thank you, sirs. May I invite the examiners of the session to kindly award the certificate of presentation to Dr. Gopi Krishna. And Dr. Naneshwar. I now request Professor Angeline Raju to kindly come on to the dais to felicitate our examiner, Dr. Venkatesh SP. Thank you, ma'am. Thank you, sir. We move on to the last session of the program. It's a case presentation. Dr. Pranay and Dr. Soumya. I request the examiners for the session to kindly come on to the dais. Professor Dr. Vishnu Prasad Sinha, Dr. Shanmugam B, and Dr. Shakti.
Mic is on. Speak to it.
Complete the details, and then we last three questions.
Okay, sir. A very warm evening to one and all present here. Today, I, Dr. Soumya Ramgopal, and my colleague, Dr. Pranay, will be presenting a case on portal hypertension. So my patient is a 56-year-old female. She's a laborer by occupation and a resident of Mundia Pakkam. She's postmenopausal with 2 live issues and 4 history of abortion. She belongs to upper-lower economic strata, and she has studied only up till fifth class. Mrs. Valyamal, a 56-year-old lady with no known comorbidities, presented to JIPMER with history of blood and complaints with complaints of blood and vomitus for 1 day. When she had noticed small quantities of blood and vomitus, she describes the vomitus as fresh blood, scanty in amount, 50 ml, which was mixed with water and did not contain any food particles and did not contain